Hello, sir. You are muted. We'll unmute you. We'll just do it. Hello, sir.
Okay, I'm okay now. Sudhir, good morning.
Dr. Sudhir has joined.
देर की देख रही है उसने स्टिल फोटोग्राफ लगाई हुई है
हाँ, वो joining around.
जल्दी
तो उनको म्यूट क्या होगा अभी हमने ऐसे रखा है सिस्टम की बाकी सब म्यूटेड एक्सेप्ट द चेयरपर्सन एंड द स्पीकर बिकॉज नहीं तो जैसे आप देखते हैं ना बाकी मीटिंग में लोग बीच बीच में बोल रहे होते हैं so that is why our telemedicine department has set it up like that. So yes. So we will just make Dr. Gupta also unmuted and we can have a chat.
Professor Sudhir Gupta, good morning. You are on mute.
He has to unmute himself.
And he is on his Sunday dress.
Dr. Gupta, just unmute yourself.
Sudhir, अरे तुम म्यूट पे हो यार.
अरे म्यूट पे आपके सामने कौन बोल सकता है?
ये बात मान ही गया फिर. देख तेरे लिए तू तो आया हुआ अंदर ड्रेस में और मैं बड़ा फॉर्मल ड्रेस में सेशन चेयरमैन हूँ.
मैं देखो आप टाई वाई लगाए हुए हो.
तुमने सेशन चेयरमैन बनाया तो कुछ तो करना पड़ेगा.
हाँ.
And I was very happy to see that this speaker is from Seattle.
Oh yes.
That's the place where I spent 2 years in the 80s, mid 80s, and I have very fond memories of that town. Beautiful town.
Yes, absolutely. And Troy is an incredible speaker. You know, he's just a terrific guy.
I see that his training at Vanderbilt and all everything. So
You know, he just moved about a year back to Paul Allen Institute as director of immunology. He was at WashU. Yeah.
I'm trying to encourage the Indian Immunology Society to, like I do for my Indian Society of Histocompatibility and Immunogenetics, we're doing every month a seminar. We're doing every month a webinar. In fact, the 7th or 8th is going to be done in about 6 days' time. And I think they should also organize this because now that at least the COVID has taught us that you don't need to call somebody from the US over here to give a talk.
You see, it is just ऐसा है ना, तू तो रिटायर हो गया है, तेरे पास बहुत टाइम है.
अबे छोड़ मेरे को रिटायरमेंट के
हम लोगों के पास ये सब करने वरने का टाइम नहीं है, समझे?
बात तो ज्यादा काम आ जाते. तू अपना काम छोड़ के देख.
हाँ.
रिटायरमेंट के बाद आप बिकम इवन मोर बिजी.
हाँ, वो बिजी है लेकिन वो अपने विल पे जो भी चाहो करो. हम लोगों को कुछ ड्यूटी करनी पड़ती है ना.
कोई वो ड्यूटी कुछ नहीं है हमारी.
हाँ, तुम्हारे लिए नहीं है ना. हिंदुस्तान में तो अगर तुम एम्प्लॉयड भी हो या रिटायर हो कोई फर्क नहीं पड़ता है.
आई एम एंजॉयिंग दिस सेल्फ एक्वायर्ड इंडिपेंडेंस.
हाँ, तुम्हारी तो जब काम करते हैं तभी भी इंडिपेंडेंस थी.
हाँ, ये कह सकते हो. चलो.
Waiting for Troy to join. Let's see.
Is Troy joined?
Not yet.
Not yet.
We still have 7 more minutes to go. So
Yeah.
I see this is a very dedicated group of about 21 participants.
Oh, we had 135 participants yesterday, so they joined slowly.
Yep. One more has joined. 22 हो गए.
We'll keep joining. We had actually 150 registrations.
और अगर कोई दिक्कत हो ना, if any problem, I can call on his cell phone in case Troy get delayed. Amita, I have his cell phone.
Yeah, if you can send him a message, that will be fine. We have 5 more minutes.
Let me send him.
Generally, they are very particular. They will join. I know.
Yeah, I think people are joining.
Yeah, they will. We'll have. We had excellent audience yesterday. Lots.
हाँ आज तो व्हाट्सएप में कई मैसेजेस आए हुए थे आपकी बड़ी तारीफ की everybody enjoyed.
So we had great speakers yesterday, and the students did a great job. Really, the student session was the best.
अब तक चलता रहा कल आपका 10 बजे तक 11 बजे तक
We had kept only 3 hour session, and we finished in 3.5 hours. So because long duration people don't like, so we had 4 lectures and 1 hour session of the students. So they presented excellent cases, excellent.
वेरी बहुत तारीफ आ रही थी
आज भी है students का. We have 7 presentations today also,
हाँ
and we have a poster round also.
Amita,
हाँ जी.
could you tell the driver to come at 10:15 instead of 10:30 so that I'll be there by 11 o'clock talk?
Okay, I'll just.
कि वो आधे घंटे से ज्यादा लगता है पहुंचने में.
I'll give him a call.
ये तुम्हारी टॉक कितने बजे है तुम्हारी तो आज नहीं है
हम टॉक नहीं कर, तुम्हारे सामने बताया ना, कोई नहीं बोल सकता है.
वो क्या ही नहीं
I'm just doing a little thing for the postgraduate, you know.
Yes.
afternoon I okay
More practical talk.
Yeah.
Last night I gave a heavy duty talk on vitamin D and signaling and everything, you know. There was the United Kingdom group.
We should be there by 11:15.
I have sent him a text, so let's see.
Anyway, we can be 5 minutes. We can wait.
4 minutes left
Yeah, there's still time.
speaker joined has Troy joined
And we are just. Dr. Gupta has sent him a message
I haven't seen him yet
because he had sent a mail. He's. Oh, yeah. Silent.
It's not too early. It's 7. It's not too late. It's 7:30 in the evening there. So.
Time.
नाम क्या नहीं वो तो सिएटल में है ना
हाँ. Who?
वहाँ हाँ 7:30 होंगे नहीं यार 9:30 होंगे भाई
तुम जो है सब गलत वो लगाते हो. 13.5 घंटे आगे हो.
12.5 घंटे का होगा ना तुम्हारा
13.5.
13.5 घंटे का
हाँ, वो स्प्रिंग के बाद होएगा 12.5.
हाँ इस बार तो स्प्रिंग आई नहीं इंडिया में तो सडनली समर
इंडिया में तो हमेशा स्प्रिंग रहती है या हमेशा समर रहती है.
नहीं स्प्रिंग आती है थोड़े दिन के लिए 3-4 वीक तो हो भी गया
हाँ, वो कोरोना की वजह से सब स्प्रिंग जो है समर में हो गई.
कूल ही नहीं आया यार
A lot of people are writing now to join. DM rheumatology from where?
सुधीर
हाँ.
हमारा फिर 16 को कर दिया हमने 9 बजे
Okay, then I'll
he will
do
write
that.
he will write to you
Okay, मेरे को जूम करा देना बस.
हाँ जूम करा देंगे ना तो तुम उस दिन कहाँ हो दिल्ली में हो
दिल्ली में हूँ.
दिल्ली में है ना ठीक है
So many people want to join now.
joined I want to see his face. He's not switching on his camera.
I'm just calling him to see.
Dr. Troy, he is still to join.
Hey, Troy, you are supposed to speak in 2 minutes.
I'm driving. I don't see. Okay. Wait. I thought it was an hour from now. Okay, so I am going to.
How long it will take you?
10 minutes probably.
Okay, let me see if we can if we can get something else done in the meantime.
Mukesh,
Okay, so let
I thought it was 8:30. So
no.
I will be there as quick as I can.
Don't worry. Make sure you're driving safe. Okay. We. Yeah. Thanks, Troy.
Okay, sorry. I will be there very soon. Bye.
Okay. All right. Okay. He just miscalculated. So what? It will take him 15-20 minutes. So
Dr.
if you want to
Mukesh,
do the case presentation or something,
yeah. I think that's.
or no, we ask Dr. Mukesh is there. We can ask Dr. Mukesh to
yeah,
present. That
just
will be
ask
better.
Mukesh if he's there.
I see him. He's
That will be better.
there. He comes.
Yes, Dr.
Yeah, he
Mukesh,
is
will it be
there.
okay for you?
Yeah, it's okay for
Is
me.
it okay for you to present in place of Dr. Troy because he is just driving?
Yes. Shall I?
So, I don't know. Is Dr. Shaili there to
Shall I
introduce?
share my
Otherwise,
screen now?
yes, you can share your. Okay, you can share your screen. I'll just introduce you to the audience because I don't think Dr. Shaili is here at present.
No, I'm very much here. I'm very much here,
Okay.
doctor.
Okay, I could see you. So, Dr. Shaili, please introduce. So, I'll just get the thing
I
started.
hear. Sure,
So, good
sure.
morning, everybody. Good morning, everybody. We start the day 2 of the meeting, and it's my pleasure to invite Dr. Shelley, who's head of Department of Pediatrics at KGMU, and we are doing this meeting together. We are partners in this whole fight against PID at Lucknow, and so Dr. Mukesh will be speaking in this session, and we had to advance this session just because Dr. Troy is driving, and we'll have that session after Dr. Mukesh's session. Over to Dr. Shelley.
Thank you very much, Dr. Amita, for excellent conduct of all the sessions. And she's the one who is the moving force and the energy behind this. So it's my pleasure to introduce Dr. Mukesh Desai. Dr. Desai is Chief of Division of Immunology and Professor Department of Pediatric Hematology Oncology in BJ Wadia Hospital for Children in Mumbai. He has major interest in immune deficiency, especially MSMD. He was instrumental in getting BMT for PID started in Wadia Hospital. Besides academics, he enjoys traveling, collecting art, and making slides with animated cartoons. Our department has been interacting with Dr. Wadia over a case of PID in the last month, and we had very good professional support. I look forward to hearing from Dr. Desai. Over to Dr. Desai. Hello, Dr.
morning,
Desai. Yes.
Yeah. Can you hear me?
Yes.
Yes.
Hello.
Just make your slides full screen, Dr. Desai, if you can make it full screen. Dr. Mukesh, can you make your slides full screen? You are muted, Dr. Desai.
Okay.
Yes, now it's perfect.
You can hear me?
Yes.
Okay. So, good morning, everybody. Thank you very much for this great opportunity to meet and interact and see you all in person on the Zoom. My job today is to talk to you about autoimmune cytopenias in inborn errors of immunity. So we all know that primary immune deficiency means infection, but today we all appreciate that autoimmunity is also a very important component of primary immune deficiency disorders, and we are going to see more and more patients coming to us with immune dysregulation, which you will hear from the speaker who is going to speak next to me. So I have divided my talk into what are the various autoimmune manifestations in inborn error of immunity, the type of autoimmunity seen in various immune deficiencies, uh, what is the incidence, and I think a very important lesson to learn from this is that we need to diagnose rare diseases or so-called rare primary immune deficiency disorder by looking at common presentations of the disorders. And we'll talk about various cytopenias and especially about autoimmune cytopenias in inborn error of immunity. Uh, how do we treat them? What is the mechanism, and how understanding the mechanism is actually helping us devise targeted therapy for specific inborn error of immunity. So this is a cartoon which shows us the various autoimmune
Can you share your screen? We are not able to see.
I've already shared the screen. I can I
We'll have to
one
do it
minute.
again. We can't see it. Can everybody see the screen?
One second.
Anybody else?
Okay. I'll do it again.
No, we can't see the screen, sir.
We can't see. I think you might have to put
Yes, yes.
share.
Now it's there.
Now
Now
it
it
is.
is.
Now it's there?
Yes.
Okay.
Perfect.
It's okay?
Yes. Yes, yes.
Okay. So this is the cartoon which shows us the various autoimmune manifestations of primary immune deficient disorder. And if you notice in this cartoon, the most important one is the cytopenias, which is often a very common presenting manifestation of inborn error of immunity, followed by lupus-like illness, arthritis, vasculitis, then you have CNS, endocrinopathies, and so on and so forth. So we will today focus our talk mainly on the cytopenias, especially autoimmune cytopenias. And you can notice over here that besides T cell defects, interferonopathies, and B cell defects, we have gain of function and loss of function mutations, which can give rise to autoimmune cytopenias, which we'll talk about. So, what are the various types of autoimmunity which we see, and what is the incidence and impact of this diagnosis of autoimmunity in a patients of inborn error of immunity? So, this cartoon you can see the different types of autoimmunity seen in different PIDs, which is humoral immunodeficiency, and you notice over here that autoimmune cytopenias. Besides that, you also have inflammatory bowel disease. You have rheumatoid arthritis, rheumatologist gets involved, the gastroenterologist gets involved, and the endocrinologist also get involved in this kind of PID. Then we have immunodeficiencies of cellular origin, where the classical example is a RAG1, RAG2 deficiency, which can not only present as Omenn syndrome, but can also present with granulomas, it can present with various autoimmunities, and also very severe combined immune deficiency. And we have Wiskott-Aldrich syndrome, where we still don't know how it causes autoimmunity, but we do know that some of the autoimmune, the thrombocytopenia is partly autoimmune because it responds to IV gamma globulin therapy. In DGOG, besides the cardiac and the hypocalcemia, we need to focus on the autoimmune phenomenon, which is quite common. Then we have the newly diagnosed STAT3 gain of function, which we'll talk about, and the STAT1 gain of function, which also presents with autoimmunity. This is 852 autoimmune manifestation in 571 patients with PID, in which you can notice the commonest autoimmune manifestation is autoimmune cytopenia, which is seen in 31.4%. And if you take this, divide this into various types of PIDs, and B cell CVID, it is the commonest with 16.6% of patients having autoimmune manifestation like ITP or Ivan syndrome or autoimmune hemolytic anemia or autoimmune neutropenia. This is the US IDNet registry, in which you can see that out of all the patients, about 10.2% present with autoimmune cytopenia, and various cell line affection is seen in anything from 3.8% to 1.6%. In fact, there are papers which tell you that if you see a patient with Ivan syndrome and work them up for underlying PID, almost 40 to 65% have underlying inborn error of immunity. So today in our unit, we follow a dictum. If you ever see an Ivan syndrome, you have to always work them up for underlying inborn error of immunity. Now, having an autoimmunity in a patient with inborn error of immunity, as shown in this Kaplan-Meier graph, will show you that they have a poorer outcome. So I think this is another impact of autoimmunity in PID, which we should be aware of. What is the mechanism of getting autoimmunity in PID? Well, this cartoon shows you the various mechanisms, but the most important thing to remember, right from lack of central and peripheral tolerance to T cell hyperactivation to increased interferon response, where you have interferonopathies, which also very often come with autoimmunity. Classical example is lupus. Though lupus is an interferonopathy, it classically comes with autoimmune manifestation like an ITP or an EVANS or an autoimmune hemolytic anemia as a presenting manifestation. And defect in apoptosis, severe lymphopenia, complement deficiency, all of them make you susceptible through various mechanisms to autoimmune processes. This is just to take you an example of a RAG1, RAG2 deficiency, where lack of central tolerance and missing out on the autoreactive T and the B cell result in autoimmunity, as well as there is decreased Treg cell because of lack of peripheral tolerance, and you can get various manifestations in them. Now we all know that FOXP3 is a very important transcription factor, and the immune system, though, is very vigilant so that our autoreactive T and B cells are suppressed all the time. They don't come out. They're not allowed to come out into the circulation. They're regulated, but still we need peripheral regulation of this. Some of the autoreactive cells which come out into the circulation, for which we need the T regulatory cell. And today we have a whole group of disorders. We call them T regopathies, which include CD25 deficiency, which includes many other disorders. Coming to cytopenias in inborn error of immunity, this cartoon shows you, taken from Journal of Blood, it shows you various mechanisms. And as you can see over here, patients with autoimmunity with cellular defects, you can have a large group where you have antibody mediated deficiencies because of, say, CVID or LRBA deficiency or a CTLA4 deficiency, which causes cytopenias, autoimmune cytopenias. Then we have immune dysregulated disorder, classical example is HLH, which you heard yesterday from Dr. Michael Jordan. And then we have the X-linked lymphoproliferative disorders, which can also present to us with multiple autoimmunities and cytopenias especially. Then we have primary bone marrow failure syndrome, of which Icaros is a very interesting gene, which has got several manifestations just like the RAG1 and RAG2 deficiency. And it can come not only as a CVID, but it can also come as a severe combined immune deficiency disorder. Then we have GATA2 deficiency, which can come as myelodysplasia and present with cytopenia. And then we have myelosuppression, which could be secondary to drugs or infection, viral infection, which the immune deficient patient cannot eliminate, which can present to us with various degree of cytopenia. So let's talk about some of the cases which we see, and the commonest cases which come with autoimmune uh, cellular manifestation are the patient with ALS and ALS-like disorder. Then we have patients who have a CVID-like presentation, especially you have the CTLA4 and LRBA deficiency, which can come to us with large incidence of autoimmune cellular manifestation. So let's talk about ALS, which is the commonest presenting manifestation. And in patient cohort of ALS, the presenting feature is autoimmune hemolytic anemia, or an ITP, or an EVANS, or a neutropenia in almost 29 to 19% of patients. Splenomegaly is almost seen in 95% of patients. That's why we say any patient who comes to you with an EVANS phenotype and who's got lymphadenopathy or who's got splenomegaly or hepatomegaly should evaluate them for underlying ALS. And this is a dictum which we follow because a good lymph node biopsy will show you a smart histopathologist can pick up a paracortical expansion. And if you look at the immunohistochemistry, you can pick up the double negative population of T cells, which could be a very important clue for the histopathologist to suspect an underlying underlying autoimmune lymphoproliferative syndrome. So here are two examples of children who have come with ITP and this child has come to you with ITP as well as autoimmune hemolytic anemia, and they had a high double negative T cell population, which is the hallmark of us, which we all are aware of. In the Indian context, we take a higher cutoff value of 2.5 and above of double negative T cell receptor alpha beta, and it has other differential diagnosis which we need to keep in mind. And one very interesting thing about is that most people will start this patient on steroid, but the definitive treatment for them, which would really benefit this patient, is sirolimus, which is an mTOR inhibitor because the mTOR pathway is hyperactive in this population. This is the current cartoon showing revised classification of ALS, and which you can go through. And this is a molecular explanation for why you get the classical T cell receptor alpha beta double negative T cell increase in patients of autoimmune lymphoproliferative syndrome. This is a very interesting slide of by Dr. Koneti Rao, where he has said that the biomarkers which we use for diagnosing us, like the IL-10, B12, fast ligand, and the double negative T cell, depending on the number of biomarkers which are positive or in the diagnostic range, the chances or the probability of the patient having an ALK mutation increasing. So we as clinicians also use biomarkers to suspect ALK in our patient. This is an interesting story of a 2-year-old boy who had come with lymph nodes and autoimmune hemolytic anemia, and a lymph node biopsy diagnosed it as a Hodgkin's lymphoma. It's surprising to see a Hodgkin's at 2 years of age. And this patient was treated with ABVD, he responded, then he relapsed in 2 years' time. Again, a lymph node biopsy confirmed a Hodgkin's lymphoma, and he was again treated with another cycle of chemotherapy. Subsequently, 4 years later, he would come to us with this kind of lymph nodes, and we did suspect an ALK in this setup, and we did his double negative T cells, which was more than 12%. And this is a classical example of a patient of ALK who can also present with malignancy to us. We reviewed all the slides, and the histopathologist from Tata Memorial said this is still, we would call it a Hodgkin lymphoma. The clue could have been the presence of autoimmune hemolytic anemia with Hodgkin lymphoma. So even Hodgkin lymphoma with autoimmune manifestation should be looked for underlying primary immune deficiency disorder. There is a word of caution which is necessary in the management. Please avoid splenectomy in patient VAS because this patient develop big spleen and they have autoimmune cytopenia. Don't be in a hurry to do a splenectomy because you must avoid it, as such as patient have a higher risk of infection, and splenectomy will increase the risk of infection, and you can have a mortality in spite of vaccination and giving prophylaxis. You must avoid rituximab in the treatment of immune cytopenia in this patient because though this patient at diagnosis of hypergammaglobulinemia, but subsequently they develop hypogammaglobulinemia, and with rituximab they can develop a prolonged hypogammaglobulinemia which would require replacement therapy. Now, not all patients of ALS come to us with cytopenia. Some patient can come to us with a very high count, and this is a patient who came to us with a count of 1,29,000. And Dr. Manisha, when she did the flow, she said there's an 83% or double negative T cell population, 86% double negative T cell population, and this was worked up by Frederick Lecoq, and they found that a homozygous fast ligand mutation. Now coming to CVIDs, which come to us with immune cytopenias, this is a cartoon which will show you those circled in green are the monogenic causes for CVID, and all of these patients can come to you with autoimmune cytopenia as a clinical manifestation. So in the USID net registry, as I told you, the incidence can vary from 10.2% to 1.6%, but it can be much higher than this also in different studies. So just to show you an example of a girl who was being treated as an Evans syndrome for almost 6 years before they was referred to us, and we suspected that she could have an underlying immune deficiency, and we worked her up, and she turned out to be a case of LRBA deficiency. This is another child with a very strong family history of 3 sibling death with autoimmunity who came to us with ITP, then went on to develop Evans syndrome, would develop infections like hand, foot, mouth syndrome like this. Ultimately, on doing a genetic workup, turned out to be an LRBA deficiency. Another example of a child who had chickenpox, who had diabetes mellitus at the age of 2 years, candidiasis, and this child had an Evans-like phenotype and celiac disease and this also turned out to be a case of LRBA deficiency. So the various manifestation of LRBA can be, there could be multiple autoimmune manifestations, but the most prominent ones are the autoimmune cytopenias, which we is the focus of today's talk. So we have about 6 patients of LRBA, and it's interesting to know that 5 out of 6 had presented as an Ivan syndrome with polyautoimmunity. 50% had consanguinity, and there was 33% who had previous sibling death with a similar history. I think we need to pick up this diagnosis early, and that's why I think I like one sentence where Dr. Koneti Rao had mentioned that you need to diagnose rare diseases by common symptoms of their presentation, common presenting manifestation. And I think that's a very interesting statement which we need to follow. This is just to show you in a cartoon form that CTLA4 and LRBA work together, and the CTLA4 expression is less if the LRBA is deficient, and that's the reason the manifestation of both LRBA and CTLA4 is very similar. Now, here is a patient, our first patient of CTLA4 deficiency, who had presented with ITP, who had this alopecia areata, and who had an inflammatory bowel disease. And this patient was treated with abatacept and subsequently underwent transplantation with Dr. Prashant Devakar and Ambreen at Vade Children's Hospital. So this is just to show you a cohort of Schwab et al. In which there are a clinical manifestation of CTLA4 deficiency, and you can notice over here that the autoimmune cytopenia is seen in 59% of patients. So how common is this presenting manifestation of LRB and CTLA4 deficiency is something. ITP in 46%. So hematologists will have to be especially very, very alert to pick up this diagnosis, the underlying cause. We need to look beyond the immediate diagnosis. Here is from the same paper, CT images showing lymphoid infiltration, which is another hallmark. The combination of ITP and lymphoid infiltration, like you see over here, should alert us to the possibility of underlying immune deficiency. And as you can see over here, the CTLA4 is deficient, and we can use abatacept to prevent the effect of CTLA4 deficiency. Here is another example of a young girl with extreme failure to thrive with CVID-like phenotype, who had this kind of extreme nodular lymphoid hyperplasia. She had chronic diarrhea, and she has this bronchiectasis, who turned out to be a PI3 kinase gain of function delta mutation. Now, we all know this is a slide which has been shared by Dr. Koneti Rao, that this patient not only develop autoimmune cytopenias, but they can also develop bone marrow failure. And the characteristic thing of their bone marrow failure is they have aggregates of lymphoid infiltrate, which is different from an idiopathic aplastic anemia. And if you see this kind of lymphoid infiltrate, you should look for TEMRA cells, and you should do a genetics test to rule out PI3 kinase delta, because they respond beautifully to sirolimus. And if sirolimus does not work, then you can use a PI3 kinase inhibitor like leniolisib or idelalisib, which is undergoing trial at NIH and is showing great result with Dr. Koneti Rao when he come to Mumbai shared with us. Now there are some ALS-like diseases which looks like ALS, but they have different molecular cause. And here is one of our child who came to us with exactly lymphadenopathy, liver spleen enlargement. He had an ITP, an autoimmune hemolytic anemia, and he had autoimmune neutropenia. And this patient, we did lymph node biopsy. The patient was referred to us from Tata Memorial. We couldn't get a diagnosis, and we did a genetic test because it looks like an ALS-like, and he turned out to be a gain of function STAT3 mutation. He didn't have any solid organ immune defect. We did his IL-6 level was high, so we gave him tocilizumab. He used to have platelet count of 1,000, 5,000, and you can see the response which was there with to tocilizumab. There was a dramatic response in 96 hours to 72 hours. The patient showed a dramatic rise, but the fall was also equally dramatic. So we thought that since there is an excess of JAK2, STAT3 activation, we can block the JAK2 pathway and hope that this patient JAK2 pathway will work. So these are the various, in the thing which you see in yellow is what the manifestation of our patient. We put him on JAK2 inhibitor, and this JAK2 inhibition actually showed a very dramatic response. And there was a rise in the platelet count within a week to 10 days, and there was a rise in the uh, WBC count, and which what we are not believed that while before putting him on ruxolitinib, he actually developed polycythemia, which has not yet been reported in the world literature. And when we put him on JAK2 inhibition with ruxolitinib, his polycythemia also regressed and it came down to normal level. So which told us that probably the STAT3 gain of function was also causal for the polycythemia. The child was given a holiday, but after holiday, uh, after 6 months, he had a drop again in his cytopenias, and we had restarted him on ruxolitinib, and he's doing exceedingly well. Probably he'll end up with a bone marrow transplantation because to give ruxolitinib for such a long time is very, very difficult. So this cartoon shows us various hypogammaglobulinemia conditions, which paradoxically present to us with sometimes autoimmunity. Classical example is CVID, and I'm giving an example of a child with XLA who actually came to us because of an ecchymotic patch and was diagnosed as ITP, but because he had an interesting past history of viral pericarditis, a cellulitis and abscess, we did his immune workup, we showed he had 0 B cell, and he turned out to be a case of XLA. So here is a patient who has got 0 B cell, is producing autoantibodies and presenting with an autoimmune cytopenia. STAT1 gain of function, which we think present mainly with chronic mucocutaneous candidiasis, and also present with an Evans type of phenotype. And here is an example of a child who came to us with autoimmune hemolytic anemia and autoimmune thrombocytopenia at the age of 10 years and 12 years, and was subsequently diagnosed as STAT1 gain of function. And this is also a patient who would benefit with ruxolitinib. Now, we all know that autoinflammatory disorders and autoimmunity very often overlap. So does autoinflammatory disorder and malignancy. Sometimes it's difficult to know whether it is inflammation or it is malignancy or it is inflammation or autoimmunity. One such disease which bridges this gap is the DARA2 deficiency, which everybody is hearing, and I think you will hear more about it from somebody else. But they can also come to with various types of cytopenias. Yesterday, Akshaya already presented to you patient of an interferonopathy SPEN CD who is on ruxolitinib doing very well. Presentation with an immune cytopenia. His neurological status is improving, but somehow his hematological status is not improving with ruxolitinib. So here is one where the ruxolitinib is not showing a dramatic response. And the proof of principle is, since the JAK-STAT pathway is important for autoactivation of interferon, we can use the JAK2 blocker for interferonopathies. How do we treat? What are the therapeutic options in autoimmunity, autoimmune cytopenias of inborn error of immunity? Now, I already showed you many pathophysiological mechanisms and how we treat different immune defects, but there are plenty of options which are available, which are based on understanding of pathophysiological mechanisms. So here is one slide which just shows you that patients of CGD who has autoimmunity with granulomas can be treated with steroid. ALS, I've already mentioned to you, sirolimus is the drug of choice. STAT1 gain of function, JAK inhibitor, this is not a great drug. We haven't found it to be so as effective as we had found it to be in STAT3 gain of function. In patient of LRBA and CTLA4, we know
Dr.
abatacept
Desai, we have done 25 minutes.
Okay, I'll finish in 2 minutes.
Yes, sir.
So we then for APDS we have the idelalisib, which is an PI3 kinase inhibitor, and I think so. Understanding, making a correct diagnosis, and understanding the pathophysiological mechanism, we can offer them a lot of treatment. And here is to just to show you in a cartoon form that using ruxolitinib, which is a JAK2 inhibitor, in gain of function STAT1 actually inhibits STAT1 phosphorylation and normalizes the Th1, Th17 responses. It even cures candidiasis and induces remission of immune-mediated cytopenias, but we haven't seen that in our own experience yet. Now, there are many B cell specific interventions which we can use, like targeting the anti-CD20, especially when you have EBV associated with it, or when you have autoimmune cytopenias. But as a word of caution, in patients of ALS, you must avoid it or in patient of CVID also, you must try to avoid because it can result in sometimes prolonged hypogammaglobulinemia requiring replacement therapy, which is very expensive. We have already gone through the CT abatacept, and of course, that bone marrow transplantation is the treatment which will cure the patient with underlying PID and hence the immune cytopenia. So this is just to acknowledge all the people who have helped and who are continuing to help us in our department. Thank you very much for giving me a very, very patient hearing.
Thank you very much, Dr. Desai. Dr. Amita, there was one hands up from Dr. Pankti Mehta and one question. Do we ask questions?
Yes, Dr. Shelly, you'll have to read out the question because we have not allowed.
Okay, so the question is prevalence of PID in Evans syndrome of 40 to 65%. Does this hold true for a particular age group? That is first question, sir.
Well, I think now everybody agrees that when we are looking at inborn errors of immunity, we don't look at the age group because the presentation can be at any age group. So I think you should be liberal in investigating patients.
So the second question is from Dr. Soma Balan. She's saying card 11 VUS mutation without recurrent infection. Now going for HLH. Any insights?
Is it a gain of function mutation or loss of function mutation?
I don't know. She hasn't written that.
Okay.
Okay.
Well, if it's a VUS, then it is very difficult to say. I don't know whether you can do any functional studies which can validate what you're doing. Maybe Manisha, is she's there, she may be able to answer this question, or anybody else.
Okay. So if there, Manisha, would you like to answer, Dr. Manisha?
Yeah. Can I answer that? Yeah. We had gain of function, 2 patients, gain of function mutation with B cell lymphoproliferation. They present like Benta syndrome, and some of them have autoimmune manifestations, and 2 of them initially, in fact, suspected with HLH. So these patients can be looked up for Benta syndrome, and we need to do B cell immunophenotyping. They have expansion of transitional B cells, and they also have expansion of double negative T cells. That can be done at our center. So it can be worked up from that angle.
Thank you very much, Dr. Desai, for a wonderful talk and for the insight. And I would also like to thank Professor Sudhir Gupta, who I see this morning. Good morning, sir. This is a wonderful seminar going on, and you linking us up with Dr. Amita has been really a knowledge gain for all of us in KGMU. So we end this session and over to Dr. Amita. Thank you.
Thank you, Dr. Shaili and Dr. Mukesh. It was wonderful. And as you know, I am interested in autoimmunity, so it was a great talk for me. And we move on to the next one. And I request Dr. Narendra Mehra to introduce the speaker.
Thank you very much, Anita. I do see Amita, not Anita. The speaker has now joined. I'm very happy to introduce him to you. Troy Torgerson is the Director of Experimental Immunology at the Allen Institute of Immunology. And prior to joining this institute, he was at the faculty of the University of Washington and Seattle Children's Hospital. He obtained his MD and PhD in immunology from Vanderbilt University School of Medicine and completed fellowship training in pediatric rheumatology and immunology at the University of Washington and Seattle Children's Hospital. Troy's research has focused on characterizing genetic mutations that cause the immune system to become dysregulated, leading to autoimmunity and susceptibility to infections. He is loved by his students for his immunology boot camps during the annual meetings of American College of Rheumatology. He is a teacher par excellence, and I think that's the kind of speaker that we want for a conference like this. Troy, you're going to speak on immune dysregulation and autoimmunity. What an important title you're going to speak on.
Thank you very much for that incredibly kind introduction, and thank you for the opportunity to present here. Let me share my slides and get this into presentation mode. So it's hard to follow that tremendous talk by Dr. Desai. That was really wonderful and really got through a lot of information. And so I am really glad to be able to follow on with a few things. Just some specific things around both diagnosis of these this class of disorders and treatment of this group of disorders. And so we'll run through this, and if you have any questions, please throw them in the chat, and I'll try to address those as I go along. So I'm going to cover 4 things. So there'll be a little bit of background. We're going to talk about a diagnosis and diagnostic approach to these disorders. We're going to touch a little bit on non-transplant disorders, although I won't do it nearly as much justice as Dr. Desai just did for non-transplant disorders. I'm going to spend most of my time actually on transplant of these disorders, because that really, I think, has become the direction that a lot of folks have gone with these patients, and there's some challenges that we face that I want to make you aware of that may be worth thinking about. So just by way of introduction, again, you all have seen this before. This is a summary of the IUIS gene list publication. The most recent version, of course, came out in the beginning of 2020, and there were about 430 genes that were associated with inborn errors of immunity in this publication. And if you take those disorders and you sort of divide them up by disorders that present mainly with infections, where infections create most of the morbidity, these are the classic primary immune deficiency disorders that we, of course, think of as PIDDs, where patients get infections. They might get autoimmunity, but mostly their problems are infections. On the other side, as you've just heard about, there's this group of disorders that really their main pathology is immune-mediated pathology. It's autoimmunity, inflammatory disease, and you've just heard a lot about those from Dr. Desai. We have had tried to try and set these apart, began calling these. It actually started that we were writing a grant, and we needed an acronym to call these disorders in that grant. So instead of PIDD for primary immune deficiency disorders, we coined the term primary immune regulatory disorders for these, and that's the term that I'll use going forward as I refer to these. So what do these disorders include? Well, there's a lot of things here. So there's the disorders that kind of got me thinking about this, which are the disorders of regulatory T cells that are up here in this quadrant. That these are IPEX and the IPEX-like disorders. But there's a lot of other disorders in this category of primary immune regulatory disorders. There are, of course, the classical familial HLH disorders. So, of course, profound inflammatory disease caused by perforin mutations and any of the mutations involved in degranulation that you're aware of. There's a group of disorders that you've just heard about, these autoinflammatory disorders that these are oftentimes, when they were originally characterized as periodic fever type disorders. And then a group of related disorders that I've listed here as kind of debris defects, which are disorders that tend to be associated with overexpression of type 1 interferons and all of the immune dysregulation that comes along with those. And so those are here. Dr. Desai has talked about the disorders that involve non-malignant lymphoproliferation, so ALPS and ALPS-like disorders down here in the corner. And then there's a growing group of disorders that are associated with a susceptibility for malignant lymphoproliferation, and y'all are familiar with many of those. And there's a list of these that continues to grow, and I think this will be an area where we'll see more. And then, of course, down here in the other corner are these congenital hypersensitivity disorders, things like PGM3, the STAT5 gain-of-function disorders, where it's really Th2 immunity that's dysregulated. And then I've included here, of course, the early onset IBD disorders, where many of those are associated with primary immune deficiency or genetic immune deficiency disorders, and a growing list of disorders associated with rheumatologic disease. And so this is really this universe of primary immune regulatory disorders that really are a growing group of disorders, and that's what we'll be talking about today. And I think it's important to be aware of how to diagnose and treat these. So let's talk a little bit about diagnosis. I think one of the challenges with these disorders is that making the
for a minute, your slides are not in the slide mode; they are in the presenters mode.
So, I'm so sorry. Let me switch that for you. Is that better?
Yeah, now it is. Thank you so much.
Okay, I'm so sorry about that. And actually I'm going to get a pointer that makes it a little bit easier to be able to see that as well. Is that better? I'm sorry about that. Thanks for telling me. Okay, great. So I think, one of the challenges is of course diagnosing these disorders, and as you've just heard from Dr. Desai, there's a lot of phenotypic overlap in these disorders. So there's many of them have shared features, and it can make the diagnosis difficult. And so, as I'll mention highlight in just a minute, because of this phenotypic overlap, really the most direct way for these disorders to make a diagnosis is to do sequencing, genetic testing early, and using broad-based genetic testing, either with a panel or with an exome or a genome, really is the most direct way to get to a diagnosis of these disorders. It's very difficult to tease them out just by the clinical features because of the overlap. And most of the flow and functional assays for these disorders, there are some exceptions, but for the most part, most of those are not as sensitive or specific as the genetic testing. And so that is my recommendation for getting to those. Now, one of the challenges with these disorders, as I'm showing here on this slide, is that there's a growing number of these disorders that can present with somatic mutations. So there's a whole list of these, and I've shown a list of this is actually from a publication, which is a very, very nice review of this that was published about a year ago. And the challenge is that there are somatic mutations in just a subset of these disorders can actually lead to, in just a subset of the cells in the immune system can actually lead to the exact same disorder that germline mutation can cause. And it may, in some cases, the mutation only needs to be present in 5 to 10% of the cells to cause the full-blown clinical disease. And that creates real problems for any kind of testing to make this diagnosis. Because, of course, when you're doing genetic testing, if you're sequencing, you will see the sequence of the 90% of cells that have a normal sequence, and it will be very difficult to detect the small population of cells that actually have the mutation and cause the disease. Okay, so many of these genes are shown here, but I wanted to show you a couple of genes that recently have been recently published that are I think are interesting. These are STAT3 gain of function mutations that cause pure red cell aplasia. But what's interesting about this group of somatic variants that were described is that these STAT3 gain of function mutations occur only in a subset of CD8 positive T cells. So if you get a STAT3 gain of function mutation in just the CD8 positive T cells, then you can develop pure red cell aplasia, as shown by this cohort of patients described from Japan. Some of you have probably seen the beautiful publication that recently came out from Megan Cooper's group in St. Louis, showing that mosaic or somatic mutations in TLR8, so gain of function mutations in TLR8, lead to bone marrow failure and neutropenia, and a combined immune deficiency disorder that includes both myeloid and lymphoid defects, because these patients, in addition to having neutropenia and myelodysplasia, they also have hypogammaglobulinemia and humoral immune defects. So this is an area where I think we're going to hear a lot more over the coming years about these somatic defects that can drive immune dysregulation in patients. I think it's very unlikely that we're going to see very somatic defects that are driving immune deficiency in most cases, because of course the cells that acquire these mutations, the way that they expand is to have a selective advantage and grow and divide, and of course if that typically means that they're going to cause immune dysregulation as opposed to immune deficiency for the most part. So that's just to make you aware of those, and just then a reminder again that because of the phenotypic overlap, the most direct way to get a diagnosis in these disorders is to do broad-based genetic testing. Now, I was going to talk about non-transplant treatment approaches to these diseases. You've just heard actually a terrific talk highlighting many of these. And so I'm not going to spend a lot of time on this. Just again, highlighting the fact that there are a growing number of targeted therapies that can be used in these diseases. And it's another reason why genetic testing to obtain a specific diagnosis is really important, because then you can choose a targeted therapy that can more effectively treat the patient and cause fewer side effects. And so that's as much as I'm going to say about this. I think Dr. Desai brought up the very interesting point, and I think one of the clinical challenges that we have, which is the question of how long can patients stay on these targeted therapies, and can you treat someone who's diagnosed in childhood for 50 or 60 years with one of these targeted therapies? And I think we just don't know that yet. So even though their disease may be well controlled, then what do we do? And I think that what we do is we think seriously in many cases about moving to bone marrow transplant. And I wanted to talk about some of the challenges that we've run across with bone marrow transplant for these immune dysregulation disorders. So when you talk about bone marrow transplant and you talk to your transplant colleagues, there's really three things that that they're going to talk to you about related to the transplant that you want to be aware of. One of those is the conditioning regimen, and what this is the set of drugs or therapies that are used to prepare the bone marrow to receive the donor cells and to make space really in the bone marrow for those donor cells to engraft and expand and be able to then take over and provide protection, immune protection for the recipient. You want to know who the donor of those cells is going to be. Is it going to be a sibling? Is it going to be a parent? Is it going to be a matched unrelated donor? And you want to know what graft versus host disease prophylaxis is going to be used in a particular regimen to try and prevent both graft rejection by the recipient, as well as graft versus host disease by the donor cells that have been given to the recipient. And so we're going to talk a little bit about these and about some of the approaches that have been tried in immune dysregulation disorders and what we've been trying to do. So this is published data. It was published earlier, later in 2020. This is a survey that we did here in the United States and among a group of centers in Europe, where we asked the question, and this is, I want to just highlight that Alice Chen and Jennifer Lighting took the lead on this survey. And we simply asked the question to all of the transplant centers in the PIDTC and the centers where we sent this survey: have you transplanted patients for an indication of an immune dysregulation or autoimmune disease? We didn't specify which diseases we were interested in. We just wanted to know whether or not they had transplanted patients because they had severe autoimmunity or immune dysregulation. And then we asked the question, if you've transplanted those patients, how many of you transplanted? What was the transplant approach used, and what was the outcome? And so it was a short survey. And again, 44 transplant centers here in the US, 3 centers from EBMT. And this is the outcome really summarized in a couple of slides. Number one is that there were 226 patients that had been transplanted by these centers for a primary indication of autoimmunity or immune dysregulation. And what was really striking here and a little bit depressing is the outcome as shown to the left in terms of the survival curve. And you'll notice that overall, out about 10 years post-transplant, survival is only about 50%, taking all comers in this group. And you'll note that there's a very rapid drop-off in survival within the first year post-transplant. And so that I think highlights the need to gather more information about these disorders, how they're being transplanted, and what we can do better. If you look at the disorders that people reported, there were the largest number were in patients with IPEX syndrome. There were 62 patients actually with IPEX syndrome that had been transplanted. There were also quite a number of patients with PI3 kinase delta deficiency that are gain of function mutations in PI3 kinase delta, and then quite a number with unknown genetic defects that were transplanted. And you'll see there was a mix of others in here that were transplanted primarily because of autoimmunity or immune dysregulation. So it raises some questions really about transplanting these patients that I think we all face as clinicians as we try to think about how do we take care of these patients most effectively. You know, survival is, it's okay, but it's not great based on the data that I just showed you. And the question is, how do we improve survival? How do we improve event-free survival? And I think one of the things that we've become aware is that, yes, for our own patients, and I'll show you data from a study that we've done here locally in Seattle, our survival is quite good, but many of the patients have long-standing morbidity. So they have a lot of ongoing problems. Some of those arose before they went to transplant, like chronic lung disease or other problems. Some of those arose because of transplant, and that is a problem. So the other big questions are, when's the best time to move to transplant? And as we just talked about, you know, there are now these targeted therapies, and the question is, how long do you maintain a patient on a targeted therapy before you make the decision to go to transplant? When's the right time? Or if the patient's not responding to therapy, when do you move to transplant in a patient like that? How should patients be treated prior to transplant? And then how much donor chimerism is sufficient to correct disease? And let me just talk about this donor chimerism issue just a little bit. So if you look at disease mechanisms in some of the diseases that you've heard about, you know, in normal patients, there's no mutations and all of the cells and all of the immune cells are happy. There are patients who have germline mutations, but mutations where the protein is only expressed in a small subset of cells. So for example, in IPEX syndrome, FOXP3 is only expressed in regulatory T cells. For the most part, it really only affects regulatory T cell function. And so regulatory T cells here, as shown in sort of the faint cells there, they've got a mutation and they're absent. The mutation, the protein's not expressed in the other cells, but because the regulatory T cells are absent, the other cells are unhappy and they're angry. And so because they're angry, they cause a lot of autoimmunity and lots of problems. There are patients with germline mutations that are expressed everywhere, like in the STAT3 gain of function and the STAT1 gain of function mutations, the IL-10 receptor defects or the PI3 kinase defects. And because they're expressed everywhere and they cause immune dysregulation in all of the cells that they're expressed in, all of the cells are unhappy and you get autoimmunity. And then lastly, as we've talked about, there are patients who have somatic mutations that can occur in a subset of cells. And when they occur, they can cause, of course, those cells to have problems and be angry, not be happy. But those cells can also cause some of their friends to be unhappy and cause autoimmune disease. So let's now think about this from the standpoint of transplant. So if you do a bone marrow transplant, and you end up with mixed donor chimerism, meaning that the donor cells only make up a portion of the total immune cells in the patient after transplant. Really what's going to happen is that you're not replacing all of the cells that have mutations. And if you leave behind any cells that have these gain of function mutations, there's a risk that the patient is going to go on and develop immune dysregulation, and then you've really not cured the disease by transplant. Even though you've gone through the whole process, you've potentially caused morbidity associated with transplant, but you've not controlled the disease. So let me just tell you very briefly in the last couple of minutes about some experience that we have here in Seattle. So I'm going to tell you about IPEX syndrome. We've done a prospective study now for the last 10 years. And for these patients, we use one of two transplant regimens. So for patients who have few comorbidities, they really are quite healthy clinically when they go into transplant. We use a transplant regimen that is a myeloablative reduced intensity transplant regimen. And what I mean by reduced intensity is that we're using treosulfan, reduced toxicity, myeloablative reduced toxicity regimen. We're using instead of busulfan. And treosulfan has fewer side effects in terms of causing veno-occlusive disease or sinusoidal obstructive syndrome in the liver and lungs, and so has reduced toxicities compared to busulfan. If patients are quite sick when they come to transplant, we use a very mild transplant regimen with just a little bit of fludarabine, some total body irradiation, and then we use peripheral blood stem cells so that we just give them a large donor graft, hoping that we can drive in a graft using this approach. So just on the scheme of fully myeloablative regimens up here in this upper corner, the treosulfan regimen, again, it's myeloablative, but it's reduced toxicity. And this less intense regimen for the patients who are really sick when they go to transplant is down here. And this is what we call a mini transplant or mini transplant approach, and certainly not myeloablative. I want to just highlight the outcome real quickly of this this transplant regimen that we like to use for patients who are well. We've transplanted 10 patients with this regimen. Survival is excellent. Actually, all 10 patients have survived. So we've got 100% survival, but here's the problem. We have now had 4 patients who have been transplanted using this fully myeloablative regimen who have started off with either full or high-level mixed donor chimerism, and over time, following the transplant, their donor chimerism has begun to drop. And first, they lose the donor chimerism in their myeloid cells, then they lose the donor chimerism in their B cells, and then their donor chimerism in the T cell compartment begins to just progressively fall. And we've had patients who've lost their bone marrow graft 6 years post-transplant and had their IPEX recur. So I think that what it raises, we used to think that with IPEX, we could just do an aggressive enough regimen that we could just get the regulatory T cells in, and if we could just get the regulatory T cells in, that was enough. And in fact, patients did clinically very well when we just got the regulatory T cells in. But what happened is that what we've now seen is if we don't get full donor chimerism, we're seeing late graft rejections, and these patients now are having disease recurrence. And we're seeing a hint of this in other immune dysregulation disorders as well. And it's really made us believe now, after again a 10-year prospective trial, that we need to be more aggressive in making sure that we try and get full donor chimerism in these disorders of immune dysregulation. And I want to leave you really with that thought, because what it means is that, of course, as you are more aggressive in the transplant regimen, there's a higher risk that you're going to have side effects and complications with the transplant. And so you have to strike a balance between really good survival and then good outcomes from the standpoint of controlling disease in the long term. And I think that's one of the challenges that we face, and we don't have an answer yet. We're doing some things to intensify the conditioning regimen to try and, again, our survival is very good, but we need to do better in terms of getting full donor chimerism. And I want to leave you with that thought, because it's an interesting thought that I think is really important for this group of disorders. And it highlights the importance of following these patients longitudinally over time and making sure that you don't transplant them, you send them home and then never see them again, because that can be a problem. And with that, I'll go ahead and stop and take questions. I know we're near the end of time.
Thank you, Troy. Thank you for highlighting the use of this stem cell transplantation in PIRD. I have a couple of minor questions first, and then I will go to the chat box. I just wanted to know, because you keep using the terminology BMT, are the stem cells only obtained from the bone marrow, or you also take from other sources?
I'm sorry, we take them from other sources. Really, I should use HCT or HSCT, but yes, absolutely. We prioritize bone marrow most of the time, but there are situations where we use peripheral blood stem cells or cord blood as well.
Were you able to find an HLA-ID sibling, or you did the mud transplant or a haplo?
So mostly mud transplants is what we end up doing, and actually our outcomes with matched unrelated donor transplants are as good as with matched siblings now, and that's actually been shown for most both immune deficiency and immune dysregulation disorders, that because of better matching and better graft versus host disease control, outcomes for matched unrelated donors are pretty darn close to matched siblings.
And these are done in Allen, not in Fred Hutch.
These are done. No, these are done in the Hutch. These are done at the Hutch and the Seattle Cancer Care Alliance. Yes. So yeah.
You know that because I spent a few years over there with John Hanson in the 80s.
Yeah.
But this is a very heterogeneous group you're talking about. You're talking about children who are normal. You're talking about children who have a germline mutation and a somatic one. So you're going to see anyway a very diverse outcome and that could be related to the germline or the somatic mutation.
Yeah, it's true, and I think we don't really. It's very difficult in this group of disorders because there is such a range of phenotypes, and it gets to some of the questions I raised earlier, which is, when do you take these patients to transplant? Can you maintain them on immune suppression for a while before you take them? And it's really hard to make that decision. And of course, you need to make sure that you don't want them to acquire any permanent organ damage before you go to transplant, because of course that can affect transplant outcomes. And so you want to make sure that you get them to transplant before they've got permanent organ damage, but you also, if they're doing really well on, for instance, on abatacept, CTLA-4 Ig, do you really need to take them to transplant? I think this is one of the big questions. We really don't know how long a patient can survive on abatacept, for instance.
Mr. Moderator, let the question come from the chat.
Yeah,
you should do the last.
There are a few questions in the chat box, and I wanted to ask you one from Tej Pratap Singh. Can we use recombinant IL-10 rather than Treg transplant?
Oh boy, that's a great question. I don't think we know yet. It's a really good question, though.
Okay, and there is one from Sapan Pandya. Between immune dysregulation and immune deficiency disorders, what drives that? Evolution? Does it change longitudinally in an individual over time?
I think it's a very good question. I think certainly with the immune, there are many immunodeficiency disorders, so PIDDs, who ultimately go on to develop immune dysregulation, as we know. We didn't know that for many of them, we didn't know that they developed immune dysregulation until, of course, we had antimicrobials, antibiotics, antivirals that could keep them alive long enough to allow the immune dysregulation then to show up. And so I think certainly in the case of immune deficiency disorders, for the most part, it's, as patients survive longer, then the immune dysregulation becomes more apparent. With the ones that start out with immune dysregulation, I think it's, again, these patients have lived in rheumatology clinics, in, hematology clinics, nephrology clinics, GI clinics, and only recently, because of genetics, have we begun to find these patients now and aggregate them so we really don't know what the extent of this is going to be.
There is one question which is more direct. This is from Umair Ahmed from National Institute of Immunohematology in Mumbai. Is there any particular clone that should be used for FOXP3?
For flow cytometry, is that what you're talking about?
That might be the yeah.
Yeah, so there are a couple of there's now a host of antibodies that really work well, and there's been a lot of debate in the literature. We tend to like the BioLegend. There's a couple of clones sold by BioLegend, and I forget the exact clone. I'm happy to, if you email me, I'm happy to share which ones. There's two that we found that work really well, but now there's a bunch actually that really work well.
Let me ask you the last one before the organizers shut me down. There's another one from Sapan Pandya. He says, we saw a similar early mortality in scleroderma ASCT as well. Was it because of infections? and that a lesser intensive regime, as you showed, would help to reduce that?
Yeah, it's a really good question. So certainly there were infections in the scleroderma patients and that were transplanted initially. And the initial transplants for scleroderma were not super successful. The more recent data looks much better, and I think that really has come about because they've refined the conditioning regimen so that they're getting so that they're using less toxic conditioning agents. So many of these patients, of course, have terrible lung disease. So that's one of them, is that the patients are having fewer side effects from the conditioning regimen. But in addition, they're agents like treosulfan, they're more intense, but because they're less toxic, you can get more of an effect with fewer side effects. And I think that's really probably what's made a big difference for instance, in scleroderma and some of these others, where they can do a more intense conditioning regimen, but with less toxicity. So
thank you very much, Troy.
Thanks, Troy. Thanks, Troy.
Thank you for inviting me. I really appreciate it. Thank you.
Great talk. Thank you.
Thanks a lot, Dr. Mehra and Professor Troy. It was wonderful and we all enjoyed it. And we move on to the next session. And the next session is free papers. And this will be chaired by Dr. Manisha Matkaikar and Dr. Biman Saikia. And they will be the judges for this session. And we will be selecting 2 presenters who will get the first and the second prize. So I'll be sharing the slides from here. So I hope you can see the slides, Dr. Manisha and Dr. Biman.
Yes.
Yes. Yes, Dr. Amita, we can see the slides. Yes. Thank you so much.
Just change it. So we can invite the first person. There is.
Iman, you want to start?
Yeah, so I think we have 7 papers in this. So I'd like to request the participants to stick to the time allotted, that is 5 minutes. And we will look at whether you are sticking to the time, the quality of your presentation, the content of your presentation, and then how you answer the questions at the end of the presentation. So can we have the first paper? This is by Dr. J. Muthumitra.
So Dr. Mitra, are you there in the audience?
No, she hasn't.
Sorry, she hasn't joined. Probably she's having some issues with joining. I don't know because we haven't seen her. So we can move to the next one.
We can have the second one. Okay.
Yeah.
Dr. Rani Manisha then? Yeah.
Yeah, she's here.
Yeah, Dr. Manisha.
And we will have a ring at 5 minutes, and we can have questions from the chat box you can take.
So, Dr. Amita, you are keeping the time?
Yes, we'll keep the time and we'll send you the.
Yeah. Do that, please. Thank you so much.
Sure.
Good morning, all. I'm Rani Manisha from Department of Medical Genetics, HGPGI. I'm going to present my study on clinical spectrum diagnosis, treatment, and molecular analysis in the series of 5 cases of hereditary angioedema. Hereditary angioedema is autosomal dominant rare disorder with the characteristic symptoms of recurrent non-pruritic self-limiting subcutaneous or submucosal edema, primarily due to increased bradykinin level. There are 2 groups of hereditary angioedema. The one is with C1 inhibitor deficiency, either qualitative or quantitative, and it is due to SERPING1 gene mutation. In type 1, there is low C1 inhibitor level, and in type 2, the inhibitor level is normal or elevated, so it is qualitative defect. The second group is with normal C1 inhibitor level. It is due to either F12 gene mutation, and other genes involved are those encoding for angiopoietin, kininogen, and kallikrein. In 70 to 75% of cases, the genetic basis is unknown. We manage the cases by demand on therapy of acute attacks, short and long-term prophylaxis. We do long-term prophylaxis in case of recurrent and severe attacks like laryngeal edema. The approved therapies of hereditary angioedema are plasma-derived C1 inhibitor, ecallantide, icatibant, that is bradykinin beta-2 receptor antagonist, and lanadelumab, which is monoclonal antibody which acts against kallikrein. Trials are ongoing for second generation oral kallikrein inhibitor and subcutaneous plasma-derived C1 inhibitor concentrate. The therapies under research are gene therapy to correct C1 inhibitor deficiency, inhibiting factor 12 by RNA interference, human monoclonal antibody against factor 12, and antisense oligonucleotide to reduce production of free kallikrein. Our study is a retrospective study with cataloging of clinical feature, diagnosis method, treatment management. In our study, all the 5 cases were male from 4 unrelated families. 2 were related and were father and son. The age of presentation in 4 of them was in early childhood, and in 1 case it was in adolescent age group. The age of diagnosis was 4 to 5 years after the age of presentation, and in 1 case it was at the age of presentation. They all came with presenting features of recurrent swelling episodes of varying regions of body like lips, face, tongue, and limbs. And in 2 cases, there were recurrent episodes of abdominal pain, and choking episodes were present in 3 of them. In 1 case, there was only recurrent episodes of swelling of hands. In our study, the C1 inhibitor level was low in 1 case, and it was slightly elevated in 3 cases. The normal level is 19 to 37 milligram per deciliter. The C1 functional esterase level was low in 2 cases. The normal level is more than 67% of normal quantity. The C4 level was variable in 4 cases, with low level in 3 cases and high level in normal level in 1 case. We did targeted exome sequencing in 2 cases, and in 1 case we found a missense variant in SERPIN1 gene, and we found that the variant is absent from population database and was predicted to be pathogenic by prediction softwares. In 1 case, there was no pathogenic variant found in either SERPIN1 or F12 gene. We managed our cases with fresh frozen plasma, intravenous steroids, antifibrinolytic therapy, danazol, and supportive therapy. 3 cases were put on long-term prophylaxis with danazol, in whom there were life-threatening, recurrent and severe episodes of swelling, and those were monitored for at 3 monthly interval for liver function, renal function, and lipid profile.
Something's going wrong.
The conclusion of our study is that there is need to suspect hereditary angioedema in all patients presenting with characteristic symptoms, even if there is absence of positive family history of hereditary angioedema. There is need of patient education about clinical situations suggesting high risk like pregnancy and puberty, and need of timely hospitalization with treatment with fresh frozen plasma and other. The screening should be performed in all first-degree relatives of an affected individual, and there is need of awareness among clinicians as the complexity of diagnostic and therapeutic options requires active involvement of them. Thank you.
Dr. Bhima, you can ask.
Thank you, Dr. Manisha. Do we have any questions in the chat box for this paper? I don't think we have any questions. So was this mutation that you demonstrated a novel mutation, or was this a known mutation?
So it was a novel mutation. We found that it was absent from population database.
Okay, that's great. Any more questions we have on this paper?
So I have one question, Manisha. So what do you suggest as a best diagnostic approach for these patients with hereditary angioedema? And identifying an underlying mutation, does it make any impact on the management of these patients?
Ma'am, the appropriate diagnostic method would be the Firstly, we will see for the characteristic clinical features and the C1 esterase level, and also the functional level is important. As in type 2, the level is the C1 inhibitor level is normal, but the functional qualitative defect is there. And for the genetic mutation testing, for the genetic mutation analysis, it is important that the variant is known so that the other family members can be screened for that variant.
Okay, so we have one question in the chat box. When do you suspect or how do you screen for HAE due to factor 12 mutation? That is a type 3. When do you suspect that?
So, when the patient presents with the characteristic symptoms of hereditary angioedema and C1 esterase level, both quantitative and qualitative analysis is normal, then we can suspect that it may be due to F12 gene mutation. The clinical features are there, but the C1 inhibitor level is normal and the functional level is also normal. Then we can suspect that it is due to F12 gene mutation. So we can go for genetic testing for that gene.
Okay, thank you so much. And I think then we can move on to the next paper now. So we'll have the first paper now by Dr. Muthu Mitra. Is Dr. Mitra there?
So has Dr. Mathu joined?
Yes.
I think she has
Yes,
joined. She put a message. Yes.
Yes.
Yes, ma'am, I'm here.
Yes. Go ahead.
Good morning, one and all. I'll be presenting a paper titled Chronic Granulomatous Disease, Review of Clinico-Pathological and Treatment Profile of 23 patients from a tertiary care center in South India. So we all know that chronic granulomatous disease is a rare inherited primary immunodeficiency disease, and it is characterized by defects in the genes encoding the essential subunits of the NADPH oxidase, thereby making the phagocytes unable to kill catalase-positive microorganisms. Hence, the hosts are susceptible to a spectrum of specific bacterial and fungal infections. So there is always a paucity of data on CGDs, especially from developing country like us. So the aim of this paper is to study and analyze the clinical profile, the microbiological spectrum, and treatment received in children diagnosed with CGD in our center over the span of 4 years. So it was a retrospective study from 2016 to 2019 using medical records where the patients diagnosed with CGD were reviewed and analyzed. And we also had a follow-up by in-person appointments and also through phone calls for the next 1 year till December 2020. So coming to the results, our study population included 10 males and 13 females. The age of presentation, the median age of presentation was 1.8 years, and the 82% of the population were less than 18 years. And the diagnosis was based on these two tests, the reduced nitroblue tetrazoline chloride test, which we did in all our study population. But because of the financial constraints, NGS was performed only in 9 patients. So reduced NBT, the results were consistent in 10 patients, and it was suspicious in 3 patients, and it was negative in 10 patients. So the patients who were suspicious, like those 3 patients, of the 3, 2 had undergone NGS, of whom, 2 were positive for the mutations. So coming to NGS was performed only in 8 patients, mainly because of the financial constraints. And it was positive for X-linked mutation, that is the CYBB mutation in 3 people. And it was positive for the NCF mutation, characterizing the autosomal recessive variant of CGD in 3 people. So this is the spectrum of infections of the patients at presentation. The majority presented with a lower respiratory tract infection, that is a pneumonia, in 65% of the population. And the next most common manifestation were multiple pyogenic skin abscesses, which constituted 52%. And otitis media was seen in 8% of the population, UTI, urinary tract infection, in 4%, and CNS infections in 4% of the population. So coming to mycobacterial tuberculosis, we had treated around 39%, both empirically and evidence-based. That is for a TB pneumonia in 39% of the population. And 13% were treated for TB lymphadenitis, and 4% for TB meningitis. And we were able to isolate few organisms. That is 17%, that is 4 patients we had isolated Aspergillus. It was both serological based and it was based on the microscopic evidence. 2 people had tested positive for serum galactomannan, whereas the other 2 had a microscopic evidence of fungal hyphae. And the 8.6%, we had in 8.6% of the population, we had isolated mycobacterial tuberculosis based on gene expert studies. And from the pyogenic abscesses, Staph aureus were isolated in 8.6% of the population. 1 patient, that is 4.3%, had a pericardial fluid, which the culture of which had grown Burkholderia. So melioidosis was found in 1 patient, and 1 patient was treated outside for nocardia. The ear swab had grown nocardia, and she was treated with chloramphenicol and Septran for 3 months outside and presented with a ring enhancing lesion in the brain. So we had to take it as nocardia, and we had treated for nocardiasis, following which she is doing well. So coming to the treatment and the follow-up, all the patients received appropriate antimicrobials. Around 56% of the population received ATT, predominantly empirical, and they were put on prophylaxis, both Septran and the antifungals. The families were also counseled for the prenatal diagnosis, and they were also offered allogenic stem cell transplant as an option of cure. But 91% of the population, they opted for symptomatic treatment, either because of the lack of donors, financial constraints, and lack of social support. And only 2 people, that is 9% of the population, had undergone an allogenic stem cell transplant. So the median follow-up was around 21 months, which ranged from 1 month to 3.5 years. And there were 11 people who were under follow-up, that is either by in-person contacts or phone calls, of which, that also included a mud transplant recipient who was doing well, except for some grade 3 GVHD, which had settled, and 7 had lost to follow-up, 5 had expired, including 1 haplotransplant recipient who died after 2 years, mainly because of sepsis. So coming to the conclusion, yes. So coming to the conclusion, CGD is not uncommon. Whenever we encounter rare organisms, especially in pediatric population like Burkholderia, Aspergillus, we need to work up for primary immunodeficiency diseases, especially CGD, and all should be offered allogenic stem cell transplant as a curative option, and they should be continued on antimicrobial prophylaxis. Thank you.
Yes, Madhu, this
Yes,
is Manisha here. Yeah, interesting collection of cases. Madhu, I wanted to ask you a couple of questions. You have said your NBT, which is actually considered as a gold standard, either NBT or abnormal DHR as a gold standard for diagnosis of CGD. You had proportion of patients who were negative, proportion of patients who were positive, and some were suspicious. 3 of them were suspicious. So you need to clarify what do you mean by negative, positive, and whether they were abnormal. And in cases where the NBT was now normal, why did you diagnose them as CGD? Another question is, okay, once you answer this, I'll ask the next question.
Because of the 10 people, 3 had NGS, which was positive for the mutations. So the rest of the 7, it was mainly a clinical correlation. Though we didn't have both the NGS and this was not, NGS was not performed, and NBT also did not yield a positive result. But mainly
you
because
cannot consider as CGD unless you have an NBT or NDHR abnormal. You have to show the functional abnormality before you call them as a CGD, unless you have a molecular diagnosis which tells you that it's a CGD. Yes. Another important question that I wanted to ask you is, you have used NGS for molecular diagnosis of CGD. Do you know what is the important drawback of NGS when you talk of Indian scenario when you use NGS for CGD diagnosis?
I'm not aware.
See, nearly 50% of the patients have P47 defect, and nearly majority of, mostly they have a del GT mutation in P47, exon 2 of P47. And
Okay.
P47 has a pseudogene, and NGS cannot pick up this P47 defect. So it is
Okay.
very critical that you know, especially in an autosomal recessive scenario, NGS may not be a good option for diagnosis of CGD. So that is
Okay.
one important thing that you must keep in mind.
Okay.
So women, you have any
So,
other?
yeah, but the first is just to comment that when you are talking of the NGS data, we should say variants and rather than calling them mutations unless you've proven that they are pathogenic. So you should say variants. And the other thing was that quite a huge proportion of the cases you said in the microbial isolates, you said 56.5% were tuberculosis, and you said that most of them were empirical without so I
Yes.
think in isolates, when you say it's empirical TB and then you say that isolates, it's where TB isolates in 56%, I think that data would
No, sir.
be.
No, 6% were empirically treated.
In isolates also you said 56%.
No. Isolates, only two people we had detected TB in the gene expert. Only 2 people.
Well, in the abstract, at least you have said that the common isolates were MTB 56.5%. So that is. So in
Yes,
the
sir, that
abstract
was a
itself, that
mistake
was
in
wrong.
abstract
Yeah,
that
that
I
was
had
a
corrected
mistake
in the
there.
paper.
So yeah, so we have a few questions in the chat box. I think we should go to that. What was the basis of diagnosis in children with the inconsistent NBT? I think that's already discussed with Dr. Manisha. And what was the basis of diagnosis of tuberculosis in CGD patients, as only 8.3% had isolation of bacterium? So I saw that was also empirical, as you said, clarified. So any patients with non-infectious manifestations or colitis, that is asked by Koshi Thomas.
Colitis, no, sir, we didn't have. There were like gastroenteritis presentation on only in 2 people, but there was no specific organisms. We couldn't in the stool workup or we couldn't isolate any organism.
Yeah, Dr. Amit Rawat has again asked the questions. Please clarify what is suspicious NBT and what were the gene variants detected in NGS in the 2 patients with suspicious NBT.
One was the mutation detected was a CYBB mutation, X-linked variant, and the other was a NCF mutation, which was characteristic of autosomal recessive.
Okay. So thank you. I think then we should, there are some more questions. I think you can answer those questions later on in the chat box. You should answer them. Next, I think we should go to the next paper now. We have Dr. Ritika Yadav.
Yes, sir.
Can you have Dr. Ritika?
Yeah. Good morning, one and all. I'm Dr. Ritika Yadav from ICMR National Institute of Immunohematology. I'll be presenting my paper on the utility of HLA-DR evaluation while screening for inborn errors of immunity. A comprehensive evaluation of the immune parameters at the time of screening provide important clues to the underlying primary immune deficiency defect. Although there is a constant debate with the genetics first approach, the importance of a baseline immune evaluation cannot be overemphasized. In 2019, our center adopted a 9-color 13 antibody screening panel, which is modified from the Euroflow Consortium screening panel for the baseline evaluation of patients referred for primary immune deficiency workup. The Euroflow Consortium recommends an 8-color 12 antibody PID orientation tube or the PIDOT tube for evaluation of the main lymphocyte subsets for detailed B and T cell analysis. The difference of our screening panel from the PIDOT tube lies in the addition of HLA-DR to the screening panel. So in our methodology, we, next please. The immunophenotyping data obtained from the analysis of our screening panel for 92 well-characterized patients diagnosed with inborn errors of immunity in 2019 was retrospectively analyzed. The sensitivity of the 6-color screening tube, PIDOT tube, and our screening tube in identifying the IEI category abnormalities in our cohort were compared. HLA-DR expression on B cells, T cells, CD4 T cells, CD8 T cells, NK cells, and monocytes was evaluated, and all values were compared against age-matched reference ranges.
I'll be presenting my result category-wise. In category 1A, we evaluated 13 patients with SCID. 10 on 13 patients had low CD3 T cell counts of less than 300 per microliter, so the diagnosis was straightforward. However, in 3 patients who had presented with a leaky phenotype and Omen's phenotype, additional findings of low naive T cell percentages and elevated HLA-DR gave a clue to the underlying diagnosis. In category 1B, we evaluated 11 patients. Of these patients, there were 2 patients of MHC class 2 deficiency. Absence of HLA-DR expression is central to the diagnosis of MHC class 2 deficiency, which was seen in both of our patients, one of whom had presented atypically with a normal CD4 T cell count. So the presence of low naive T cells and hypogammaglobulinemia, along with low B cells, had given a clue to the combined immune deficiency, and absence of HLA-DR expression had clinched the diagnosis. We had another patient in this category with a atypical presentation. It was the case of ZAP70 deficiency, who had presented with normal T cell counts and normal CD3 helper T cells and elevated CD8 T cell counts. In these patients also, absence of reduced naive T cells and elevated HLA-DR along with hypogammaglobulinemia had given a clue to combined immune deficiency. On comparing the sensitivity of the screening tubes, a significant difference in sensitivity was observed in category 3, which is antibody deficiencies, where the sensitivity of the 6-color screening tube was found to be 60% against the extended panels with a sensitivity of 100%, because CVID may have normal B cell numbers, but the memory B cells and the class switch B cells were reduced. In category 4, again, we in disorders of immune dysregulation, we evaluated 13 patients, of which 4 were HLH, 5 ALPS, 3 LRBA, and 1 CTLA4 deficiency patients were there. And the HLA-DR expression was markedly elevated on CD8 T cells in all our patients of familial HLH, and HLA-DR expression was markedly elevated on DNT in all our patients with ALPS. In 2 on 3 patients with LRBA deficiency, again, the HLA-DR expression was elevated with the reduced naive CD4 T cell percentages. In category 5 and 6, although the lymphoid abnormalities were observed in accordance with those reported in literature, there was no diagnostic utility. In category 7, again, in auto-inflammatory diseases, out of 4 patients we evaluated, 2 patients had elevated HLA-DR expression. 1 had presented with lymphopenia and the other with lymphocytosis at the time of evaluation. Next slide now. So our new screening panel could pinpoint the possibility of an underlying IEI of the lymphoid system with an overall sensitivity of approximately 90%. This helps in making a decision on further evaluation of the patient, including a molecular workup, and is particularly helpful in those cases who present with an atypical presentation, as exemplified by our cases of MHC class 2 deficiency and ZAP70 deficiency. The early diagnosis made in our case of MHC class 2 deficiency led to a favorable prognosis for the patient who underwent HSCT soon after diagnosis and is currently doing well. Comparing the sensitivity of the PIDOT and our screening panel against the traditional 6-color screening panel for the cohort, significant difference was found in sensitivity for detecting combined immune deficiencies, antibody deficiencies, and diseases of immune dysregulation. The utility of addition of HLA-DR to the screening tube was seen especially for patients suspected with combined immune deficiencies, including SCID, specifically the Omen's phenotype, where the increased percentage of memory B cells pointing towards autoreactive T cells along with an elevated HLA-DR can give important clue to the underlying diagnosis. And diseases of immune dysregulation, for example, elevated HLA-DR in patients of ALPS and elevated HLA-DR also in patients of HLH give a clue to the diagnosis. Hence, I would like to conclude that the addition of HLA-DR at the time of screening can give corroborative clues to the underlying immune deficiency and makes the immune evaluation more comprehensive. Thank you.
And do we have the audience? I mean, the judges, any questions?
Yeah. So that was a simple paper, but with a very strong, clear message. Do we have any questions in the chat box for that? No, not relating to this talk. So, so it's good that we could show that the addition of HLA-DR has helped in picking up these cases of Omen's, ZAP70 and ALPS. So apart from these, whatever you have encountered, do you speculate some more disorders that could be picked up with this addition of the HLA-DR into the tube?
So in our experience, what we evaluated, we only found that it is of importance in cases with combined immune deficiencies and disorders of immune dysregulation. We would like to evaluate more patients with autoinflammatory disorders. We had only 4 who had, among whom 2 had elevated HLA-DR. So maybe evaluating more patients could give more insight into that.
Exactly. So does it make a significant difference the cost for the test? I don't think it should.
Not
Did you
really.
really do a calculation on that? No.
I didn't really do a calculation, but addition of one more antibody, I don't think would
Exactly.
really
It shouldn't be. It should. Any more questions we have? Dr. Manisha, you do have any comments for that?
No. We
On
have
this paper?
found HLA-DR extremely useful in these situations.
Exactly.
We
Yeah.
had a screening tube, so I think that is a useful addition. Yeah. We can go
So
to
we'll
the
have to.
We can go to the
we'll have
next
to move
one.
on because we have 4
Yeah.
left and we have
Yeah.
less time.
Yeah.
Yes.
Let's move on to the next.
Dr. Dhanya. Dr. Dhanya, are you there? No. Dhanya was there? Not there. Okay. If she's lost, we can move to the next then. Dr. Dhansuraj. Dr. Dhansuraj?
Hello, ma'am. Hello. This is Dharmiya, ma'am. I was actually unable to unmute. Yeah, sorry about that. Yeah. Yep. Okay, ma'am. Shall I start? Yeah.
We are already late. So quick.
Yeah. At the outset, I would like to thank the organizers and judges for giving me the opportunity to present our experience on using exome sequencing for genetic evaluation of type 1 interferonopathies. Next slide, please. So, exome sequencing has emerged as an efficient tool for molecular diagnosis of Mendelian disorders, and this unbiased technique has the power to identify novel as well as known disease-causing variants, especially in genetically heterogeneous monogenic disorders. Type 1 interferonopathies are a heterogeneous group of autoinflammatory disorders characterized by overactivation of type 1 interferon signaling. And till date, the genetic basis of around 15 different types of interferonopathies are known. Next slide, please. We conducted a retrospective study of all the families who underwent exome sequencing at our center from January 2015 to June 2020 to identify families with a disease-causing variant in genes implicated in type 1 interferonopathies. Next slide, please. During the study period, 614 families underwent exome sequencing and a molecular diagnosis was established in 408 families, which is around 66%. We identified 7 families with a disease-causing variant in one of the genes implicated in type 1 interferonopathies. So 5 of those families were diagnosed to have Aicardi-Gautier syndrome type 3, and 1 family had Aicardi-Gautier syndrome type 1, and 1 family had Singleton-Merten syndrome. Next slide, please. So 5 of the 7 families had a known homozygous pathogenic Asian founder variant C.205C2T in RNA SEH2C gene, which causes Aicardi-Gautier syndrome type 3. So the details of 3 of these families with 4 affected individuals were published previously. All the 4 affected individuals had early onset encephalopathy, seizures, neurodevelopmental delay, spasticity, delayed myelination, hypoplastic corpus callosum, white matter abnormalities, and intracranial calcification. Serum and CSF alpha interferons were actually available only for one of the proband, and that was normal. And the proband in family 2 had associated hypothyroidism. Endocrine abnormalities, including hypothyroidism and diabetes, are known to occur in Aicardi-Gautier syndrome and were previously described with TREX1 variant. And this was the first instance where hypothyroidism was reported to be associated with RNA SEH2C variant. We did not observe any intrafamilial variability among the 2 siblings that we identified in family 3. And in another, in the second, so there was another consanguineous family where the 1-year-old proband, in addition to the Asian founder variant, had 2 novel variants in another gene known as VARS1. And this variant was not observed in any of the population databases, and it was absent from our in-house exome data of 927 individuals. And both these variants were predicted to be actually disease-causing, and this variants in biallelic variants in VARS1 are known to cause neurodevelopmental disorder with microcephaly, seizures, and cortical atrophy. The dysmorphic features that this proband had, including sloping forehead, micrognathia, short nose, flat nasal bridge, and long eyelashes, were similar to those previously reported individuals with variants in VARS1. but the clinical findings did overlap with Aicardi-Gouthier syndrome 3 and could not be independently correlated with the proband's phenotype. So we classified those novel variants in VARS1 as variants of uncertain significance. And in the family where Singleton-Merten syndrome was diagnosed, the 7-year-old girl presented with short stature, facial dysmorphism, which included thin upper lips and smooth philtrum, failure to thrive, and acro-osteolysis. And initially, a diagnosis of Winchester syndrome was considered, but exome sequencing helped in identifying a known heterozygous pathogenic variant in IFIH1. And this variant was inherited from her father, who also had a short stature, and both of them later on retrospective analysis or retrospective phenotyping of these patients, we identified that they also had extensive calcification, aortic calcification. Next slide, please. So to conclude, exome sequencing aids in molecular diagnosis in clinically and genetically heterogeneous conditions like type 1 interferonopathies, and identification of population-specific founder variants may be used for devising appropriate genetic testing strategies. Exome sequencing sometimes may aid in identifying multiple Mendelian disorders, which would actually have an impact on genetic counseling as well as recurrence risk for a family. Molecular diagnosis is essential to establish diagnosis as well as to provide genetic counseling to families. Thank you.
Yes, Danya, it is a very interesting presentation. Yeah, interesting cases.
Thank you, ma'am.
I have a couple of questions that I want to ask you. I just want to understand, you have said the whole exome is useful for diagnosis of interferonopathies, and I think there is no second doubt about it. But what was your yield of whole exome sequencing? Suppose you sequenced 150 cases of suspected interferonopathies. In how many did you get an answer? And what was your approach for functionally validating the variants of unknown significance?
Okay, ma'am. So actually, we during the study period, we what we have done is we have tried to take identify all the families where we already got a variant in one of the genes implicated in type 1 interferonopathy. So our yield of using exome sequencing for all the disorders together is around 66%. Like over the last 5 years, yeah. But specifically for type 1 interferonopathy, I do not have a I do not have a particular value to comment on that.
Okay. And how did you functionally validate or it was only clinical correlation or any other test?
Yeah, ma'am. So so in the families that we have described here, in the families with RNA-SH2C variants, that variant was actually a well-known established founder variant in South Asian population.
Okay.
So, and then we had, we did not actually identify any novel variant in the family that with TREX1 also, that variant was a duplication, and that was also a disease-causing variant. And in IFIH1 also, that is a single heterozygous known variant, which has been previously validated to cause Singleton-Merten syndrome.
There are a couple of questions in the chat box that I'll ask you. Dr. Amit Rawat has asked, how was type 1 interferon measured in one patient in which it was done? And what is the, again, functional validation? I think that is another important.
Yeah, ma'am. So we had a value for serum interferon and CSF interferon only in one of the patient, and that apparently was they had done from outside, and that child had actually expired by the time they brought the reports of the family. And apparently here in the cases that we presented, all the variants that we got in genes with type 1 interferonopathy were established known variants.
Okay. So, Miman, you want to ask any questions or we can go to the next presentation? I think we can go on to the next presentation. Thank you.
Thank you, ma'am. Yeah. Thank you.
Hello. Am I audible?
Yes.
Please. Yes. Myself, Dhanush Suraj from Government Medical College, Kozhikode. Actually, this work is a result of a wonderful collaboration between different institutes listed here. It's difficult to mention all of them because in a short time. But I must be thankful to Dr. Geeta Kongraj from Government Medical College, Kozhikode for allowing me to present this work here, and Dr. Vinoskaria and Dr. Sridhar Shivasubbu from IJAB and all team from IJAB for their as all of you know, XLA or X-linked gamma globulinemia is an X-linked recessive primary immunodeficiency disorder. It is marked by the failure of maturation of B cell precursors to plasma cells, less or low immunoglobulins. The pathogenic variant in this disease is mainly BTK gene, which is positioned, which is in the X chromosome, and it consists of around 19 exons and 337 kilobase pairs. The incidence of the disease or XLI is 1 in 379,000 live births, while in male births it is 1 in 190,000. And delayed diagnosis and suboptimal access to treatment are main hurdles, especially in developing countries. So here in this work, we present a first case series of 17 patients from 10 different families from South Indian, that is from Kerala. Next slide, please. So the methods includes, we included 2 or more Jeffrey model warning signs showing patients. So initially we did complete CBC and nephrometry for the calculation of or identification of immunoglobulin levels. Lymphocyte subset analysis and BTK protein expression were done using flow cytometry. And from which we identified that patients which less than CD19, less than 2% of CD19 or B cell deficient patients. Those were around 17 patients. We did 15 for 15% whole exome sequencing, while for 2 whole exome genome sequencing. So this procedure identified many variants, disease specific variants, and those were later verified by also were screened using Sanger sequencing. Some mutations, which are like some variants like deletion, cannot be verified by Sanger. So we did MLPA assay using the genome sequencing, and MLPA assays were done at IGAB. Thanks for their support. Next slide, please. Next slide, please. Thank you. So the result showing that patients show this are classic symptoms of XLA, and we showed that resulting HLA usually be after the ceasing out of material antibody. So age of onset of the symptoms usually within 1 year, but in our conditions you can see that age of diagnosis usually 7.2 years for patients with the clear family history, and for others it's around 4.7 years. And the variants we identified by next generation sequencing included 10 unique pathogenic variants, and out of which two were novel. So identification of these novel variants and pathogenic or pathogenic like variants resulted in helping IVIG support or hematopoietic stem cell transplantation, which saved around 15 patients of ours. They are living normal now. And 2 of where children succumbed with some conditions. So this is a graphical representation of our conditions in patients. We can see that recurrent pneumonia is one of the main things, and recurrent diarrhea is a classical like XLA symptoms. And the average number of hospitalization for our treatment in case of many people is around 12 per child, and it was due to bronchitis. And lower window show that main variants observed in the BTK gene as well as adjacent gene. We found 2 large deletion. We can show that deletion around exon 3 to 5, and another large deletion covering under 6 to 19 exons and another adjacent gene. Next slide, please. So this study characterized the clinical and genetic features of patients' family groups from South India. This underscores the pure availability of diagnosis facility and the lack of awareness among clinicians. So if the awareness can be increased, that will be helpful to the management of disease. The study could help in better recognition of patients with XLA and help their family also screened even prenatal diagnosis. To our best of knowledge, this is the first case study like this one from South India. Thank you for listening to me.
Thank you, Dharna Suraj. Yes, Dr. Manish. So, sorry, I was not able to unmute in the previous presentation. So there was a glitch
No
there.
problem.
Yeah,
Go ahead.
yeah. So, Dr. Dharna Suraj, in those patients where you had normal immunoglobulins and in one case you had hyperimmunoglobulins. So, how do you explain that part?
Though those variants were not severe in those cases, first of all. That variant, the pathogenicity of those variants were less in those cases.
Okay.
So the BTK gene can be expressed little bit, so the level of immunoglobulin will be normal.
But they had absent B cells?
Yeah, in some cases, we included less than 2% B cells is there.
That they do the BTK.
One more question, Dr. Dhansuraj, is your median age of diagnosis in patients with positive family history was more than the ones without family history. Why is that?
This is the result of a study for the last 5 years. We find patients.
That is a little unusual because especially when you have a positive family history, the next sibling gets diagnosed a little earlier. So that was one just.
Yeah, we find the history.
So we have some.
It is the last 5 years studies there.
So we have some questions in the chat box. How do you explain the normal or high IgG in XLA? So that is, and how was the large exon deletion detected? Is another question there. So, and what was the BTK protein in these patients? So I think there are a lot of queries in this paper. So I think you can answer those questions later on because we are running out of time, and we'll move to the next paper. Thank you so much. Next, we have Dr. Harika. Can we have Dr. Harika?
Yes, good morning, sir.
Good morning. Please start.
Good morning, everyone. I'm Dr. Harika from Pediatric Blood and Marrow Transplantation Unit, Apollo Cancer Center, Chennai. I would like to thank the organizers for giving me this opportunity to present our data on hematopoietic stem cell transplantation in children with neutrophil disorders. Next slide, ma'am. So as we all know that children with phagocytic or neutrophilic disorders like chronic granulomatous disease, leukocyte adhesion defect, and severe congenital neutropenia present with recurrent life-threatening bacterial and fungal infections. And hematopoietic stem cell transplantation is an available curative option. So early HSCT can result in intact disease-free survival in these group of children. We performed a retrospective study from March 2013 to September 2020 in children with neutrophilic disorders up to 18 years of age, and the minimum age was 5 months. Among the 25 children included, 14 children had chronic granulomatous disease, 8 were having a leukocyte adhesion defect, and 3 with severe congenital neutropenia. The male to female ratio was 1.3:1, and the median age at transplant was 3 years. And mention about the infant age group, there were eight children in less than 1 year age group, and more than 1 year age group, there were 17 children. Next slide, ma'am. With regards to chronic granulomatous disease, all the children presented with some form of disseminated BCGosis or tuberculosis who required anti-tubercular therapy, and all had staphylococcal pneumonia at least 2 to 3 times prior to the transplantation, of which 13 children out of total 14 CGD children required ventilation. And with regards to leukocyte adhesion defect children, all the children presented with non-healing ulcers, out of which 50% required stabilization with anti-staphylococcal antibiotics and buffycoat infusions prior to the transplant. While regards to severe congenital neutropenia, all children presented with at least 3 severe febrile illnesses per year before the transplantation. The conditioning which we used was myeloablative conditioning in 88% of the children, which was predominantly triosulfan based. With regards to donor characteristics, 13 children underwent matched family donor transplants, and 5 underwent matched unrelated, and 7 underwent haplo transplants in our cohort. In haploidentical transplanted children, 5 children underwent TCR alpha beta depletion. Ma'am, sorry, previous slide, ma'am. Yes, ma'am. And 2 children underwent post-transplant cyclophosphamide they received after the infusion of the stem cells. And our major source of stem cells was peripheral blood stem cells, which was 80% in our cohort. 28% of the children had cytomegalovirus infection post-transplant, but all were responsive to ganciclovir. And with regards to engraftment, total 24 children engrafted out of the 25 children who were transplanted. 1 child has primary graft failure, and 3 children had secondary graft failure post engraftment among the 24 who had engrafted. Graft versus host disease. Acute GVHD was predominant at 64% in our cohort, and chronic GVHD was seen in 7 children. Grade 1, grade 2 were in 44%, and grade 4 was in 31% of the children. With regards to age, graft versus host disease was higher in children who were transplanted more than 1 year of age group. That is, 14 out of 16 children had graft versus host disease, and all the children who had grade 3 and grade 4 graft versus host disease was in the age group of more than 1 year, and it was statistically significant with p-value of 0.01. Next slide, ma'am. The overall survival was 72% in our cohort with mean survival time of 74 months. With regards to individual diagnosis, the overall survival was highest in LAD group at 87%, followed by severe congenital neutropenia, which was 66%, and chronic granulomatous disease of 65% in our cohort. The lessons which we have learned was there was a superior survival in children who underwent transplant in infancy, that is 87% versus 65% who had transplant more than 1 year of age group. And there was an increased risk of mortality in children who had increased pre-transplant infections. And HSCT achieved cure in children with these type of neutrophilic disorders with best outcome in leukocyte adhesion defect children. And outcomes were superior in children who were transplanted as early and most preferably less than 1 year of age group. And haploidentical HSCT using TCR alpha beta depletion is safe in infants with these group of children. And early referral for HSCT is the key to intact survival in these set of children. Thank you, everyone. I would like to thank the organizers, the patient families, doctors, physicians, and nurses for this opportunity. Thank you.
Thank you, Dr. Harika, for that nice presentation. So maybe we can take a few questions. There was a question in a chat box by Dr. Umair. Was there a difference between the outcome for AR and X? No, that was for the previous paper. So this is, do you screen for CMV before all transplants, Naveen? Do you screen for CMV before all transplants? That is the question. Hello?
Yes, Dr. Harika, can you hear the question? Do you screen for CMV before you do transplants?
Sorry, ma'am, I was unmuted. Yeah, and
okay.
Yes, we screen for CMV in every child prior to transplant in our center, ma'am. Especially this immunodeficiency children, we screen for viral infections prior to transplant.
Okay. Any more questions?
Yeah,
Dr.
I think
Manisha?
Umair has asked one question, whether the outcome of autosomal recessive versus X-linked CGD transplant was different.
In our cohort, we didn't look at that thing, ma'am, but we can get back, ma'am. But in our study, we did not look specifically with regards to autosomal recessive and X-linked.
So what are your criteria for selecting a patient with CGD for transplantation?
Any child who has genetically proved CGD with recurrent infections and failure to thrive and recurrent infections, continuously not responding with prophylactic drugs, we generally take to transplant in our center.
Okay. Because already we are running late. Your study was really nice, Harika. I think we'll go on to the next presentation. Thank you.
May I present, ma'am?
Yes.
Yes, please go
Good
on.
morning, everyone. I am Satish Meena from Apollo Cancer Center, Chennai. Thank you, ISPID, for this opportunity for sharing our experience on hematopoietic stem cell transplantation for very early onset inflammatory bowel disease. Inflammatory bowel disease, when it presents in children of less than 6 years of age, it is called very early onset IBD. In 1/4 of cases, it is associated with a primary immune deficiency, and hematopoietic stem cell transplantation is a curative option available. T and B cell defect like viscoelastic syndrome, genetic immune dysregulation like IPEX syndrome, phagocytic defects, and autoinflammatory conditions like LRBA defects. These are some inborn errors of immunity which can present with very early onset IBD. So we performed a retrospective analysis from January 2013 to January 2020 at Apollo Hospital, Chennai, in children with PID who presented with very early onset IBD and who underwent hematopoietic stem cell transplantation. Next. So in this cohort, we included 14 children. There was male preponderance in the cohort because of X-linked inheritance of a few of these disorders. Most of the children, they presented in the age group of 28 days to 2 years. One child with leukocyte adhesion defect presented with neonatal IBD. We transplanted 3 children for interleukin-10 defect, 3 for Viscott-Eldridge syndrome, 2 for hyper-IgM syndrome, and 1 for each leukocyte adhesion defect, hyper-IgE syndrome, IPEX syndrome, LRBA deficiency, congenital neutropenia, hyper-IgM. Though IBD was only one aspect of the clinical spectrum, these children, they had recurrent infection, failure to thrive, and skin lesions, and other symptoms also. Though recurrent diarrhea, though recurrent diarrhea was present in all of the children, the typical stool mixed with blood and mucus was present in 1/3 of the children. Next slide, please, ma'am. We transplanted 5 children with matched family donor and 3 children with matched unrelated donor, and maximum transplant were done from an haplo-matched donor. As these children are already malnourished and there is inflamed gut and there is altered gut flora in these children's intestines, so we chose a conditioning regimen which has minimal gut toxicity. When we use reduced intensity conditioning regimen in these children, there is a risk of rejection because the underlying etiology, underlying pathology is immune dysregulation. So we chose a reduced toxicity conditioning regimen containing fludarabine, pyrosulfan, and thiotepa in majority of our children. We use peripheral blood as a source of stem cells in majority of children to ensure rapid engraftment, and we infuse 7 to 8 times of CD34 cells. The graft rejection rates were as high as 21.4%, and the mean time period for neutrophil engraftment was 12 days. Among the children who engrafted, half of them developed GVHD, and in the background of an already inflamed gut, the gut GVHD was the most common organ involved in graft versus host disease. CMV reactivation was seen in 3 children. Next slide, ma'am. The overall survival was 64.2%, and the children who had mixed chimerism, 1 child died because of late sepsis and 1 because of late graft rejection. 3 children, they died because of primary graft failure. Next slide, please, ma'am. So the lessons we learned during transplanting these children, then that we should take time to stabilize a child before transplantation. Like steroids, we can use in Viscott-Eldridge syndrome, abatacept in LRBA defect, and in hormone replacement for IPEX syndrome. Very early onset IBD is associated with immune dysregulation, and it requires myeloablative conditioning regimen. Triosulfan has a limited extramedullary toxicity, so it is preferred over busulfan. High rate of graft rejection, and so stem cell dose requirement is also high. Poor general condition and poor reserve results in intensive supportive care. So these children should be supported with parenteral nutrition, with partial alimental feed, and all the micronutrient replacement should be addressed. Platelet cutoff should be kept above 30,000 to prevent any GI bleeding. Hypocalcemia, hypomagnesemia, hypokalemia, all electrolyte disorders, all electrolyte imbalance should be corrected. Perineal care is very important because it can lead to ulceration, and also it can result in GNB sepsis. Next slide, ma'am. On follow-up, all of our children who had complete chimerism, there was resolution of GI symptoms. Children started thriving well. All infections resolved. Perianal take that is associated with interleukin-10 defect healed with hematopoietic stem cell transplantation. Particularly in IPEX syndrome, autoimmune and GI symptoms improved, but endocrinopathies persisted. Next slide, ma'am. I would like to conclude that we need to raise awareness among primary physicians on this rare disorder. Children with PID and very early onset IBD have dismal natural course, and early transplantation has proven to be effective in improving prognosis. This transplantation results not only in resolution of the inflammatory bowel disease, but also the associated immune deficiency and autoimmune disorders also. I would like to end my talk by placing my sincere thanks to the patient family, to the donors, and to the treating physician and the amazing nursing team. Thank you.
Thank you, Dr. Meena, for that excellent presentation. I have one question for you. This is regarding that the patient with STAT3, I mean the hyper IgE syndrome. That was intriguing. So what was this patient presentation like?
Hyper IgE syndrome, these children presented with skin eczema, and mainly the child referred to us with skin eczema and recurrent diarrhea.
Because in hyper IgE syndrome, IBD doesn't figure in the common this thing. It's more in the gain of function mutations of STAT3 that you see very early onset IBD. So was it a gain of function mutation by any chance?
Yes, sir. All our cases in which we included in this cohort, 14 children, we diagnosed for genetic mutation, sir. All the cases were proven by genetic mutation on this.
So this could be a gain of function mutation then, quite possible, because looking at the presentation.
Yes, sir.
Any more questions? Anything in the chat box? No. Dr. Manisha, any comments?
I just wanted to ask you, Dr. Meena, first of all, a very nice lucid presentation, interesting case series. What I wanted to ask you is how did majority of these patients have underlying primary immunodeficiency, which is not necessarily predominantly manifesting as IBD. So how did you differentiate your chronic infectious diarrhea versus IBD in these patients, and how did you label them as IBD?
Sir, ma'am, thank you for the question, ma'am. Majority of these children, ma'am, they had some autoimmune feature like skin eczema, and also that typical blood and mucus mixed diarrhea. And we, the primary few LRBA defect in these 3 children, which primarily they refer to gastroenterologist, ma'am. There they diagnosed as IBD. From there, and they were started on elemental feed and NG feed. Then they was referred here, and then we further evaluated them for the primary immune deficiency due to strong clinical suspicion. And then we found out that it is associated via IBD with primary immune deficiency.
Okay, thank you. I think with the interest of time, we'll stop here. It has been a very interesting session. All the presentations were excellent, and it just shows the quality of presentations. Every year it is improving. We had this session particularly case series and selected for all presentations, and they were really fantastic. Yes, over to you, Dr. Amit.
Thanks a lot, Dr. Biman and Dr. Manisha.
Thank you.
Conducted
Thank you
the
so
session
much.
so well. And to the participants who have really presented excellent work, which they have been doing for years. It's not easy to collect data and to present in a 5-minute presentation. So I thank all of you. And we move on to the next
more time. Yeah. Thank you.
Yeah,
Thank you so
next
much.
time we keep 1 hour.
I know.
But I think we need to have one meeting where we have only the free papers where people present.
But we are most time pe tha, only 5 minutes. Yes. Yeah. Thank you so much. Thank you.
Thank you.
Chairpersons have done a great job, kept to time. So we move on to the next session, which is a thing which we are facing in the clinic every day. So Dr. Shubha Khatke, who is the head of Department of Medical Genetics at SGPGI, will be chairing this session, and she'll be introducing the speaker, Vinod Skaria. Over to Shubha.
Thank you, Dr. Amita. Very interesting conference. I'm enjoying since yesterday. Of course, a lot of things we hardly know about so much of developments in immunology, but NGS really has changed the diagnosis of monogenic disorders of all systems, including immune system. So now in this session, we have an expert, Dr. Vinod Skeria, a fellow of Royal Society of Biology, who is a scientist at CSR Institute of Genomics and Integrative Biology and adjunct faculty at Indraprastha Institute of Information Technology in Delhi. Everybody who is working in NGS must have read his book, and he is known for sequencing the first Indian genome. He is pioneer in the area of clinical genomics in India, and they have formed a large clinical network in area of rare diseases labeled as Guardian. His special interest in immunodeficiency diseases is also well known, as we have seen some papers with his collaboration in the previous sessions. And he has recently described a large cohort of hyper IgD syndrome. So NGS is like a miracle in diagnostics of monogenic disorders, but the dark side of it is if you get to see VUS, and then really it's a challenge for the clinician as well as the laboratory person. So Dr. Skeria is the expert in NGS, and I think he will make us the task of dealing with VUS easier, and I request him to deliver his talk. Thank you.
Thank you, Professor Phadke, for the nice introduction, and thank you, Professor Amita Agarwal, for inviting me here. So over the next 20 minutes or so, I took also the liberty to change a bit the title of my talk, because I'm sure a lot of students out here would really be worried what VUS is all about. So I will probably over the next 20 minutes or so give a very broad overview of analyzing and interpreting clinical variants, touching upon a few factors that are very important while annotating these variants, and also some examples of how we have gone about doing clinical validation of such variants of unknown significance or uncertain significance. I will not really touch upon PID specifically, because of course there are a variety of other talks out here. Now, for all clinicians out there, there are a variety of clinical conditions that come to you. A vast majority of them could be because of environmental influences like infections. A small amount of them could be because of pure genetic conditions where PID and autoinflammatory diseases or syndromes could fall in. Now, there's a vast variety in the molecular pathology of these disorders. On one end of the spectrum, you talk about complex and common disorders, and the other end of the spectrum, you talk about rare and simple Mendelian disorders. Now, broadly, you need to classify these disorders based on the effect size, or what we call as the odds ratio, or the relative risk of a genetic variant in the causality of the disease. And of course, on the other end of the spectrum, you could classify them by the frequency of genetic variants as they occur in different populations. So as you see here, on one end of the spectrum, you would have common disorders which are caused by common variants, but each of these variants have very small effect sizes or relative risk. And then therefore, these are not really the causative variants, or they're multiple variants which come together to sort of be associated with the disease. On the other end of the spectrum, you have rare genetic condition, or what we call as Mendelian genetic disorders, where the effect sizes are enormously large, or in other words, if you have the genetic mutation in an individual, you would be able to predict with very utmost certainty that the individual will develop the disease. Now, the methods and tools to look at such conditions and the genetic test or approaches to understand such conditions are also distinctly very different. For common disorders, at least in the research domain, we use an approach called the genome-wide association study. The principle of this is that you have SNPs or polymorphisms spaced across the genome, and you look for associations of these genetic variants. On the other end of the spectrum, what we use is sequencing. This could be a gene sequencing, this could be an exome or a panel sequencing, this could be genome sequencing, and so on and so forth, to be able to understand the causal genetic variant and be able to identify the molecular pathology. Now, when we come to genetic testing, there are of course a variety of genetic tests that are available, and what you need to keep in mind is that you need to test appropriately. You should not test less, you should not test more, you should actually pick up the right test for the kind of condition that you come across. So broadly, this test can be dependent upon the specificity of the locus. So if the disease has a very specific locus, the best examples would be, for example, XLA, X-linked gamma globalinemia. It has a very specific locus. It is in the BTK gene. it's on the X chromosome. So in that particular case, you need to test only for the gene if that test is available. Now, depending upon the specific locus, you could also have different kinds of tests. You could have mutations which should be screened if they are single mutations or small insertion deletions, or if you have large deletions, like for example, in at least some cases of XLA, you could use an approach called MLPA to query or assay for specific deletions. Now, there are a variety of conditions where there is no one gene, there are multiple locus which are influencing that particular gene or disorder. Then what you do is to use targeted panels, and targeted panels are of multiple different varieties and comes in different shades. On one end of the spectrum, you would have small gene panels, you could have clinical exome sequencing, you could have whole exome sequencing, and in some cases, you might approach a whole genome sequencing because none of the above worked. So depending upon the specificity of this phenotype and some a priori information about what are the kind of genetic variants that occur in a particular disease, you could select what is the appropriate test. Now, on the extreme right end of the spectrum, you would have a very specific set of tests which are very widely used, and these are for chromosomal abnormalities. So these are much lesser resolution, but can cover a large amount of the chromosomal region, and these are typically limited to syndromic occurrences of diseases where we know that there are very specific abnormalities in the chromosome structure or organization which can cause a particular disease. Now, so what you need to keep in mind is that depending upon the disease, you need to pick the right test and administer the right test. Now, the problem in many clinical situations is that you don't administer the right test. I'll give you an example. And this is an example from very early on. And this is, I believe, from 2015. And these patients were referred to us by a dermatologist from D.Y. Patil Hospital. Now, as you see here, there are two kids. One kid was 8 years and the other kid was 12 years. They were tested at multiple different places before, and it came with an abnormal chromosomal karyotype with a 22q12 duplication. Now, is this the test of choice for lamellaichthyosis? The answer is probably no. And this also probably points us to another important factor, is that two children affected with a similar genetic disease would also mean that genetic counseling was never probably appropriately provided to these children. So the appropriate test for this condition is probably a small gene panel or a whole exome sequencing because there are 9 genes which are involved in lamellaichthyosis. The whole exome sequencing was done, the mutation was identified, a Sanger sequencing test was provided, and of course, kids with TGM1 mutations could respond quite well to retinoic acid. And as you see here, an appropriate genetic test might actually save a lot of money, a lot of time, and provide appropriate treatment to the children, but not just that, can provide evidence-based genetic counseling, and the family could have a perfectly normal child. Now, depending upon this test that you administer, there are a variety of tests that are now available, and I'll at this moment delve just about sequencing-based tests. On one end of the spectrum, you have single gene test when there is a single gene that causes the disease, things like sickle cell anemia or thalassemia. You don't do an exome sequencing, you do just that gene sequencing. When the clinical diagnosis is accurate, a specific locus is known, this is what you do. On the other end of the spectrum, you have what we call as panels. Panels come, as I said, in multiple different shades. There could be small number of genes in a panel, like for example, cardiomyopathy panel or primary immunodeficiency panel, or you could do whole exome sequencing, which is in some ways also a panel testing, depending upon the genes that are in there. And this is typically when you have multiple genes or multiple gene locus which cause a disease. And it is very effective and in terms of time and in terms of cost, because it covers a large number of genes all in one single shot. And then therefore, it's a very useful approach when you have multiple genes or loci involved in a disease. On the extreme right end of the spectrum, you have what we call as whole genome sequencing. It's not really applicable in clinical situations yet, at least in India, but there are now in many countries where whole genome sequencing has become the mainstay. And this is extremely useful in undiagnosed genetic conditions where you have exhausted all the other opportunities. And the advantage being that it is all tests combined into one. And the limitation, of course, is that it's still expensive, at least twice expensive today as a whole exome sequencing test. Now, after you do a sequencing test, what do people do? What they do is essentially the reads that are generated after next generation sequencing are aligned to the reference genome, And depending upon the positions at which they align, and depending upon the positions at which they are different from each other, you call what we call as genetic variants. Now, genetic variants are typically filtered, and there are a variety of approaches to filter genetic variations. And the commonly used approaches to be based on the phenotypes of the genetic disease, and they are then further evaluated to understand the clinical impact. And then a report is prepared and handed it over to the clinician. And that's when the clinician gets a report and sorts of looks at it. Now, there has been a paradigm shift, at least in the very recent past, in the way genetic testing is done. Typically, in a clinical setting, what a clinician does is looks at the patient, makes a mental map of the disorder or the spectrum of disorders that could be possible. A specific clinical genetic test is ordered. The variance that sort of maps the phenotype is sort of interpreted, and then a clinical decision is made. Now, there are of course very big fallacies to such an approach, because you always try to look for a variant which can explain the phenotype, which in many cases may not be the right way to do. So there is now what we call as evidence-based genomics, where the genetic test is first done, and then the evidence on each genetic variant is evaluated, and then a clinical interpretation is done. And in many ways, this is statistically more robust, because this is essentially evidence-based. And there's a reason why such an approach is increasingly being used. And the reason is that we think that whole genome sequencing is increasingly going to be the mainstay of genetic testing. And to give numbers, today there are close to around 15 million genomes that has been sequenced across the world, compared to just less than a million genomes that has been sequenced for rare genetic conditions. So in other words, a far more number of individuals who have a genome that is available, who don't have a clinical phenotype yet, than individuals who have been sequenced based on a clinical phenotype. Now, of course, this has many advantages, and one of the advantages is that it is fast. Today, a whole genome sequencing is much faster than a whole exome sequencing, and probably we expect that in a year or a couple of years, whole genome sequencing and whole exome sequencing would approximately become at the same cost. And then, of course, this has a lot of advantages, because there are time-critical applications like neonatal ICUs, and, for example, primary immunodeficiencies, where diagnosis and early diagnosis is really, really important. Such methodologies could really become the mainstay of clinical genetic testing. Now, once you have the genome information or genomic variants, you need to evaluate evidence. And what we use to evaluate evidence globally is what we call as the ACMG and the AMP guidelines. Now, the ACMG and the AMP guidelines are based on approximately 8 major domains, encompasses 28 standard attributes. And using these attributes, you can eventually classify a genetic variant in one of the 5 categories: pathogenic, likely pathogenic, benign, likely benign, and VUS, or variants of uncertain or unknown significance. Now, these domains can largely be divided into 2 classes: one which are based on databases or a priori information. This includes computational tools, which includes type of the genetic variant, which includes population frequency or allele frequency of the genetic variant. And of course, there are also information which are dependent upon the protein or the data or the protein domain information for each of these genetic variants. So depending upon them, there are around 17 attributes which can be classified extensively based on computational tools and computational databases. And of course, there are another 11 attributes of this 28, which extensively come from either functional studies. Functional studies could be in vitro or in vivo studies, in cells or in whole organisms. They could be familial segregation studies, which are based on extended pedigree analysis. There could be association studies, and of course, the allelic effect studies, which are in many ways based on the extended family analysis to establish whether the variants are in cis or trans. So when a clinical interpretation of a particular variant comes to us, and you have reached to a point saying that it is a VUS, there are only very few things that you can actually add value in terms of adding evidence to change the annotation. And first and foremost of this is functional studies. And there is no rule of the thumb on what is a functional study that you need to do. There are a variety of functional studies which could range from expression studies of the RNA, expression studies at the protein level. This could be cell-based or morphological studies. That could be whole organism studies when, for example, you sort of look for an organism pathology. And of course, what is really more important and clinically applicable in most cases is familial segregation studies. There are a variety of approaches you could do this, either by evaluating an extended pedigree of individuals in the same family, or sharing information with other clinicians who would have observed other families changeable as the population allele frequency resources, which could be made better. And of course, I will delve a bit deeper into it a few slides from now. I'll give a few examples, probably just 2 examples on how we sort of approach such a problem. This is one such example which has been extensively worked up by multiple different departments from the All India Institute of Medical Sciences in Delhi. A child, the first born child of a family, with apparent mitochondrial disorder, multiple tests showing mitochondrial disorder. Mitochondrial sequencing was, of course, the first line of choice, but of course it revealed nothing. So we went ahead and did a whole exome sequencing, which also revealed nothing. So the rule of thumb is that if you have exhausted all the other options, probably do a whole genome sequencing. We did a whole genome sequencing, and what we found was a chromosomal deletion, a small deletion of approximately around 142 kb, which is homozygous in the child. Of course, we could not save this child, but of course the family went ahead and did have another pregnancy, and that the child was also tested positive for this homozygous deletion. Now, does it prove that the homozygous deletion causes the disease? The answer is no, because one, this is a mitochondrial disorder, so we expect to have a mitochondrial pathology. Second, you have a homozygous chromosomal deletion. We have never observed this before. Doesn't necessarily mean that that is a pathogenic variant. So the only way in such situations to actually establish a pathogenicity is to actually make the exact same chromosomal deletion in a model organism. So that is number one opportunity. What we use is zebrafish. Zebrafish essentially has homologs for almost all genes in humans, or almost all disease-causing genes in humans. So we could make the exact gene mutation or deletion using a CRISPR-Cas technology, and therefore go back and evaluate the phenotype of zebrafish. The second approach you can do is, of course, much more laborious. You can isolate fetal skin fibroblasts. You can culture them and to do a mitochondrial assay. And here is what you see in the mitochondrial assay. The mitochondrial respiratory chain was critically shut down in the fetal fibroblasts compared to the normal controls. So put these two evidence together, that is functional evaluation of the chromosomal abnormality, we sort of substantiate that chromosomal small deletion of 142 kilobases can cause a mitochondrial genetic abnormality. Of course, we could go back and prove that this particular gene is involved in mitochondrial respiratory chain. There are a lot of chromosomal genes which are now implicated in mitochondrial disorder. And of course, you could build a MLPA assay for this very specific chromosomal abnormality. And then therefore, for the further pregnancies, you could apply this tool to evaluate the products of conception, and then
We seem to have lost some connection with Dr. Vinod.
Yeah, he's frozen.
Yeah, Vinod, you're back. Yeah.
Oh, okay. Yeah, so this is the second family, and this family was referred to us from the Christian Medical College, Vellore. And this was a 29-year-old male who complained of intermittent periodic fever for the last 5 years, multiple rounds of diagnosis or proved nothing. And this was referred to us with a provisional diagnosis of periodic fever. Now, the index case is marked in here. We did an exome sequencing for this family, and what we found was nothing. So only a heterozygous variant in the MEFE gene causing familial Mediterranean fever. Heterozygous variants do not cause familial Mediterranean fever because it's a recessive condition. Now, on close examination, what we realized is that we missed the variant because this was essentially a biallelic variant, just one nucleotide apart. Most of the variant callers that we use in next generation sequencing would not call such variants. So manual inspection, one nucleotide apart, and as you see here, they're mutually excluded in the alleles. We did an extended family pedigree and analysis, which suggested that one of the variant was paternal, the other one is maternal, sort of establishing the pathogenicity of this variant. And of course, there are also additional things that you can do, which doesn't really impact the assessment of the variant, but also in terms of proving that this variant had, or this individual had a different ancestry, this individual had actually a Middle Eastern ancestry. So genomic evidence can actually be put into context to sort of establish such ancestry and to also sort of give additional evidence that this is the variant that we're sort of looking forward to. Now, the other thing that you need to keep in mind is that a lot of clinicians out there categorize variants which are available in ClinVar and take it for the face value. And really, you should not do that, because most of the variants, I would say approximately 35% of the variants, to give a number, are actually misclassified or misannotated even in public databases like ClinVar. And this is one such example. I have seen a lot of reports for this particular variant, which has come across from multiple different centers for Alström syndrome. What we know today is that this is not a pathogenic variant. This is an extremely frequent polymorphism found in Indian population. So you need to have public databases to look at allele frequencies. This is one of the oldest public databases that we have put together, called SAGE, which published in 2018, sorry. And very recently in 2021, we have a new database which is called Indigen, which encompasses 1,029 odd individual genomes spread from across the country. And this is publicly available, and I'm sure as clinicians, you should be able to access this without any restrictions. And the other opportunity is to be able to share genotypes and phenotypes of patients with the anticipation that if you have seen a patient with a particular genotype, there are also a very large chance that there is some other clinician who has also found another patient with the same genotype. And individually, you would all classify them as a VUS, but put together by segregation studies, you could now classify them as a pathogenic or a likely pathogenic. So that requires platforms to share genetic information. This is one of the platforms that we use extensively in the Guardian Consortium. It's called Variant Share. I'm sure you can make a login and you can start using it. Now, what's very important is that genomic evidence is very dynamic. That necessarily means that the evidence that is there today might not be the evidence and the classification for a particular variant tomorrow. And this necessarily means that you need to have reporting in a very dynamic format, factoring in the evidence. And therefore, this is very important in diseases, especially things like primary immunodeficiency disorders, where the patients are on long-term treatment or long-term care. And therefore, we have sort of rolled out this particular mechanism, which is a card and an app, which was launched late 2019 by the Honorable Minister for Health. And the idea of this is that the evidence would get updated on a constant basis. The genomes remain a constant from the day you're born to the day you have died. But nevertheless, the evidence on genetic variations on this genome would be dynamic and would change according to evidence. To put some numbers, just reanalysis of data from our own cohorts have revealed close to 10 to 15% more yield just after 3 to 4 years. I think I'll stop there and take questions. But before that, I'll just put a minute to discuss about the PID cohort and 3 people who sort of put together this cohort. Dr. Geeta Govindaraj, Dr. Sridhar, who is my colleague, and Abhinav, who has been a graduate student in my lab, recently graduating out. And of course, we have been working very closely with a large number of clinicians to educate them about these guidelines and how to implement them in clinical settings. We are in the last leg of the first international symposium, which was attended by around 1,000 individuals from 30 different countries. We will have a second course very close by, sometime in July 2021. If you're interested, please do let us know. Thank you very much.
Publishing here on the important thing.
So Shubha, are you there?
Hello. Great talk. I'm sure many youngsters and clinicians who are new to this NGS technology will be happy and may feel little more comfortable with while ordering these NGS-based testing as well as interpreting results. So it's a lot of experience he has put in his slides. So there are some questions and from the chat box, which I shall read, which are, of course, the questions, the answers are very big, already answered, but some of them briefly, maybe Dr. Vinod can say. So Ashwin is asking, are gene panels for diseases where mutations are known available, or have to be designed?
Yeah, so the problem with gene panels, at least, is that the genes and implications in diseases are also an evolving topic. Like, for example, if you look at primary immunodeficiency disorders, 5 years ago, this was around 280 genes. Today, we have around 400 genes. Now, it is almost impossible to create gene panels which can keep pace with the developments in genomics. So I would preferably not recommend it, at least for conditions like primary immunodeficiency conditions, because there are a few hundreds of tests that are done annually. But probably a whole exome sequencing or a clinical exome sequencing would be better in terms of workflows. But having said that, there are some disorders where their testing is very large in number. The best examples would be hereditary cancer syndromes. Other examples would be cardiac channelopathies or cardiomyopathy panels, where you expect to have hundreds of samples to be tested even annually, and then therefore panels would be cost effective. But it depends upon the field, number of genes, and the dynamicity of evidence that is emerging in that particular field.
Will it be useful that do the whole exome sequencing and look virtually at the gene panels, like important genes known at that particular time, immunodeficiency disorders and so on? Such type of things are routinely used in clinical diagnostics.
Yes, that is something that is routinely used in clinical diagnostics, and that is why I said that there is a small problem with that. And to give a few examples, what I would say is that many of these disorders which are pathogenic but otherwise polymorphic in the population, what you realize is that if you go back to the publication, these are individuals who have been tested elsewhere, right? So essentially look at a case where, for example, somebody has looked at, say, XLA, right, and send a sample abroad to, for example, one of the European or American laboratories. They would test for that particular gene, they would find a mutation which can fit the profile, and they would report it as pathogenic. Now that is wrong, because that might be a polymorphism back here in the population. They don't have access to the Indian population data, therefore they have no way to assess it about the pathogenicity. So therefore, you need to actually factor in the evidence first rather than the phenotype first.
So this is the most important message. Whatever sequence variation you identify before labeling it as causative or pathogenic, one should look at these all information so that the proper conclusions can be drawn and no wrong labeling of the diagnosis should be done. And most importantly, many of the times this mutation-based data is used for prenatal diagnosis. So if your mutation is this sequence variation is not really pathogenic, then there will be maybe false errors in the prenatal diagnosis.
Right, and this is happening. This is happening very rampantly.
Yeah, so the one has to be very, clinicians have to be very careful. So I think time is less. So one more question from Dr. Manisha. How reliable is how to use NGS based testing for diagnosis detection of big deletions, and do we need to confirm by MLP or other technique?
Yes, the quick answer is that you need to confirm it using orthogonal techniques, depending upon the assays that you use. So I'm not trying to say that large deletions cannot be captured on whole exome sequencing. It can be captured even on whole exome sequencing, but nevertheless, you still have a dilemma whether it is because those probes didn't work or because it's actually a deletion. So you always need to sort of validate using an orthogonal technique. Depending upon the case scenario. If it's a very large deletion, you could use chromosomal microarrays. If it's a small deletion, you could use MLPA.
So one last question I want to ask, that as all clinicians and including myself, we tend to give a lot of stress to the clinical situation and correlation with the clinical findings. But as per ACMG guidelines, this is if the phenotype matches with the gene identified, is not a very strong evidence for causative or pathogenic nature of the gene. Or the sequence variation. However, sometimes there are very, very specific phenotypes like nail hypoplasia in case of FOXN1 related immune deficiency, or alopecia in case of say Omenn syndrome. So do you think such type of clinical or biochemical or immunological very, very specific phenotype, you would give added weightage to that while interpreting the sequence variation in the gene where it is, where the sequence variation is added?
Yeah, my personal opinion, and so this is just a personal opinion, is that you should not get carried away by the clinical phenotype. because if you look at a clinical phenotype and given any random genome, we have done this exercise in the lab quite, I mean, this is a fun experiment that you can sort of do. We sort of shuffle the genomes and the clinical phenotypes, and you'll be surprised that individuals can still identify probably variants that can explain the phenotype. So that is in many ways a biased system which can create a lot of errors and long-term implications. So my
So
personal
that is
opinion
the
is that you should not
message,
do
and
that.
I think that we should end with this strong message that just clinical correlation should not be the priority or considered important evidence for pathogenic nature.
That's right.
And lastly, there is one question probably asked by many. What is the email of Dr. Scaria? So probably you can get it on email as soon as you put his name. You can get his email, but you can tell
I can post it online, not an issue.
Okay, thank you, Dr. Amita. Should we?
Yeah, thanks a lot, Dr. Shiva. Thank you.
This is Dr. Gupta. It was a great presentation. I think one of the very important message should be in gene sequencing and everything. The functional aspect is the most critical one. You can make any gene mutation shown, but you have to prove, at least in our PID, that's one of the criteria. Without that, you cannot assign that gene as a causative gene. So functional studies are and so many times we see the mutations when we look at the functionality, perfectly fine, So it is very, very critical that we do the functional analysis of that particular gene.
Right, absolutely right.
Just a back question to Dr. Gupta. Do you think that functional studies in case of these genes for immune function are little easier as compared to the genes for our other disorders like intellectual disability and neurological disorders?
You see, I won't say that they are easier one. It all depends upon the gene,
Yeah. But still, like most of them, they will express in the
And at the same time, also, I might inject. Yeah, I may also inject when somebody, there was a presentation on a BTK mutation. A BTK mutation doesn't make somebody to have XLA. It is a signaling molecule. And that's why that case which was presented with normal or increased immunoglobulin is not XLA because it's a signaling molecule in BCR signaling. So you can have mutation. Well, BTK mutations have been seen in selective IgM deficiency and other. That doesn't mean anything. So one should not make a diagnosis because you got the BTK, because that particular gene doesn't have a single function.
So at the end, I would like to really thank Dr. Shubha and Dr. Sakaria. Dr. Sakaria, wonderful talk, a very different talk from the ones which we've been having since yesterday. And great, we'll keep in touch. And I think your email, you have put it in the chat box. So people who want to contact Dr. Sakaria can contact him. And he is always very helpful. So we move on to the next talk. That is on looking for PID in common autoimmune rheumatic diseases. This will be given by Professor Sujit Singh, and the session will be chaired by Dr. Negi, who's the head Department of Clinical Immunology at JIPMER Pondicherry. Over to Dr. Negi.
Thank you, madam. Good morning. I now welcome the next speaker, Professor Sujit Singh, Head Advanced Pediatrics Center and Chief of Pediatrics Department and Pediatric Allergy and Immunology. Professor Singh is an expert in pediatric immunological disorders. He is well known for his work on primary immunodeficiency and Kawasaki disease. Today, he will be delivering his address on a topic which has been a dilemma for immunologists for long, that is looking for PID in common autoimmune rheumatic diseases. Not able to diagnose these associations may have some consequences for patient diagnosis, treatment, etc. So now I welcome Professor Sujit Singh for his talk. Welcome, sir.
Thank you, Dr. Negi. I hope I'm audible. Am I audible?
Yes, sir.
Okay.
Yes, Dr. Sujit, we can hear you.
Thank you. So I shall be talking on inborn errors of immunity and the overlap with common autoimmune diseases. So this is a dilemma which is faced by rheumatologists the world over, and many seemingly classical rheumatic diseases, in fact, may turn out to be uh, 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 inborn errors of immunity if only you looked a little deeper. And we have had our fair share of misdiagnosis in this field. And I shall be presenting some of our own patients in whom we were initially wrong and in whom the diagnosis was made not weeks later, months later, but in many cases, years later, the correct diagnosis. So with that, I will go on. So the term—
Can you put it in full mode? Can you put it in full screen?
So the term primary immune deficiencies was hitherto used to describe diseases which had increased susceptibility to infection. However, it has now become amply clear that immune dysfunction and dysregulation are now important components of these genetic immune diseases, and hence in the IUIS classification of 2017, the new terminology is inborn errors of immunity rather than PIDs, to which all of us used to refer to earlier. We must remember that autoimmune and rheumatological diseases can be presenting manifestations of several IEIs. For the rheumatologist, therefore, it is important to be able to identify patients who may present seeming with typical rheumatological findings, but in fact who have an underlying inborn error of immunity. So IEIs can present to the rheumatologist in two ways: seemingly typical rheumatological disease with an underlying covert IEI, or a difficult to diagnose rheumatological disease with an underlying covert IEI. For the first scenario, we have, for instance, lupus in disorders of early complement components. And for the second scenario, we have disorders like common variable immune deficiency and autoinflammatory disorders. What are the mechanisms of autoimmunity in IEI? These are not clearly understood, but there are several mechanisms involved. It could be disorders of central tolerance, peripheral tolerance, disorders of peripheral B cell tolerance, problems with the complement pathways, defects in the immune-mediated clearance, or defects in the interferon pathways. So I'll start with case one. This was a young boy with early onset lupus. He had what was at that time diagnosed as discoid lupus by our dermatologist when he was just 2.5 years of age. He had seizures at 7 years, and he was found to have cortical vein thrombosis. He had had 2 episodes of pneumonia, and his elder sister had died of lupus in Delhi at the age of 7 years. When we worked up this child, he seemed to have lupus, but somehow he didn't fit into the classic lupus. His C3 and C4 was normal, ANA was 4+ speckled, anti-dsDNA was negative. He had the lupus anticoagulant antibody. So when we worked him up further, we found that he had C1q deficiency, and he was in fact the first of several such patients with monogenic lupus that we then started identifying at our center. So we suspect early complement component deficiency in patients with lupus whenever there is very early onset lupus, especially lupus starting below the age of 3 or 4. Whenever there is family history of early onset lupus, whenever you have associated infections, and especially if you have ANA positivity and anti-dsDNA negativity. So that should immediately alert the rheumatologist. So several complement deficiencies can be associated with lupus. And if you look at this figure, the highest association is with C1q deficiency, and the percentage of patients who will develop lupus is as high as 93%. With C1R, C1S, it's 57%, C4, 75%, and with C2 and C4, the figures are much lower. This is the second patient that we had. This was a 14-year-old girl who had had third-degree consanguinity. She presented with fever, polyarthralgia, epistaxis, rash. She had anemia, alopecia, chromonychia, and sclerodactyly, and she had massive hepatosplenomegaly. Her hemoglobin was low. She had borderline low platelet counts, and ANA was 4+ speckled. Anti-dsDNA was elevated. She had positive antiphospholipid antibodies. She had a positive EBV IgM serology, and she had a CMV viral load, which was more than 100,000 copies. So she fulfilled the criteria for lupus. She also had antiphospholipid antibodies. She had features of lymphoproliferation. She had some overlap with scleroderma. Her EBV serology was positive, and she had CMV viremia. So when we worked up the patient, we found that she had low levels of switched and unswitched memory B cells. And on further workup, she turned out to have a homozygous missense mutation in exon 21 of the LRBA gene. The workup in the family showed that the parents and the elder brother were carriers for this variant. So there are several IEIs that can be associated with lupus. These include common variable immune deficiency, selective IgA deficiency, some types of selected IgG subclass deficiency, and some patients with unexplained hypogammaglobulinemia. But the one in which we have had the maximum difficulty is LRBA deficiency, and we have a couple of these patients at our center now. A common phagocytic defect, for instance, chronic granulomatous disease, we know that female carriers of patients with CGD can have lupus-like features. And this was a patient with CGD in whom we had a very prominent malar rash and several other findings associated with lupus. So lupus is not because of a single genetic disease, and there are several genes which have been associated with monogenic lupus and lupus-like features. So whenever you're dealing with unusual types of lupus, whenever you're dealing with very early onset lupus or familial lupus, one has no choice but to think of an underlying immune defect in these patients. This was a 1.5-year-old boy who presented with what looked like a typical IgA vasculitis. The clinical features were rather typical of Henoch-Schönlein purpura. However, when we did the workup, we found that the patient had thrombocytopenia. The platelet counts were rather low, and the mean platelet volume was also on the lower side. The IgM levels were below normal, and so we worked up the child further, and he turned out to have the Wiskott-Aldrich syndrome, and this was proven on flow cytometry. So 40% of patients with Wiskott-Aldrich syndrome develop autoimmunity. This may include Coombs positive hemolytic anemia, a vasculitis. They may present with renal disease, arthritis, and this autoimmunity is due to the formation of autoantibodies and because of poor survival and functions of the Treg cells. So this was another patient that we had with Wiskott-Aldrich syndrome who presented predominantly with very prominent vasculitis. So leukocytoclastic vasculitis may be associated with several inborn errors of immunity, and these include, in addition to Wiskott-Aldrich syndrome, C4 deficiency, ALPS, and the APEX syndrome. This was a 13-year-old girl who presented to us in the year 2013. She had had fever, recurrent abdominal pain, loss of vision in the left eye, and she was hypertensive. She had initially presented to the pediatric gastroenterology unit in our institute. They diagnosed this as polyarthritis nodosa and referred the case to us. So when we took up the patient, we thought this was classic PAN, and we started treatment for PAN in the year 2013. The child responded gradually. It was a rather hectic course in the ward. She had to be operated twice because of gastrointestinal complications, but she recovered ultimately. So there was no problem in labeling her to be having polyarthritis nodosa. However, the real problem started when 5 years later, her younger brother presented with an acute painless loss of vision in the left eye for 3 days. And he was found to have central retinal artery occlusion. So at that time, we just couldn't correlate. Why should 2 children in the same family have such unusual clinical presentations? However, when we worked up these patients 2 years down the line, we realized that both of them had ADA2 deficiency. So these are the 2 children with the homozygous mutation. This was another patient with polyarthritis nodosa in whom we have a follow-up of 30 years. In fact, this was the child whom we diagnosed in the early 90s, and he was our first patient of polyarthritis nodosa. Again, what looked like classic polyarthritis nodosa, picked up at the age of 3 years and then followed up for the next 30 years. He had in between neurological relapses, which were managed adequately. And it's only lately that we diagnosed this child also to be having ADA2 deficiency. So this is how misleading a PAN can be in the pediatric age group. So whenever you have unusual features, you must think of an alternative diagnosis. And many rheumatologists, in fact, now recommend that PAN in children mandates a workup for DADA2. So the predominant clinical presentation in DADA2 is small and medium-sized vasculitis. It affects the skin and central nervous system. Clinical features may include fever, polyarthritis nodosa, livedo-racemosa, early onset, typically lacular stroke, and some patients can have immunodeficiency as well. Several IEIs can be associated with vasculitis. So we have already discussed VOS and DADA2, but there are several others in whom a common presentation can be vasculitis. And whenever these children with such IEIs present with vasculitis, it's not an easy condition to diagnose unless you have a very low threshold of for workup. Arthritis is one of the common symptoms in children who present with rheumatological disorders. And what looks like juvenile idiopathic arthritis may not be so. And especially when you have arthritis associated with some other clinical features which you can't explain with a simple diagnosis of JIA. So this was a 4-year-old boy who had been failing to thrive. He had had recurrent pneumonia, and he also had very prominent arthritis. So this child had X-linked A gamma globulinemia. And arthritis is the most common rheumatological manifestation in XLA. We have seen several such children being misdiagnosed to have JIA and being even started on treatment for JIA. 15 to 20% of patients with XLA may present with arthritis, especially if the diagnosis is delayed. Usually it affects the large joints of the lower extremities, and arthritis may be the result of an intra-articular infection. Mycoplasma infection is the usually incriminated organism, and arthritis resolves with administration of IVIG therapy in majority of the patients. This was a patient who was referred to us from Tripura, and he had had arthritis involving the proximal interphalangeal joints, and this looked like JIA. But this child, when we took the history, we realized that he had had several infections in early childhood, and he also had X-linked A gamma globulinemia. So arthritis is most notably found in patients with XLA, but selective IgA deficiency, CVID, can also present both rheumatoid arthritis as well as juvenile idiopathic arthritis. D-George syndrome has been noted to have early onset chronic polyarthritis. Viscotaldi syndrome, Blau syndrome, early onset sarcoidosis, and Savi and Copa can also have arthritis. So we must remember that arthritis in children has several mimickers, and we must think of disorders of immunity whenever there is any history of recurrent, severe, or unusual infections in children with arthritis, whenever there is an unusual presentation of arthritis, whenever there is a family history of IEI, or if the arthritis is not responding to conventional treatment. This was a 2-year-old girl who had had recurrent oral and genital ulcers, colitis. This was refractory to conventional treatment. She turned out to have HLA-B51 positivity. She had significant family history in that her younger brother had recurrent oral ulcers since the age of 8 months. So we thought this was Behçet's disease, but when we did the workup, we realized that this was A20 haploinsufficiency. So monogenic Behçet's is now well described, and in this series from Ghosh in London, the median age of disease onset was 0.5 years. 6 out of the 11 patients had had family history of disease, and 9 out of the 11 had known disease-causing genetic mutations in patients with early onset Behçet's. So several variants have been recognized, and these patients can present with Behçet's disease starting very early on in life. So genetic screening should be considered in young children with Behçet's whenever there is early onset disease, a positive family history, an atypical presentation, or a refractory disease. This was a 7-year-old girl. This girl had come from Dhaka, Bangladesh. She had been symptomatic since the age of 6 months. She had had recurrent history of fever and cough. She had hepatosplenomegaly, and she had facial dysmorphism in the form of hypertelorism and epicanthus. Investigation showed elevated transaminases, and liver biopsy showed a granulomatous hepatitis. Imaging of the chest revealed enlarged lymph nodes in the subcarinal, paraesophageal, para-aortic regions and at the renal hilum. She had been investigated at several hospitals in India, and a diagnosis of sarcoidosis was considered in view of the granulomata, and she was initiated on immunosuppression for sarcoidosis. However, she continued to remain unwell. We must remember that whenever you have sarcoidosis, we must remember that sarcoidosis is usually a diagnosis of exclusion. And two immune deficiencies which must be ruled out in patients who seem to have sarcoidosis are common variable immune deficiency and chronic granulomatous disease. It is quite difficult to differentiate sarcoidosis from common variable immune deficiency. However, if you have prominent infections, then this is a pointer towards CVID. If you have autoimmunity, again, more common in CVID. Splenomegaly, more common in CVID. Low serum IgG, again, that is a pointer towards CVID. Granulomas can occur in both. LIP would be a pointer towards CVID, but can also occur in sarcoidosis. And you can have various permutations and combinations of these clinical findings. But we must remember that misdiagnosis of sarcoidosis in a patient with CVID can lead to inappropriate treatment and lot of associated morbidity and mortality. So in this patient who had been referred to us with a query of sarcoidosis, we started workup on this patient. We realized that this patient had hypogammaglobulinemia. We realized that this patient had low levels of switched and unswitched memory B cells. So thereafter, we did further workup, and this was the result of the workup. So this patient ultimately was started on IVIG therapy. She's been on IVIG therapy now for almost 4 years, and she's much better now. This is a patient whom we had first seen in 1997 when she had presented with fever and polyarthritis. She looked to be having juvenile idiopathic arthritis. There was no uveitis at that time. She developed uveitis 10 years down the line at the age of 13 years when she developed granulomatous uveitis. At the age of 20 years, she developed chronic hepatitis and nephrotic range proteinuria. So it was at this time that we started investigating her further, and we realized that what we had been dealing with was a patient of Blau syndrome in whom the uveitis presented many, many years later after the onset of arthritis. She had boggy swelling, she had granulomatous uveitis, she had granulomatous hepatitis, granulomas in the kidney, but all this appeared later. Her initial presentation was only with fever and arthritis. So several immune deficiencies can be associated with granulomata, starting from chronic granulomatous disease, common variable immune deficiency, selective IgA deficiency, IPEX, Omens, Blaus, and one has to be aware of these conditions whenever one is dealing with such patients, and it's only investigations which will help you clinch a diagnosis. Dermatomyositis-like syndromes can also sometimes be associated with immune deficiencies, and we know that XLA can have a dermatomyositis-like picture, but there are clinical clues. For instance, patients with XLA who have dermatomyositis usually would not have elevation of the muscle enzymes, but it can be a very difficult differential diagnosis. We have never encountered a dermatomyositis-like presentation in XLA, but it is well known. Similarly, patients with Viscott-Aldrich syndrome can sometimes have a dermatomyositis-like presentation. So to summarize, there are several types of immune deficiencies that can have a predominant rheumatological presentation. And not all rheumatological diseases, even so-called classic rheumatological diseases, are in fact pure rheumatological disorders. Many of them have an underlying defect of immunity. And for the rheumatologist, it is always better to have a low threshold of suspicion for an underlying inborn error of immunity. And whenever the presentation is unusual, atypical, or the child presents at a very young age, for instance, lupus, whenever you see lupus below the age of 5, especially lupus below the age of 3 or 4, one would be very, very concerned about the presence of an inborn error of immunity. Common disorders like arthritis in children, we have been fooled many times, have turned out to be nothing but inborn errors of immunity. So it is essential to have an increased index of suspicion in patients with rheumatological disorders whenever there is early onset disease, refractory disease, and atypical presentation, or multi-system autoimmunity without a clear unifying diagnosis. We must remember that not all inborn errors of immunity present only with infection. Many of them present with autoimmunity, many of them present with immune dysregulation, and the clinical correlate of this autoimmunity and of this immune dysregulation can be a rheumatological disorder. And one has to have a low index of suspicion when dealing with such patients. Thank you very much.
Thank you, Professor Sujit. Thank you for nice presentation with the clinical examples. I think we are already running late. I'll just ask one or two questions which were there in the chat box. Dr. Naveen has asked that is A20 haplotype insufficiency, which is associated Behçet, is thrombosis as frequent as seen in Behçet, or there are any differences?
I'm afraid we have just seen, I think, 2 or maximum 3 patients. We haven't seen thrombosis in them, but I don't have enough experience of this condition.
Okay, and Dr. Sharath has asked the question that early onset lupus with family history, or all patients with family history should be investigated of rheumatological disorder should be investigated for PID?
Well, we began our journey on this aspect through early onset lupus, and we were dealing with these children. We realized that they were unusual patients of lupus, but at that time, I'm talking of almost 15 years ago, we never realized that we were dealing with complement component deficiencies. So whenever there is early onset lupus, yes, we will definitely think of an underlying immune deficiency. But I think if there is a family history of lupus, you have good reason to suspect an underlying PID, and there is no harm in working up for PID in such patients.
Thank you, Dr. Surjit. I'll hand over the mic to Dr. Amita now.
Thanks a lot. Thank you, Dr. Negi, for sharing the session, and for Dr. Sujit for giving us wonderful insights into patients' histories, which have helped make the diagnosis, though sometimes late. We are all learning all the time. And if there are any more questions, you can answer in the chat box, and we'll move on to the next session, which is a very important session for our society, which is a curtain raiser to the ICMR PID registry. And Dr. Manisha will be taking us through in a short presentation. And with the start of registry, I think the country will move forward, and we will really see a difference in the kind of cases which we will gather over a period of next few years. Over to Dr. Manisha.
Thank you, Dr. Amita. First of all, sincere thanks to Dr. Amita and Dr. Sudhir Gupta for giving this opportunity to present this good news, because this is something that the primary immunodeficiency disease registry that we have been talking for quite some time now. We've prepared pro formas, debated, but somehow it was not materializing. But ICMR came up with the National Rare Disease Registry Program. And so we managed to get primary immunodeficiencies included in this Rare Disease Registry Program. So around 2 years back, ICMR announced that they wanted to actually include actually initiate a registry for rare diseases. And that is how primary immunodeficiency diseases national registry attempts we have initiated. So as you all know that India being a huge country, and there is so much of data on rare disease registry, but there are diseases that are available in India, but somehow there has never been a registry of a formal registry for these rare diseases. So ICMR has come up with this registry with the major objective to collect epidemiological, clinical, laboratory and treatment data on rare diseases from India. The overall aim of this registry is to understand, not only to understand the prevalence of these diseases across India, but also understand the outcome of these diseases, understand the or estimate the unmet needs of these patients, and facilitate the policy making and collaboration between the stakeholders and encourage multicentric research. And with these objectives, there are 7 diseases that rare diseases that have been included in the ICMR Rare Disease Registry. So along with primary immunodeficiency diseases, we have hemoglobinopathies, bleeding disorders, neuromuscular disorders like LSDs, skeletal dysplasias, and small molecule diseases. So the structure of these registry is we have ICMR RBMCH as the administrative coordinator for this registry. We have Dr. Rita Rasili, who has coordinated the entire attempt across India. But the technical coordinator, or the looking at the technical details of the registry, is Dr. Madhulika Kabra from Division of Genetics from AIIMS New Delhi. She is the main coordinator for the entire registry across India. And for all these 7 centers, there have been nodal centers which have been identified. 7 diseases, there are nodal centers which have been identified. And for primary immunodeficiency diseases, it is PGI Chandigarh and our center who has been, who will be the nodal centers for coordinating this registry. So in 2018, actually, ICMR had floated advertisement for participation in this registry. So the centers who had a significant number of patients in these rare diseases had applied. And based on their applications, 21 centers have been shortlisted across India for different diseases to enroll these diseases, enroll the patients in this registry. However, these numbers are not going to be fixed. New participating centers can be added, and this will be a continuous process as the registry progresses. So coming to the primary immunodeficiency registry, it was a tough task actually, because it's such a complex group of disorders that every year or every 6 monthly now you have many more diseases which are being added. So the major debate was whether to have a simple registry which just gives you the number of diseases or number of patients in each category, have some basic clinical manifestation, or have a reasonably comprehensive registry which will have some more clinical details, laboratory parameters, as well as management parameters. So after a debate which we had with PGI Chandigarh and AIIMS Dr. Naresh, we decided to have a more comprehensive registry, because we thought that we will make this attempt, this kind of attempt is not possible and again and again. So might as well prepare a comprehensive proforma which has not only basic diagnosis of the patient, but also have other important details. So the proforma consists of socio-demographic details, which actually are common for all the rare diseases included in ICMR registry. But the clinical details, family history, investigations, including molecular analysis, treatment, are specific for primary immunodeficiencies, and similar different proformas are there for other diseases. So in this registry, basically now we have included latest 10 diagnostic categories of IUIs. So eventually the patient will be categorized based on the latest IUIs classification. And also there is a scope under each of these categories of unclassified patients to include those which are strongly clinically suspected, but not molecularly confirmed. So the criteria that we are going to eventually use for inclusion of the patients for inclusion in this registry are the patients which are molecularly proven or molecularly diagnosed, or patients satisfying the ECID working definition for the clinical diagnosis of primary immunodeficiencies. So I'm happy to share that after a long exercise with ICMR IT department, now this online portal is ready for including registering the patients under primary immunodeficiencies. So we have actually each participating center will have a login ID and a password through which they can enter the data. So once they log in, there is an exhaustive proforma which comes in. These are the simple yes and no answers, or some areas where you need to add in figures. So this proforma needs to be filled up through online portal, and the data that is put up by the participating centers will be validated by the nodal centers that will validate the data, and eventually the entry will be completed in the portal. So for the participating centers, it is very critical that you have your ethics approval for the institute, from the institute, because the patient data along with the patient ID, especially Aadhaar number, will go into this, though it will not be shared with anybody, but it will still be linked to the patient. So ethical approval is must for entering the patient data in this registry. So the participating centers also need to identify a nodal person who can take the consent, take the responsibility of taking consent, filling up the proformas, and coordinating with the nodal center, ensure the timely sharing of data with the nodal center. And it is important that once a center is recognized or gets a login, they can add in not only for primary immunodeficiency, but all the other 6 diseases that they are diagnosing at their center. So it will be a one-time exercise for that particular center. So if the center has or a pediatric department has multiple other diseases that are being diagnosed, that can also be entered through the center. So what we recommend is, in the beginning, apart from these 21 centers who can enter the data in the primary immunodeficiency registry, other centers can also participate in the registry initially, that they can send their data to two of the nodal centers by filling up the proformas and sending it to us after getting the ethical approval from their respective institutes. And what we have decided that we will share the center. So PGI Chandigarh will look after northern and eastern India. We can look after southern and western part, and maybe the central part of India. So not only for taking the data of the patients and filling up eventually on the online registry, but also coordinating with the centers and monitoring their data entry. So I think that is all from my side. I think we are just beginning. We will know what are the problems that we are facing. Last 15 days, we've been entering the data in this PID registry. So once we enter more patients, what we have realized that for most of the patients, even the center like us do not have many critical important information that is available, though we are filling up the proformas regularly. So I think it is going to be a great learning process for all of us. We will know what is critical, what is important, not only for diagnosis, but also for follow-up of these patients. And I encourage all the participating, all the centers or all the people who are present today to actually coordinate with us and participate in this study. Yesterday, we had a beautiful presentation from that Eurofever registry, and this is something that can be done if all the people from all over India participate in this registry. We will have data that is generated, which will be systematic, well evaluated, and I think will go a long way in improving our understanding. And maybe it will also be very critical to have India-specific guidelines. What everybody keeps saying, that we should have India-specific guidelines for diagnosis of and management of these diseases. Unless we have a systematic data from our India, which is registered in this registry, it will be difficult to establish these kind of guidelines. So once again, thank you, Dr. Amita, and special thanks to Dr. Sudhir Gupta, because he has helped us a lot. He got us in touch with the USIDNet registry group. We had a look. We actually modified the proforma from USIDNet registry, as well as ICIT registry, which Dr. PJ Chandigarh was already using for their Center of Excellence data. So it has been a beginning. So I just hope within 1 or 2 years, we'll have some good data coming out of this registry. Thank you so much.
Thank you, Manisha. Dr. Gupta has something to add.
Thank you, Manisha. It is a great, I think it is a great day to see the registry coming to fruition. It's a very hard work that you have been doing for last 2-3 years, and I had a number of meeting with Dr. Vardhan also to push this, because originally it was not included in the rare diseases.
This was
yeah, so it is about the time, I think all of us who are one way or other seeing these patients with inborn error of immunity, that should really communicate with both the nodal center, include their data, and they should feel comfortable that nobody is going to take away their data. It is just entering those data, and these things become very, very important down the line, because then we can really show the ministry and government that these are the hard data. This is what can be done. Because in the performa that I saw from the health minister is really, ultimately the government will support the diagnosis and the treatment of these diseases as well. So, but first we have to do our job, and therefore I'll request and appreciate each and every one who is involved with primary immunodeficiency, including all our major centers, to really start inputting the data. I think it will be just a great thing, I think, in 2-3 years. And then for each disease, you can really put together, just like we do in USIDNet, that take each disease, and everybody who is participating is on that publication, but it gives in the country, you know, what's happening and how they are managed, what the complication, what the presentation is. So it will be terrific, really. I hope I can see during my lifetime, you know, because I don't know how long I'll be around, but I like to see some of these things come to fruition, that government can really support these treatments, which are often very expensive. And they admit that in their draft, that this is one of the thing in primary immunodeficiency, because the bone marrow stem cell transplants are expensive, you know. So again, thank you very much putting together. Thank you, Sujit, having your nodal center, and each of you, I again request that please enter your data through the portal. Thank
So
you.
one more thing I would like to add is all participating centers, new participating centers, if they, in a year or two, if they have sufficient number of patients, they can get an independent participating center status. So it is extremely important that they begin sending us the data, and once they have enough number of patients, they can have an independent participating center. And that provision is there in an ICMR registry. So every year it will be evaluated. Probably we'll have a provision of adding few new more centers, and that I'm going to push, because that is very critical, that if a center is, because not all centers actually gave application in the beginning when ICMR announced this registry, and half of them probably did not know about it. But now if they have adequate number of patients and all categories together, then definitely they can get an independent institute participating center status, and then they can have their data entirely collated so well under this registry, and that they themselves can analyze, and of course they'll have access to, eventually there'll be a policy to access to these registry also. So parallelly ICMR is working on that policy. Probably 6 months down the line we'll have some clarity on that policy, how this data will be monitored and utilized, but that is ICMR is working on that.
Yeah, I think that's very, very true. Already for our FPID network, we have more network center than our own FPID. So similar way, you can have more centers, because there are centers who are doing sufficient number of these patients.
Thanks a lot, Manisha.
Thank you, madam.
And we hope we will succeed. If all of us work together, I think things will happen.
Yes, yes, we have to work together. That is very critical.
Yeah, the most important. So we move on to the next session, which is just before the lunch. That is the poster round. And for the poster round, I have requested Dr. Sudhir Gupta to judge these posters. And the format we have is that these poster round, we will put up the poster for 2 minutes. And if the person who's available wants to just read out the conclusion, because we are not giving too much time. And these posters will keep running during the lunch break. So they will be on as we have the poster rounds in a physical meeting. So they will be available, and anybody who has time during the lunch break till 2 p.m. can keep looking at them. So I'll just share the screen. Yes. So this is the first poster from Abhinav Jain from CSIR Institute of IGIB and Kozhikode. So Abhinav, if you're there, you can read out the conclusion of your poster or the highlight of your poster.
Is it there?
Is he muted or just ask him? If Abhinav is not around, I can. So he is not there. So basically, they have looked for the BTK gene mutation in 2 families with multiple affected individuals with XLA, and they have identified using NGS and MLPA. And they said that identification of causative mutation by NGS in children with XLA can be leveraged to plan affordable, low-tech intervention for screening their extended families. And that has potential to reduce mortality and morbidity. So they've done 2 families. And the number of affected individuals were 2 and 5, and they've screened 15 and 17. So they could identify carriers in 7 members in each family.
Yeah, the only important thing is to have just the data on the immunoglobulin and the B cell in these patients, so that we know that they are really the XLA from that point of view. So it will be always good to have the B cell number in the immunoglobulin.
So this is the second paper. Is Dr. Swati Yadav in the audience? Swati, can you unmute yourself? Yeah.
Yes, ma'am.
Yeah, you
Good
can
morning,
tell us
ma'am
the
and sir.
conclusion of your paper. Yes.
Ma'am, in our study, 16 children with warning signs were assessed and 13, that is 22%, came out to be PID positive. Among them, severe combined immunodeficiency disorder and leukocyte adhesion defect, that is type 1, were most common, having 3 cases each. Among warning signs, family history and shriveling death were most common. As they require high clinical suspicion and advanced diagnostic technique, so they represent the tip of the iceberg.
So any questions anybody has can put it in the chat box. See the chat box. So is the lead frequency similar with other centers who have published? So Dr. Gupta is asking, is your leukocyte adhesion deficiency frequency similar to what has been reported from other centers in India, or you have more of leukocyte adhesion deficiency, Swati?
Good afternoon to all. The total of
More
11.
like same.
Yes, Swati.
Yes, ma'am.
Dr. Gupta is asking that do you have more of leukocyte adhesion deficiency here as compared to other centers in India, or?
Ma'am, it is more likely the same.
More or less the same.
Okay. Are you sure? Because I think that they have put together, a big series, and may not be. When you look at the SCADE and XLA, they make the major part in India. So I don't know whether LAD is 1/4 of the inborn error of immunity. That's a lot. Okay.
Okay, let's move to the next. So the next one is by Atulya. Basically, he's titled Significant Reduction in Febrile Flares in South Indian Cohort of Children with MVK Deficiency during the COVID-19 pandemic. So they have looked at interaction between hyper IgD syndrome and the COVID-19 pandemic. So Atulya, if you are there, can you tell us?
Okay. We analyzed a total of 11 children with a confirmed genetic diagnosis of AIDS and under care followed up on telephone using a questionnaire, part of routine follow-up during the COVID-19 pandemic. And the main data we collected were the frequency of flares, duration of febrile episodes, number of hospital admissions, and the outpatient visits. All these showed a significant decrease in 2020 compared to the corresponding period in 2018 and 2019. That over 70% of patients in the present study had 2 recurrent mutations in MVK gene. That is a non-synonymous variant, popularly known as Dutch mutation, along with a splicing variant that commits a compound heterozygous state. So, to our best of our knowledge, this is the first most comprehensive series of clinically and genetically characterized his patients from India.
So any of these patients had the COVID infection, or all of them had the COVID infection?
No, sir. During the COVID-19 pandemic, we studied. We followed up their own.
So none of them have the COVID infection?
No, sir.
So is it something in the air that is making the difference?
So what is your hypothesis that because they were using masks and they were not getting infection, is that the reason why they had less flares?
Because the mean frequency of flares and the duration of febrile episode of hospital admissions all were analyzed. And in 2018, the hospital admissions were 19. In 2019, 7 to 8, and in 2020, it was 1.
But that might be, as Dr. Amita said, because they are not getting infections. And this is true for all primary immunodeficiency. When you have lockdown and everybody is staying home, they are not exposed so much to the extraneous world, and therefore you don't have infection, which triggers some of those events. So it may not be anything very unusual to expect. You should expect that.
And
Yeah,
did you
this
have a control
COVID-19
group?
pandemic provided a unique opportunity to access the disease activity before and during the COVID-19 pandemic, during April to December 2000.
So did you find the similar thing with your other PID patients?
Just notice this in hyper IgD syndrome, ma'am.
Okay. Okay. Thank you.
Thank you.
Thanks a lot. So the next one we have is by Dr. Chandini. This is again from Kozhikode. Antenatal echo as a clue to diagnosis of DiGeorge syndrome. So Chandini, are you there? So Chandini, I don't think. So basically what they have described is that they have described 4 cases of DiGeorge syndrome, including 3 newborns who presented with antenatally diagnosed congenital heart disease and absent thymus on an ultrasound. And that they say is that increases the awareness and you can diagnose it even antenatally. And then they have done.
Hello, am I
Are
audible?
you there? Yes, Chandni, if you have come.
Hello.
So did this patient clinically were suspected of DiGeorge syndrome, and that's why the echo was done?
Hello, am I audible?
Yes, yes, you are audible now. Yes, please tell us, Chandni.
Yes, ma'am. Yeah, in these 4 newborns, actually, it was the antenatal echocardiogram which showed a congenital heart disease with an absent thymus that made us do an early FISH to detect the microdeletion. Phenotypically, only one of the child had the facial dysmorphism characteristic of DiGeorge syndrome. So it was actually the antenatal echo finding which helped us in offering an early FISH to these patients so that we could identify the microdeletion.
Why did they suspect?
So why did
It
you
was
suspect?
absent thymus. It was basically the absent thymus associated, which is seen in the echocardiogram, which made us suspect DiGeorge syndrome in an antenatal.
So how did you suspect or selected your patient on whom you do the antenatal echocardiogram? Was it on the basis of a history or what?
It was a routine, sir. It was a routine antenatal echo.
Routine?
Antenatal anomaly scan echocardiogram.
So what you are saying is just like a prenatal diagnosis that you screen them?
No, sir. What I meant to imply is that if you have a child with an antenatal echo suggesting a heart disease with an absent thymus, that should prompt the clinician to look for features of DiGeorge syndrome, and if possible, a FISH should be offered so that we can pick up the microdeletion at an earlier stage.
So I mean, these are routine scans done by a gynecologist for an anomaly scan, you're saying, and then you picked up these and then you followed them up when they were born. Yes. That's what you're saying?
Yes, ma'am.
So what was the denominator? How many echo were done, antenatal echo, out of which you picked up 4? Because that's important.
Actually, sir, I selected only those cases which had an antenatally detected heart disease, and I did a FISH on them so that I could. We had another 3 patients who had truncus arteriosus and other complex congenital heart disease, whose FISH turned out to be negative.
Okay, so 1 out of 4 only you could prove.
Yes, ma'am.
Okay. Fine. So this is another from your institution itself. So this is by Fiji. So Dr.
Yes.
Fiji, if you're around. Yes.
So this is regarding X-linked gamma globulinemia patients developing COVID-19 infection. So in the beginning, it was not sure whether they will have severe COVID-19 or whether their severity will be less because of their immunological problems. So this is a case report. 2 patients we had, 18-year-old boy and then another 19-year-old. Both of them were under follow-up from the PID clinic here. They were diagnosed at around 8 years and 17 years. They were on regular treatment and follow-up. Both of them developed COVID-19, and one had a very mild illness in the form of fever, rhinitis, myalgia, headache and all, and was admitted in the first-line treatment center. and he didn't develop a lower respiratory infection. Improved with supportive care. Only thing that he took around 2 weeks to become COVID antigen negative. Second child with bronchiectasis and recurrent infection developed pneumonia, but he also recovered within 3 days. He was shifted to the step down area, and the patient also didn't need ventilation or convalescent plasma for recovery. So my conclusion is that unlike we expected, the absence of B cells is not detrimental except for resulting in a delayed recovery. And sometimes this disease may be causing less immune reaction, and they are less prone to develop cytokine storm as part of COVID-19.
As you might know, we, about 30 of us, we published a paper, a international study of the PID with COVID, where 60% of those, 70% of those were with antibody deficiency. There were a number of them with XLA, and majority of these patients has a very mild illness. So it is not because of, and that's only a hypothesis, that because they have no defect in innate immune system to make a case for because they didn't have a storm that way. What it tells you is that T cells are very, very important in clearing the infection, and that's what makes the difference whether you get severe disease. So antibodies are very important in the transmissibility, whereas the T cells are important in clearance of the infection. And these experiment of nature, and not only that study, before that Biennial has published it, and we published 2 cases, one of CVID and one normal person who did not develop antibodies for 3 months and had a very mild course and did a very comprehensive T cell studies. And the title of that paper is COVID-associated T cell responses in antibody deficiency. So it should not come as a surprise. There's plenty of data now published, and it just reinforces your paper again, your cases again reinforces that the T cells are very, very important.
Thank you,
Yes.
Dr. Fiji.
Thank you, sir.
So now do we have Dr. Jay Lakshmi?
Yes, ma'am. Good afternoon, ma'am and sir. We did a retrospective analysis from SCPGI of our prospectively kept database of pediatric IBD. All children with IBD over a period of 8 years from Jan 2010 to December 2018 were included in this study. And especially among this category, children with less than 6 years who had the age of onset of IBD. That is very early onset IBD, were the data was collected, and then we classified the etiological spectrum of monogenic very early onset IBD. A total of 138 children were diagnosed with IBD during the study period, of which VO IBD, that is less than 6 years, was seen in around 35% of these children. And among this, there were 12 children in which we could identify a monogenic cause, of which 2 children had interleukin-10 receptor defect, 2 had severe combined immunodeficiency, 1 with IPEX syndrome, 1 with PIK3CD mutation, and hyper IgE syndrome, hyper IgM, viscotalric syndrome, autoimmune lymphoproliferative disease, leukocyte adhesion defect, and selective IgA deficiency. So the importance of this study was that very early onset IBD is a unique entity, and a variety of monogenic causes which gives rise to these IBD are potentially curable with hematopoietic stem cell transplant. Hence, an early diagnosis and referral is important instead of treating them with the conventional medical therapy of IBD, like steroids or azathioprine. So,
how many of these patients got transplanted? I think the IPEX patient got transplanted.
Yes, ma'am, but he died because of the rejection, after 1 month. And one viscotalric syndrome was transplanted, and he's improved and he's doing well.
So there were only 2 patients who underwent hematopoietic stem cell transplant?
Yeah.
Yes, sir. We had referred, but because of financial constraints, they could not.
Okay.
And few were critically ill, like both these kids with severe combined immunodeficiency were very sick at presentation, and they did not have.
So where were they transplanted? Where did
So
you send them?
one in Vadia, and the other child went to CMC Vellore.
Okay.
CMC Vellore, one we sent to Vadia.
Okay.
Okay, we move on to the next. This is by Dr. Niranjan Chattopadhyay from KEM Hospital, Bombay. So, Dr. Niranjan, are you there? Chronic neck ulcer in a case of MSMD.
Hello. Yes, ma'am. I was not able to unmute. Sorry, ma'am. Ma'am, this was an 8-year-old boy who had presented with multiple neck swellings and ulcerations, which developed from the swellings over the course of 1.5 years. And he had fever occurring with each new swelling, poor weight gain since 6 months, and a white lesion on the tongue since 1 month. This patient, since it was a long-standing complaint, he had undergone multiple investigations elsewhere. He was diagnosed with a cold abscess on a USG followed by an FNAC, and he was started on treatment with 4-drug AKT, which he took for 1 month. He had defaulted for 6 months and then restarted again, and after that he was compliant for 5 months. He presented to us after 1.5 years, and he was already on that 4-drug AKT. And when he had presented, he was found to be malnourished with weight and height less than -3 standard deviation for his age. He had tachycardia and tachypnea. He was found to have oral candidiasis and right inguinal lymphadenopathy. And he had an extensive ulcer on the neck with undermined edges and pale and unhealthy granulation tissue. Ma'am, we want edge biopsy done for this.
Can you just summarize the whole thing? You don't have to read the whole.
Yes, ma'am. Yes, ma'am. His edge biopsy was suggestive of Mycobacterium ulcerans. We upgraded his. He also developed a chest wall abscess on the treatment, so we upgraded his AKT to MDR AKT, and his wound swab also grew Pseudomonas. So according to that, antibiotics were upgraded. Since the edge biopsy suggested suggestive of Mycobacterium ulcerans, we gave him non-NTM treatment. Ma'am, otherwise there was no. The bone scan was normal. There was no osteomyelitis. We got his MSMD workup done and his primary immunodeficiency workup done. He had NBT was normal. Serum immunoglobulins were mildly deranged, but his lymphocyte subset assay showed decreased T cells, and his MSMD workup showed a deficiency of IL-12 beta-1 receptor, and interferon gamma was normal. On NTM and MDR AKT, he improved. He started gaining weight. His appetite has improved. His oral candidiasis decreased, and his ulcer presently has healthy granulation tissue, and it is now decreasing. On follow-up, actually, his parents' workup was also sent. That is awaited. His other sibling does not have any such complaints. So he seems to be improving on this. In case he comes with recurrent infections, then we would plan an interferon gamma treatment for him.
Did we come the diagnosis by molecular typing, or this is only a flow based?
It was flow cytometry. Genetic tests have not yet been sent, ma'am.
Okay, thank you. Thank you, Niranjan.
Yes, thank you, ma'am.
Okay, so the next one we have is a STS syndrome. This is by Dr. Anjana Mishra. This is from Gangaram Hospital.
Good morning.
Anjana, are you there? Yeah.
Yes, ma'am. Yeah. Good morning, everyone.
If you can tell us, yeah.
Sure, ma'am. So this is these are two siblings which we had seen in a genetic clinic. They came at ages around 23 years and 18 years respectively, and they had a long-standing history of exocrine pancreatic insufficiency, short stature. And the thing to note was that the younger sibling was more severely affected. He had a history of deep-seated abscess, pancreatic lipomatosis, osteomyelitis. All of this had required surgical intervention, and he had history of packed RBC transfusion and platelet transfusion also. So initially they had been at the primary treating centers, they had been suspected to have cystic fibrosis, and some tests like sweat chloride had been done, and 2 common mutation for the CFTR gene had been done, which were all negative. Then in the differential diagnosis, SDS was also suspected. We went ahead in our center, we went ahead with the genetic testing, and we found compound heterozygous mutations. One was a splice site and the other one was a nonsense mutation. So what I want to conclude over here is that this is, it is actually underreported in the literature search. I've come across very few literature citing SDS in the cohort, and at least not genetically confirmed, although suspected. And then it is very important to suspect this disorder in the cohort of cystic fibrosis, especially, and as this is the second most common cause of bone marrow failure also. So it is important to suspect it, and because it will require long-term surveillance also. And the second thing is that we can get a spectrum of severity. There can be extensive phenotypic variability in the same subship in the family itself. Thank you, ma'am.
Thank you. Thank you for sharing interesting case. Okay, we move to the next. So this is from Lady Harding Medical College by Sakshi. This is XLA with septic arthritis and Kawasaki disease. Sakshi, you were there in the audience. I could see you.
Yes, ma'am.
Just summarize because the case so short.
Ma'am, it was a rare case of X-linked agammaglobulinemia with septic arthritis with Kawasaki disease, ma'am. The child presented to us at 3 years of age, ma'am, with the complaints of fever and pain and swelling of the left knee. Before, at age of 1 year, ma'am, the child was diagnosed to have a X-linked agammaglobulinemia from another center where the child had low levels of immunoglobulins and CD19 counts. So was labeled XLA, but was not given any immunoglobulins or any treatment for that. At 3 years of age, he presented with these complaints. Ma'am, the child undergoed knee arthrotomy for septic arthritis. First culture was sent where it came out to be MRSA positive. We started antibiotics, but also the child had bilateral eye redness, cracking of lips, generalized lymphadenopathy, peripheral edema. For that, ma'am, we suspected Kawasaki disease, and we started the child on IVIG, and the child responded to it. Further, we planned an echo which showed dilated coronaries with Z-score of plus 3.5 in LAD and plus 2.7 in RCA. And also, ma'am, we sent an BTK gene. Also, we sent for PCR genetic mutation. For that, it came out to be positive for BTK gene mutation. And thus, ma'am, it was a rare case where Kawasaki disease is presented in X-linked agammaglobulinemia. So, ma'am, the pathogenesis of KD is still very elusive, and though in XLA there are immune deficient state where there's no antibody production as such, but development of KD definitely raises a question ki, what is the pathogens behind it. So further studies need to be done for linking these two. So it was an interesting case and a very rare in the literature review also we only found 3 or 4 cases. So it was a really interesting case to report.
So how sure you are about Kawasaki disease in this patient?
So the clinical pointers like the child was not responding to the first line antibiotics which we had started, and also sir after giving IVIG, and we had seen that in the 2D echo further which we had come for follow up, the child responded, and even in that the dilation delta changes were seen, though not significant, but definitely there was change. So clinically the child responded to IVIG, and that's why that's why I suspected it to be a Kawasaki disease.
I think it will be stretching a diagnosis based on response to IVIG treatment. Have you done any other cytokine during the time the patient had symptoms?
So the CRP was raised. There were the CRP was 300, and so other investigation could not be done because of the resource constraint.
It's not, because patient is having a septic arthritis, so I don't think CRP alone is going to make in response to IVIG. So I think we should be cautious
So, but
about
the
making
2D echo had shown coronary artery dilation, which was a pointer towards the child having Kawasaki disease, sir.
Okay, and after, have you repeated after the IVIG whether this
Yes, sir. We
improved?
had reported and it had showed improvement. And further, sir, it had after 1 month of treatment, again the echo was reported with definitely showed delta change, and had shown improvement after the treatment.
Okay, good. So this is from Department of Immunology, Wadia Children's Hospital.
Hello everyone, am I audible?
Yes, Vaishnavi.
Good afternoon, ma'am. Good afternoon, sir. So I am presenting today a case of an unusual manifestation in an autoinflammatory disease. So we had a 10-year-old boy who presented to us with severe pallor and in failure. On examination, he had hemolytic facies with a massive hepatosplenomegaly. So this was a case of hemolytic anemia who had come with failure, but there were some odd manifestations in this child. He also had deformity of small joints of hand. On investigation, he was found to have severe anemia with pancytopenia, a total lymphocyte count of 710, platelet count of 55,000, and a raised retic count. A Coombs test done at this time was negative. He also had low serum haptoglobulin, which indicates hemolytic anemia, but HB electrophoresis was normal, and his bone marrow examination was hypercellular. When we analyzed his past history, he had recurrent episodes of fever with rash, and he was admitted twice in the past at 4 and 7 years. Both times he had fever with rash, hepatosplenomegaly, multiple generalized lymphadenopathy, and polyarthritis. Both these episodes were treated as systemic onset JIA, and the second time he had a ferritin of more than 1 lakh. So it was treated as macrophage activation. But although the macrophage activation improved, the pancytopenia and organomegaly persisted. So with the past history of periodic fever, pancytopenia, persistent pancytopenia, organomegaly, and hemolytic facies, possible diagnosis of hemolytic anemia with hypersplenism and autoinflammatory disease was considered. And the whole exome sequencing was done, which revealed a compound heterozygous mutation in exon 2 of ADA2 gene. And he has been offered stem cell transplantation. So in conclusion, we present a case of ADA2 deficiency with predominant hemolytic anemia and macrophage activation as presenting manifestation. Patients with ADA2 are known to have a wide range of hematological abnormalities that can range from vasculitis to some patients coming to us with pure red cell aplasia or bone marrow failure. The clue in our patient was the presence of periodic fever in the past. Thank you, ma'am.
In DARA 2, do you get hemolytic anemia? You get a bone marrow failure, I thought. You get a pure red cell aplasia and other things, but you generally don't see hemolytic anemia in that.
Ma'am, hemolytic anemia is listed as one of the hematological manifestations of ADA2. And there are case reports of around 7 patients which have been reported to have hemolytic anemia. The majority of them had autoimmune hemolytic anemia, but in around 2 or 3 of those patients, they couldn't find, the DCT was negative. So there is a possibility of non-autoimmune hemolytic anemia as well.
What's the follow-up on the bone marrow transplant?
So we have offered them the option of bone marrow transplant, but
yet.
No, sir.
Okay.
Okay. Thanks, Vaishnavi.
Thank you.
We have this case from Madras Medical College. Dr. Alfred.
Good afternoon, sir.
Yeah.
Am I audible?
Yes.
Keeping in line with the theme of this year's conference, we would like to present this case of an autoinflammatory syndrome, chronic non-bacterial osteitis or chronic recurrent multifocal osteomyelitis. The 8-year-old female presented, as you can see in the image, with multiple pustules and ulcers and dactylitis. She was bedridden at presentation. She had multifocal osteomyelitis on MR imaging. Bone biopsy revealed acute and chronic osteomyelitis. Both the images are on the bottom left, and the biopsy did not have any evidence of granuloma. Immunodeficiency workup, autoimmune workup, sickle cell anemia workup, tuberculosis workup were negative. In spite of TB workup being negative, multifocal skeletal tuberculosis was one of the differential, along with chronic non-bacterial osteitis since the child satisfied the Bristol diagnostic criteria. So we gave the benefit of doubt with anti-tuberculosis therapy along with NSAID, that is naproxen. The image on the right side shows the recovery at the end of 1 year follow-up. Repeat imaging shows reduced severity of the osteomyelitis. So we have planned pamidronate for the child, bisphosphonates.
So you were given both anti-TB treatment as well as non-steroidal anti-inflammatory drugs. Generally, TB treatment is not required, no? So this is an inflammatory conditions. So
Yes,
you
madam.
don't need to do
TB workup was negative. However, since tuberculosis is endemic in our part of the world, as well as the one of the child's relative had tuberculosis and was on anti-tuberculosis therapy 1 year ago, we decided to offer the benefit of doubt even if the tuberculosis workup was negative in this child.
Thank you for your case of CRMO.
Thank you, ma'am.
One more left. So this is I think the last but one, Tale of Two Sisters. So you just tell us a short about this, two lines about your two cases, Dr. Lakshmi. Dr. Lakshmi, are you there? So if she's not there, I'll just highlight this case. So they have tried to present two cases with two different. Yeah, Lakshmi, yes, start off.
So this case, this poster is mainly about two sisters of a family born of a third-degree consanguineous marriage, and they had two distinct genetic disorders leading to immunodeficiency. One child was diagnosed with Chediak-Higashi syndrome, and the other with Mendelian susceptibility to mycobacterial diseases. In the first case of Chediak-Higashi syndrome, we were able to, the clinical picture was very much fitting into the diagnosis. A child had presented to the dermatology department with skin diffuse hyperpigmentation on the patches on the skin, as well as the hair with a silvery sheen. And the child had ophthalmological evaluation, had high myopia and a depigmented fundus. Later on, the child on follow-up developed HLH, and subsequently she was treated and with the HLH protocol, and she underwent the hematopoietic stem cell transplant. The sibling of this child had received ATT treatment at 8 months of age, and subsequently she developed recurrent lymphadenopathy. And the cultures from the lymph node had grown salmonella. So this child, because she was getting recurrent granulomatous lymphadenitis, grown salmonella, we did an NGS and we found a mutation in the interleukin 12 RB1 gene that clinched the diagnosis of Mendelian susceptibility to mycobacterial disorders. But in the early...
Is there any link between these two? Do you think pathogenetically are these two linked, or these are not linked diseases? The same family.
It's not done molecular typing.
So you have not done the molecular typing for the Chediak-Higashi syndrome, no?
Chediak-Higashi, we don't have the molecular diagnosis for that case. Actually, we did a study, we did the NGS, but we couldn't find a mutation.
You couldn't find anything. Okay. Okay, so interesting two cases. And this is from Department of Genetics, our SGPGI. So Varun said he's sick, so he would not be able to present. This is a case of T-cell immunodeficiency, congenital alopecia, nail dystrophy.
I'm
Achha,
sorry.
you were there? Okay. Yes, John, Varun. Yes.
Good afternoon, ma'am.
Yeah.
This is a 1-month-old female child who presents to us with history of loss of hair. There's no hair, decreased hair on the head, eyebrows, and then generalized weakness. And also there is purulent discharge, ma'am. On further probing the family history, she's born to third-degree consanguineous marriage with one sibling death, similar to the proband. He died of pneumonia at the age of 3 months, ma'am. Similarly, She also developed a episode of pneumonia at 3 months, and she also expired, ma'am. In the family history, there are 3 people affected, which I have shaded as 1/4 square. They all had nail dystrophy, ma'am, but they did not have any other manifestations, including the proband's father. On examination, the child did not have any eyebrows, eyelashes were absent. There was even alopecia present, ma'am. On further investigating the case, there was decreased lymphocyte count. There was also decreased IgA levels. We had simultaneously sent for characterization of CD, the type of CD lymphocytes and the exome sequencing, as this gene has 11 exons, ma'am. So before the follow-up was possible, the child expired and we could not trace the reports of the CD markers, but we could get the NGS reports and the Sanger sequencing of the parents, ma'am, which confirmed the mutation in FOXN1 gene, which is associated with T cell immunodeficiency with nail dystrophy and alopecia, ma'am. Usually, this case highlights that if the disorder was identified in the previous sibling, then this we could have done prenatal diagnosis and we could have treated them with thymic cell transplantation and hematopoietic stem cell transplantation, ma'am.
Thank you. It's an interesting case. I have never seen it. I've seen
Ma'am,
one more child who had nail dystrophy and alopecia.
Ma'am, the picture below I have shown protein modeling just to show the effect of the mutation on the protein, ma'am. Since FOXN1 is a transcription factor, it the serine forms a bond with the DNA with water molecule. Then the serine is substituted by cysteine. This destabilizes the bond and leads to conformational change, which leads to dysfunction of the protein, ma'am, which is shown below, ma'am. Labeled as normal and abnormal.
Thank you. Thanks a lot. I must thank all the students who have presented excellent cases. Each case is a learning exercise for us. And what Dr. Gupta is saying, that all these good cases, you should publish them. Then only they come into the public domain. So it is on you to write and to see what are the loose ends which need to be tied up before you write up. So thank you all. And we break for lunch. And we'll reassemble at 2 o'clock. So we have 50 minutes and then we start our course for the postgraduates. Thanks a lot for everybody. And I request Manisha and Biman to send me the scores so that we can collate the winners for the free papers along with the posters as well as the cases which we had yesterday. Thank you. And we'll have these posters running during the lunch break. If anybody is interested, can have seen them. Yeah. Thank you. Good. Dr. Ujjal, we'll just wait for 2 minutes and then we will start.
Okay. Not opening. Let's see what's happening here.
सब पीटीआई वालों का आ रहा है अभी आई एम इंटरेस्टेड इन अटेंडिंग टुडेस सेशंस all of them. I'm a women scientist.
It is not showing. Can't open PowerPoint. I'm glad I was looking into it.
Done. Good afternoon, Dr. Ujjal Podar, and Dr. Mala. So we'll just get started for the afternoon session. And this is one of the most important session for our society. That is the continuing medical education for our postgraduates. And as you see, we have more than 80 people already logged in and some more are logging in. So we should have nearly 100 people who should be available to listen to our speakers. And the whole theme is how to suspect primary immunodeficiency in the clinic. That is why we have tried to have all case-based approach and a simple thing how to manage. Just give them an overview of how to manage these patients. So I'll pass on to Professor Ujjal Podar. He is the head of Department of Pediatric Gastroenterology, with whom we collaborate for patients on primary immunodeficiency at SGPGI. And we have another co-chair, Professor Mala Kumar. She is in Department of Pediatrics at King George Medical University, and they would carry forward the proceedings from now. And we have two speakers in this session, Dr. Geeta and Dr. Amit Rawat. Over to Ujjal and Mala.
Professor Mala Kumar, should I start or you would like to?
You start.
Okay, thank you. At the onset, I must thank Amita and the Indian Society of Primary Immune Deficiency Diseases for giving us this opportunity. And this is, as Amita said, this is the most interesting and important part of the meeting, because we are going to learn about the basics of immune deficiency diseases, and mainly for the postgraduate. So without wasting any time, I will start the session. We have actually the 6 speaker, and we have divided this session into 3 slots. So first slot is basically me and Professor Mala Kumar will chair. So Dr. Amita, should we have the question answer at the end of each speaker?
You can do either way, because these are for students. So we have asked everybody to put the questions in the chat box. So you can see the chat box and choose the questions which are relevant and ask them.
Okay. So the first session, we have the topic of the first session is when to suspect primary immune deficiency diseases. And the speaker is Geeta Govindaraj. She is a professor, Department of Pediatrics at Government Medical College, Kozhikode, Kerala. She's a pediatrician with a special interest. All of us are pediatrician anyway. Pediatrician with special interest in immune deficiency. And she started off working with HIV infected children. She's running the immune deficiency clinic for the last 15 years and one of the pioneers in this field in the South, conducting primary immune deficiency diseases program with collaboration with CSIR, IGIB Delhi, and this is supported by funding from CSIR, SERB, and PFID. She enjoys writing, traveling, and listening to music. And today, Professor Govindaraj is going to talk when to suspect primary immune deficiency disorder. Over to you, Professor Geeta.
Geeta, can you unmute yourself? We're not able to hear you. Dr. Geeta, we are not able to hear you. Dr. Geeta?
Yeah.
Yeah. Thank you. Thank you. Now.
So thanks so much to the organizers for this very kind invitation. And I bring you greetings from all of us at Government Medical College, Kozhikode, and also our collaborators at CSIR IGIB, Delhi. This journey started 6 years ago, and we have learned so much in the last 6 years that I'm really excited to share with you. So it all started with a surprise in the ward. One morning on ward rounds, we had 2 children at 2 ends of the ward, both boys over a year old with recurrent infections. The second child's mother disclosed that these 2 boys were first cousins, and we decided to look more closely. And from then on, it's been a journey that has been well worth it. And it's been all about recognizing patterns. And I would like to tell all my junior resident friends that this is something that you need to look for. Recognizing patterns all the time. And these 2 children both had X-linked A-gamma globulinemia. Now, we'll be going through the background, the relevance, why it's important to make an early diagnosis, what is the role of the pediatrician, and what are the benefits to the family and society. So what should you look for? Where do you look for it? When, why, and how all these will be answered, although the talk is when to suspect a primary immune deficiency disorder. And we all heard of the adage, curiosity kills a cat, but curiosity could save a life, not one life, many lives. Now, there are lots of opportunities and challenges we started with. To begin with, there are no estimates in this part of the country for PIDDs. Although we have high rates of consanguinity, we are saddled with a lack of awareness among healthcare providers, poor availability of immunological and molecular genetic testing to begin with, and vast distances to be covered to access tests in premier centers. So we used to send samples to Mumbai, to Delhi, and get a reply saying that your sample doesn't work or your tubes are broken, and so many other things to start with. And it used to bring tears to our eyes. And also our naivete, of course. Now, the first question we should ask is there increased exposure to pathogens? So we all know that when a child starts school at 3 or 4 years, there is increased exposure to pathogens and they come down with recurrent infections, but most of these are upper respiratory. The next thing is there an anatomical abnormality? So if you have infections confined to one organ system, for example, recurrent pneumonia, well, it could be a diaphragmatic hernia, eventration of the diaphragm, or another respiratory abnormality. But if you have symptoms which can be attributed to various symptoms, then you need to ask, is this particular child immunocompromised? And the word unusual is key. Unusual severity, unusually persistent, unusual organisms, unusual organ, or unusually recurrent in frequency. That is the key word here is unusual. At the top of your screen, you can see a pyopericardium. That was a child with a combined immune deficiency, an ectyma gangrenosum in a child with CGD. Now we need to have an early start. So we need to look for patterns. We need to develop a flair for the unusual. Do not think that these unusual disorders are only residing in textbooks. They do not. They are right there with us. A detailed family history is essential. And it's not just infections. As we have heard, it's autoimmunity, autoinflammation, malignancies. There's a whole spectrum of manifestations, but the most common for us is infections. And remember that if a child fails to thrive, It's not just inborn errors of metabolism, it could be an inborn error of immunity. And this is a chart that we prepared with IGIB for disseminating this information to pediatricians. So it incorporates the Jeffrey model warning signs, as well as it tells us to look for recurrent fever, early onset immunity, and the like. Now, weeding out secondary causes first is paramount. So we have children with malignancies, on steroids or other immunosuppressive drugs, with diabetes, which is so common nowadays, nephrotic syndrome, and severe malnutrition, which of course is the commonest form of secondary immune deficiency. But the easiest thing to do upfront is rule out HIV infection by a simple test. So you can see the image there is a child with multiple liver abscesses who turned out to have HIV infection. Now, using the types of infections as clues, remember B for bacterial, mainly of the respiratory tract, Haemophilus, pneumococcal, Staph aureus, and the like, including a narrow spectrum of viruses that includes the enteroviruses and the hepatotropic viruses, and of course, a few fungi. Remember T for total. You have the total spectrum: viral, bacterial, fungal, and opportunistic infections. If you're looking at a phagocytic defect, it's mainly osteomyelitis, abscesses, recurrent superficial and deep abscesses by catalase positive organisms, and aspergillus is a signature pathogen for CGD. And MSMD is not just susceptibility to mycobacteria, but also to Salmonella, Candida, and the like. Now, what about the onset of infections? Well, a neonatal onset is suggestive of a T cell or a combined immune deficiency, like skin, or a phagocytic defect. You get pure B cell defects, usually only after the first half of infancy, when maternal immunoglobulins have waned off. A late onset, like adolescence, would go with a CVID, although we do have early onset CVIDs. But the key fact to remember is that PIDDs can have their onset anytime. Spending time with a pedigree chart always pays. So look at this pedigree chart you see here. It's a family with 5 children affected with X-linked A-gamma globulinemia. The one who died, I'm sorry, has not been shaded. So these children had a large deletion in the BTK gene from exon 3 to exon 5. And we also did extended family screening and were able to identify 7 carriers. And this extended family had 22 male infant deaths. So it really is worthwhile to do extended family screening. This is another pedigree chart of a child with a hyper IgM syndrome who had 5 male deaths in the family. And the grandmother was so perturbed, she thought there was a curse on the family. So what are the clinical clues? Well, facial dysmorphism, for example, it can give you a clue to DiGeorge syndrome, hyper IgE syndrome, and others. Absent tonsils or palpable lymph nodes at an age when you expect to have lymphoproliferation. Skin lesions, like in the hyper IgE syndrome and various other, like Wiskott-Aldrich syndrome, where you have florid atopic dermatitis, bleeding manifestations, again, Wiskott, Chediak-Higashi, and a range of others, depigmentation of the skin, gingivitis, oral ulcers, generalized lymphadenopathy, and hepatosplenomegaly. And it's worthwhile to remember that it is not common to have hepatosplenomegaly in a PIDD, except in a few like ALPS and CGD. And then looking out for well-recognized syndromes does pay dividends. Again, hyper IgE and Chediak-Higashi, Wiskott-Aldrich, DiGeorge, and the rest. But it is worth remembering that you do not get the full spectrum all the time. Now we'll just travel through a few cases. This was a 6-year-old girl born to third-degree consanguineous parents, symptomatic from the newborn period, 3 admissions for pneumonia, pyogenic meningitis once, malignant external otitis with pseudomonal perichondritis, recurrent thrush, umbilical sepsis, cellulitis. What is striking is the leukocytosis, neutrophilic leukocytosis with a normal immunoglobulin profile. Here you can see hypertrophic scars, florid gingivitis, and cauliflower ears. So what could this be? Well, we found absent expression of CD18 and CD11A, and there was a variant in the ITGB2 gene suggestive of leukocyte adhesion deficiency 1. But this child had a mild phenotype and is doing well without a transplant on antibiotic and antifungal prophylaxis. The second case is a 6-month-old male baby born to non-consanguineous parents who had intractable bouts of cough for 3 weeks. The child had pneumonia at 4 months, was partially immunized, had mild developmental delay, and had 5 male child deaths in 2 generations. This is the same pedigree that I had shown earlier. The grandmother asks, "Is this a curse, doctor?" Now, looking for the diagnosis, what we found is low IgA, low IgG with a normal IgM, normal lymphocyte subsets, and absent CD154 expression, and a variant in the CD40 ligand gene. So what I would like to stress is that unlike in XLA, in this group of children, you can have early onset and you can have a normal or an elevated IgM. It does not have to be elevated as the name suggests. It could just be normal. So this was the diagnosis that we got. And there was something else. The child had protracted cough with bouts of vomiting and turned out to have presented to us with whooping cough. So you get lots of things happening together sometimes. The third case, an adolescent boy, he was 16 but looked 12. He presented with hemoptysis, recurrent respiratory infections and diarrhea from early infancy, septic arthritis, empyema, pneumococcal meningitis with multi-organ dysfunction, hemopericardium at 15 years. Repeatedly, Pseudomonas was grown on sputum culture, and he had delayed puberty and growth failure. So what we need to remember that growth failure is a hallmark of the T cell or combined immune deficiency. But if a child with B cell deficiency has organ impairment, like for example bronchitis, then growth failure goes with it. And delayed puberty as in any child with a severe systemic infection. So we went on to investigate this child. Although he came to us very late, we were able to make a diagnosis of X-linked agammaglobulinemia, find out a non-synonymous variant, start him on IVIG, and he does not need to get admitted to hospital frequently anymore. So the family had spent their entire fortune on investigating this child, and he had bronchiectasis, so he had organ impairment, lifelong morbidity. So this is the importance of being aware of these disorders and investigating for them. Why should we look out for lymphopenia? Well, obviously, SCID is usually fatal in infancy, and our junior residents are now always on the lookout for the absolute lymphocyte count, which should definitely be at least 3,000 or more in infancy. So this child had ASOM, recurrent pneumonia and diarrhea, BCG adenitis, CMV infection. Everything was written that this child should have SCID. And remember that TREC and CREC assays not available now in the country, but this is life-saving for a diagnosis of a child with SCID, because if you diagnose it before 3.5 months, they have the best chance of survival with HSCT, which is curative. Now, would you like to spot the diagnosis in this child? You can see this was reported in the Indian Journal of Pediatrics. You can see the facial features, how they evolved over time in adolescence from 2012 to 2016. He had recurrent abscesses, Staph aureus was grown repeatedly, retained primary dentition, and you can see the characteristic cold abscess, which grew Staph aureus, but there was no signs of inflammation. So this child turned out to have the hyper IgE syndrome, autosomal dominant, with a STAT3 variant. Now, unusual infections are something that we need to focus on as well, not just unusually severe or unusually frequent infections. This was a 6-year-old girl of consanguineous parentage who had papillary lesion on the left arm of 3 weeks duration. She had had recurrent oral and genital ulcers and gingivitis, 2 episodes of pneumonia, hepatomegaly, workup for Behçet's and Crohn's was negative. So this is the papule that you see. And she had a normal immunoglobulin profile and lymphocyte subsets, but her DHR and MBT were grossly abnormal at 0%. And she had a variant in the NCF1 gene, suggestive of autosomal recessive CGD. So this child, again, has a mild phenotype, doing well on antibiotic and antifungal prophylaxis. And you can see how useful the NBT and DHR are. You can see that there was no shift in the case of the CGD cells, but a shift to the right in normal healthy control cells. Another child with an unusual infection who had recurrent pneumonia due to a ubiquitous gram-negative bacillus, Elizabeth kingia, which we do not see frequently at all. And that child turned out to have positive FISH for DiGeorge syndrome and also had a translocation of 11 and 14. So sometimes we do get these complicated inheritance patterns. Now, the autoinflammatory syndromes are on everyone's mind. They present with recurrent fever, inflamed skin, mucosa, synovium. These children are characteristically normal in between flares, but have raised inflammatory markers at the time of flares. And they run the risk of amyloidosis and deafness, especially those with Muckle-Wells syndrome and NORMID. And they sometimes have an associated immune deficiency and autoimmunity. This again is a chart that we made for pediatrician empowerment with the different symptoms and signs that need to be looked for in these disorders. Again, with IGIB support. Now, we have reported the largest cohort of HIDs in India, and this was the findings. I'm sure the more you look, the more you will find. So more than 75% had rash, recurrent diarrhea, lymphadenitis, and hepatosplenomegaly. And at this time, I would like to remember Professor Amita Agarwal, who was the first person to report HIDs from South Asia. So we're just following in her footsteps. Children who had less than 50% involvement, less than 50% of the children had recurrent abdominal pain, vomiting, and flares on vaccination. And remember that looking for adverse events on immunization sometimes pays rich dividends. A large number of these children, at least 40% of them, had adverse events on DPT vaccination. The rest of them had arthritis, aphthous ulcers, and recurrent infections. This is again a poster for increasing pediatrician awareness that we are sharing in this area. So, what are the clinical clues for diagnosis of a B cell defect? Well, absent tonsils and cervical lymph nodes which are not palpable, onset at about 6 months, sinopulmonary infections, autoimmunity. T cell or combined, failure to thrive, pneumonia, chronic diarrhea, recurrent fungal infections, and opportunistic infections. Phagocytic defects, recurrent abscesses, osteomyelitis, suppurative lymphadenitis, osteomyelitis, oral ulcers. Complement deficiencies, meningococcal meningitis, especially recurrent ones, recurrent angioedema, atypical HUS, SLE, and PNH. Autoinflammatory syndromes, recurrent fever, oral ulcers, rash, diarrhea, adenopathy, arthritis, and conjunctivitis. Syndromic ones, characteristic facies, bleeding manifestations, congenital heart disease, skeletal abnormalities, or skin manifestations. And what are the booby traps to avoid? This is from our own experience. Never ever go by a single lab report. Sit down, take your time, open the folder, look carefully at the series of laboratory reports they often have. Not calculating absolute counts of neutrophils or lymphocytes. Never ever do that. Never go just by percentages. And always go by the age-wise cutoffs. Not spending time on a pedigree chart. Well, you'll get pudding on your face sometimes, as we almost did once. So we asked a child to bring his father and come the next day. So the father asks us, should I really come? We said, of course you must come with the mother. And then the father says, oh no, but I am not the child's father. This is my adopted child. Okay, so you should spend time on a pedigree chart. It is really well worth it. And never take an old diagnosis for granted. Never wait for tomorrow. Tomorrow may never come. And the way forward, improving awareness, suspecting PIDDs upfront, never in extremis. It's often much too late. Improving laboratory support, in-house laboratory support is essential to improve. Offering timely genetic counseling really helps, and developing a flair for the unusual and a priority for social support. If you do not do that, again, that could end up in real tragedy. So we had a child with a hyper IgE syndrome whose father had attempted suicide, but we were able to salvage this particular person. In the picture, you can see these are some of the educational materials for pediatricians and patients, and the seminars in pediatric immunology which we conducted on autoinflammatory syndromes with global leaders. And on top, Dr. Vinod speaking to patients with the X-linked A-gamma globulinemia. And regarding timely genetic counseling, it's really, it pays to do that, because we have done antenatal diagnosis for more than half a dozen patients and have been able to make them able to take informed decisions. This is the last slide. There was this diagnostic conundrum on a child with XLA. And since we have so many experts in the audience, I thought I would share this problem that we had with a 6-year-old boy with sensory neural hearing impairment who had 2 hospitalizations for fever, and he had absent CD19. He had 0 BTK expression on CD14 positive monocytes. So CD19 absent, 0 BTK expression, and he also had a contiguous deletion of exon 6 to 19 encompassing the BTK and the whole TIM-HA genes. And he actually had, he had a surgery, a cochlear implant, but it didn't really help him. And you can see the pedigree chart, which shows that another of his first cousins was also affected. And this child had high IgG levels and IgE levels. So we are working with Professor Manisha Madkaiker to solve this diagnostic conundrum. So to conclude, I would like to thank all the people who have been working with us. Dr. Aravindan, who was actually instrumental in giving us inspiration, Dr. Vinod Skaria, and Dr. Sridhar Shivasubu, and Abhinav Jain from IGIB, Dr. Shaini from the Department of Pathology, Atulya, and Dr. Dhanasuraj, and Krishna Kumar from IMHANS. And this is this wonderful collaborative program, which we've been running for the last 6 years. I'd also like to thank Dr. Revati Raj, Dr. Manisha Madkaiker, and of course, Dr. Sudhir. Thank you so much for listening to me.
Yes, Dr. Poddar or Dr. Mala.
I'm sorry, I couldn't unmute myself. Thank you, Dr. Geeta Govindaraj, for giving a fantastic talk, showing interesting cases. Now, in the chat box, there's not many questions. Dr. Pooja Malhotra has rightly given the answer to Dr. Geeta's quiz, that case with hyper IgE syndrome. You asked to the audience. So the credit goes to Dr. Pooja Malhotra. Then there is a question from Dr. Dhania Lakshmi Narayan. He said that was the variant seen in his mother also and sister? The same genetic variant.
Yes, Dhanya, we were able to find that the mother was a carrier as well.
Okay, Dr. Geeta, I have a layman's question. This is a common conflict down between the pediatrician and immunologist. We had a this kind of problem. When should we suspect and refer a case to immunology? Means commonly after how many infections? Like the child is coming with recurrent respiratory infection, after what number will you say, okay, this is the time? Because respiratory infection is quite common. Diarrhea is quite common in infancy. Is there any sacrosanct number? Or just to modify it a little bit, like we get the deep-seated infection. Liver abscess is quite common in my practice of pediatric gastro. So is it that all liver abscess patients should be investigated for immune deficiency?
It is a good idea to investigate upfront, especially to screen. From our experience, if you wait for 2 pneumonias in a year, or if you wait for 4 ear infections in a year, that really doesn't help. So if you have a clinical suspicion, especially if you have a positive family history, there's no doubt at all. But even otherwise, if there is something unusual, so a normal child, why we always need to ask the question why. So why has this child, who has been normal until now, suddenly developed a liver abscess? So then it's a very good idea to screen. We lose nothing and we gain so much. So we can do the nitroblue tetrazolium test. We can just do an immunoglobulin profile. So the first line investigation, it's never a bad idea to do. And always to have our thinking caps on and always expect the unexpected.
Okay, thank you, Dr. Geeta. I don't see any question in the chat box, and probably we have finished our time. Thank you very much, Dr. Geeta. Now I will ask Dr. Mala Kumar to introduce the next speaker.
Thank you.
Thank you, Dr. Ujjwal. The next speaker is Dr. Amit Rawat. He is Professor of Pediatric Allergy and Immunology at PGI Chandigarh. He is a pathologist with special interest in immunology, and he has set up the PID lab services in the Advanced Pediatric Center in Chandigarh. Welcome, Dr. Amit.
Thank you, Dr. Mala. Just start sharing my screen. Can you see my screen now?
No, we are not able to. We are able to see you on the B side.
And your beard.
And your beard.
Amitabh Bachchan background.
So are you having any? Yes, now we can. Yes, it is starting to come, hopefully. Has started sharing screen.
You look good.
Thank you, sir.
Is your slides very heavy? Do they have too many pictures?
It has been showing that the screening has stopped as the share window is closed.
Okay, let me just see the issues.
So how are you, Amit?
You have the permission to share. You just share it.
Okay.
Just try again. Try once more. Dr. Amit, is there any issue? Otherwise, you can email and we can share from here if there's
I'm trying to see.
It's at the bottom. Yes, it's showing that it has started sharing. Yeah, you have to select your slide. You have to first open the presentation.
The presentation is opened. Okay.
Then we are able to see your file list.
Can
We
you
are
see
seeing
it
your
now?
file list. Yes, we are able to see your screen, but we are seeing only the file list.
Okay.
We're not seeing your presentation.
The
You have to
presentation
select that one. So
okay.
you select that one. You go to share screen where your presentation is, because you must be having multiple windows open. So select that window and that will be shown there.
Okay.
Sure.
Can you see
Yes,
it now?
it is there. It's there. Yes, yes.
I'm sorry for the goof up.
No issues, no issues. We are all learning.
So
Yes.
I have actually not done a webinar for quite long. So I will be talking briefly about the laboratory diagnosis of inborn errors of immunity. It's a vast topic, and I'll try to just give a flavor of this in 25 minutes. So before coming on to the topic per se, I would like to all the participants to go through these two important papers. So the IUIS has a classification committee on human inborn errors of immunity, which comes up with the updated classification every 2 years. And the recent one was in 2019. However, another update has appeared in Jan 2021 because we will not have a formal classification update in 2021. So in this, 29 disorders have been, 26 additional disorders have been included. So PIDs, as some of the earlier speakers have highlighted, are divided into 10 categories, including immunodeficiencies affecting cellular and humoral immunity, combined immunodeficiencies with associated and syndromic features, predominantly antibody deficiency, diseases of immune dysregulation, congenital defects of phagocyte number, function of both. Then we have defects in intrinsic immunity, autoinflammatory disorders, complement deficiencies, and then we have a new category which was added in 2019 classification, the bone marrow failure syndrome, and we have a phenocopies of inborn errors of immunity, which include immune defects resulting from autoantibodies or somatic mutations. So if you can see the figure here, the bar chart here, what it shows is that the exponential increase in the number of genes which have been described in PIDs in the last decade has been mainly as a result of the powerful and high throughput sequencing technologies which have been available. And each year we are adding a number of genes, new genes to the growing list of PIDs. And this is the result of the powerful high throughput technology of next generation sequencing. So how would you approach a PID? So there is no sacrosanct or one method or to start screening. Some would advocate that you would straight away go ahead with the gene sequencing, follow it up with functional studies, enzyme studies, cytokine and receptor studies. You can do a CBC differential, which is of course done in all cases, or you can go from the top to bottom. I mean, you can look at the flow cytometry, the animal models, and gene sequencing. So both the approaches are correct, and the approach could vary from on a case-to-case basis. So there is no fixed way to do it. And so when we encounter a family with a suspected PID, we can first do the functional analysis. We can do the flow cytometry. We can do the immunoglobulin analysis by nephrometry. And then depending on the results, if we have narrowed down our gene list, we could do a targeted sequencing, a Sanger sequencing, or a targeted gene panel, or we could go for exome sequencing. Or as I said, we could straight away move to exome sequencing and depending on the result, to the function analysis. So what are the tools, laboratory tools that we have in hand for diagnosing these diseases? So we have the nephrometry, from which we can get the results about immunoglobulins, the IgG subclasses, complements, including C1 inhibitor. Some turbidimeters can also do an automated CH50. Then we can move on to flow cytometry for investigating the various surface and intracellular molecules. We can do functional studies. In certain diseases, ELISAs or suspension bead arrays, especially if you want to do a number of cytokines and limited amount of sample, the suspension beader is using the Luminex technology, they can be useful. And then finally, to confirm the diagnosis, you can move on to genetic sequencing, and depending upon what is the likely gene, or if you're sure about one gene, or the gene you know is not very long, has hotspots, or then you can go for Sanger sequencing, or you can use the next generation sequencing technologies available now. So I will not be going into the basics of flow cytometry, but the applications of flow cytometry in the diagnosis of inborn errors of immunity. So how can flow cytometry help in the evaluation of a suspected inborn error of immunity? The evaluation of PIDs with flow cytometry helps us to enumerate different populations and subpopulations which can be abnormal in different PIDs. It can help us detect protein molecules which are present on the surface of cells or intracellularly. It can also give us an idea of what the functional abnormalities in different immune cells. Additionally, it can also help us to, in the case of a novel variant, it can help us to validate the functional effect of the variant, so that we functionally validate that this particular variant has got a functional impact on the immune system. And in this regard, it holds a promise of redemption from the woes of the variants of undetermined significance, which are a bane with this NGS technologies. And also, additionally, I have put up that testing could also help in post-translational testing for post-transplantation chimerism. So I'll be moving to diseases, the different categories. So first, that immune deficiencies which affect both humoral and cellular immunity. The prototype disorder is severe combined immunodeficiency, which is epitomized by the bubble boy, David Vetter. So this is David Vetter, who was born with SCID. And this is his physician, William Scherer, and he lived in this bubble for over a decade before he was transplanted, but then he succumbed to the EBV-related complications. So how can flow cytometry help in the diagnosis of severe combined immunodeficiency? So if you do flow cytometry, these children, obviously, most of them will present with lymphopenia. And if you do a flow cytometry, the upper panel here shows the control, which has got normal proportions of the CD3 positive T cells, CD19 positive B cells, and normal NK cells. Whereas this child with T plus, B minus, NK plus, that meaning that T lymphocytes are present, B lymphocytes are absent, and NK are absent. And then you could have T minus, B plus, NK minus kit, where the proportion of T cells is reduced, the B and NK are normal. And then you could also have a different other kinds of skid, T minus, B minus, exemplified by the RAG defects, the Artemis defects, the T minus, B plus, NK plus, most commonly by the IL-7 receptor defect. And in addition to doing peripheral blood phenotyping to classify these skids into T minus or T minus, B minus, or T plus, T minus, B minus, NK plus, or T minus, B plus, NK minus, you can also do surface staining for different molecules. So in this figure, you should see a case of IL-7 receptor defect skid, where the upper panel shows a normal healthy control, and the patient, you see there is a reduced expression of CD127, confirming a diagnosis of skid due to IL-7 receptor defect. You could also do a CD132, which stands for the common gamma chain, and as you can see here, that on the lymphocytes, the expression of CD132 is decreased compared to control. In addition to these surface staining, you can do functional studies in cases of STIDs as well. So if you stimulate the whole blood with recombinant interferon, recombinant IL-2, and then look for the expression of P-STAT. This is a case from a IL-2 receptor defect skid. And as you can see in the control, there is a normal shift. There's a normal expression of P-STAT5 on gated lymphocytes after stimulation with recombinant IL-2, whereas in the patient, there is no expression of P-STAT upon stimulation with IL-2, indicating that there is a defect in the IL-2 receptor. Additionally, as has been highlighted in one of the oral talks earlier, HLA-DR is an important molecule which can be used to detect MSC class 2 deficiency, but in addition, this is also expressed in increased quantities in children with Omenn syndrome. Omenn syndrome is a variant of STID where you have a oligoclonal population of T cells, which and they are there is a high expression of, as you can see in the panel on the down, that the gated CD3 positive cells, they show an increased amount of increased expression of HLA-DR. So normally HLA-DR is a MSC class 2 molecule which is present on antigen presenting cells, but the activated T cells also express HLA-DR, but these abnormal oligoclonal T cells express high amounts in Omenn syndrome. So the next group of disorders is combined immunodeficiency with associated or syndromic features. So in this, I have taken a case of Wiskott-Aldrich syndrome. So Wiskott-Aldrich syndrome can be detected by flow cytometry by looking for the expression of Wiskott-Aldrich syndrome protein on the lymphocytes. So the upper panel shows the control, the patient pre-BMT. So in the control, there is a normal expression. In the patient before BMT, there is no expression of VAS protein. And post-transplant, as you can see, when there has been engraftment, there is a normal expression of VAS protein. In fact, it's more than the control. So the predominantly antibody deficiencies, similarly, they will have the patients, if you do the basic investigation, the serum immunoglobulins, the different isotypes may be decreased. And when you do a lymphocyte subset analysis, this is from a case with X-linked gamma globulinemia. So you use CD45, which is a leukocyte common antigen, and site scatter to gate out your lymphocytes. And then you look for the different proportions of different cells. So this patient here has got normal proportions of E cells, CD3 positive 87%. However, there are no B cells, and the NK cells, which are CD56 positive, they are also normal. So this is a male child with a history of normally expressed on B cells, it is not expressed on T cells. So you have so you have to look for the expression of these cells on this protein on the CD14 positive monocytes. And when you gate on the monocytes and look for the protein, as you can see in this case, it is absent. So moving on to the next group of disorders, the diseases of immune dysregulation. So the commonest defect in the diseases of immune dysregulation, one of the commonest is HLH. We had a nice lecture from Michael Jordan yesterday, and this control, in the control you can see that when we gate the CD56 positive, CD3 negative NK cells and look for the expression of perforin, it is normal. Whereas in the patient, you see that there is almost absent absent perforin expression. So this was proven perforin resistance variant, where this perforin protein expression was absent on the NK cells. Other forms of HLH can present with the abnormal granule release. So here you see that we have gated on again on 56 and 8 positive, 56 positive and 8 negative, and then you see that these cells, they're showing decreased granule release compared to control. This was from a case of Griscelli type 2. So the next group of disorders are congenital defects of phagocyte number or function, and this group, the prototypic disorder, is a chronic granulomatous disease. So as you can see, this is the NADPH oxidase complex, which has got different component proteins. The NOX2 is the C by BB. Then you have some cytosolic proteins, P67, P47, P40, and then you have C by BA, which encodes for P22. These two are membrane-bound proteins on the endosomes, and the P67, P47, and P40 are cytosolic proteins. And defects of in any of these can result in CGD. So how can you look for these defects? So the most common test that we do for this defect is a dihydrorhodamine 1,2,3 flow-based assay. The first panel, the panel on the left, depicts the DHR in a healthy control. As you can see, upon stimulation with the PMA, there is a good shift to the right. with a good SI and delta MFI, whereas in the patient, there is no shift upon stimulation. We've gated on the neutrophils, there's no shift indicating that this is a case of CGD. And then when we do the same in the mother, you can see there are two peaks. So females have two X chromosomes and one of them is randomly inactivated. So you in females, you have got two peaks. So this indicates that this is a, in addition to confirming this, that mother is a carrier, it also tells us that this is probably a case of X-linked CGD. You can also look for the expression of different component proteins of the NADPH oxidase, like D558 for the your GP91 FOX and P22 FOX. You can look for P47, P67, but for the sake of time, I've not included all those. The next category I've included are the defects in the innate and intrinsic and innate immunity. And here we have the most classical disorders in this category is a Mendelian susceptibility to mycobacterial diseases. And in this group of disorders, there is a defect in the IL-12 IFN gamma axis. Here you can see that this is a flow cytometry data from a IL-12 receptor beta-1 expression on activated T cells. The PBMCs are separated. They are stimulated with PHA for 72 hours. And upon stimulation, there is a decrease. You can see there is a decreased expression of IL-12 receptor beta-1 in the patient compared to control, indicating that this is a IL-12 receptor beta-1 defect, which is the most common defect in patients with MSMD. In addition to this expression, you can also do a functional analysis where you stimulate the PBMCs and then look for, with IL-12, recombinant IL-12, and look for P-STAT expression. And as you can see here, there is a decreased expression indicating that it is there is a defect in the IL-12 receptor beta-1. It could be also in the beta-2. IFN gamma R1 and R2 can also be measured by flow cytometry on the surface of monocytes and neutrophils. And in this case, you see IFN gamma expression in the patient with partial dominant form of IFN gamma. So in contrast to patients who have the autosomal recessive forms of IFN gamma R1, the expression of IFN gamma R1 protein is increased in the patients compared to controls. So that was about flow cytometry. Moving quickly on to the genetic diagnosis of inborn errors of immunity. So does it matter? Yes, I think it does. It provides a definitive diagnosis, at times resolving a long diagnostic odyssey. It has implications for more and more targeted drugs or personalized medicine, which are available for some of these defects. It can detect unusual or atypical phenotypes of known PIDs. New genes, it can detect new genes for previous PIDs. It has high helps in advocacy for patient benefits. It has implications for undiagnosed family members. It also helps in genetic and antenatal diagnosis. So what are the different methodologies which are available for genetic analysis? So if you have only a few or a couple of genes or a small number of genes, you could still do, or you have a hotspot areas in the gene, you could do a Sanger sequencing. You could also do a massively parallel sequencing if you don't have a you don't have a short list of genes or a few genes. You could go for a targeted gene panel. You could do exome sequencing, or if you have enough money, you could even go for whole genome sequencing. In addition, there are some variants which will not be picked up by any of these technologies, where you would have to go for resolve to RNA sequencing. And for copy number variations, which are very difficult to detect on exome sequencing, you will have to look for, depending on the size of the copy number variation, you could have to do a conventional karyotyping, a FISH, or a chromosomal microarray. So these are the different genetic technologies which are available. So the Sanger sequencing is the gold standard. It can detect splice site variants. The data is limited to the specific genes or exons you have sequenced. It is extensive, expensive, and labor intensive, and it is slow. The NGS panels, they have a high sequence coverage, 200 to 300 is typical. They can detect somatic variants. The data is only on the genes which are included in your panel. They're relatively inexpensive compared to whole exome sequencing or whole genome sequencing. They might miss intronic and splice site variants. They are rapid. The whole exome sequencing has a moderate coverage of 30 to 100x. But there is an inherent bias in this approach, depending on what capture methods you have used to capture the exome. The data is only focused on the coding regions, so you will have missed non-coding regions. It is less expensive compared to your Sanger sequencing for cost per gene, sequencing per gene. Large, however, it can miss large insertion deletions, and it is also rapid. The whole genome sequencing has got a limited coverage. However, it is the best when the bias-free approach, and you have a data on the whole genome. However, it is expensive. It can also miss some insertion deletions, and it is rapid. In fact, now with some technologies, you can do a whole genome before even a whole exome. So I'll briefly tell you about Sanger sequencing. So Sanger sequencing basically has two reactions: amplification PCR, where you have a set of primers for your target, you have a polymerase, you have DNTPs and primers. So after you have got an amplified product, you go in for the second reaction, which is a sequencing PCR. Here you use, instead of using only DNTPs, you use a mixture of dideoxy NTPs, nucleotides, and deoxy nucleotides. And wherever this dideoxy nucleotides are incorporated, there's a chain termination, and then the different fragments are resolved according to the in a capillary. This all process is automated and it's fluorescence based, and then the readout is a chromatogram or electrophotogram which you get. So I'll just show you a couple of these. So this is a child with a HLH due to perforin defect, where there was a compound heterozygous mutation. So you can see that the child is heterozygous at this particular locus, and this mutation he got it from the mother, and the other one which he got from the father. And this is a heterozygous variant in the card 15 or the NOD2 in a child with Blau syndrome. She had the common mutation arginine 334-2 tryptophan. So what are the different NGS technologies which are available for sequencing? So the most widely used is the sequencing by synthesis, which is patented by Illumina. We have got electrochemical sequencing from ion torrent, where what you detect is when a nucleotide is incorporated, a hydrogen ion is released, which results in a change in the pH, and this then results in a gradient which is sensed by the sensor layer, and this then gives out readout as a nucleotides. Then you have got both these technologies, the sequencing by synthesis and the electrochemical sequencing by ion torrent. They give shorter reads, typically of 100-150 base pairs. But we have other technologies like the single molecule sequencing by PacBio and the nanopore sequencing by Oxford Nanopore, which gives long reads. However, the sequencing by Oxford Nanopore has got a lot of errors, and it is not yet been validated for use in clinical practice. So apart from the sequencing technologies, you might have to resort to other genetic tests like array CGH when you are suspecting a large deletion or a chromosomal rearrangement, or a FISH when you're expecting a deletion. For example, in a Dijot syndrome, you could do a FISH or you could do a MLPA. So these are some IGV snapshots from a few cases. So you can see this is a child with a X-linked A-gamma globulinemia, and here there was a missense mutation in the exon 18 of the BTK gene. This is a child with GATA2 deficiency, and as you can see, there's a 10 nucleotide deletion. This is a heterozygous deletion because you can see that there is not all the reads have the same. It is not present on all the reads, so it is a heterozygous variant in the GATA2 gene. There are some difficult to sequence areas. For example, genes which have got pseudogenes, they are difficult to sequence, and we have seen that in CGD with in autosomal recessive CGD because of NCF1 gene defect. There are no reads from the exon 2, and it can and when there are large deletions, you see that there are no reads from those particular exons. So this is a deletion of exons 10, 11, and 12 in a child with BTK. This was confirmed later by cDNA sequencing. In addition, you can also do a multiplex PCR. You can also do a multiplex ligation-dependent probe amplification for deletions. And this is MLPA data from a child with T minus, B minus, NK plus kid, where in the child you see a homozygous deletion in the exons of the Artemis or the BCL RE1C gene, and the parents are heterozygous carriers. So moving quickly on prenatal diagnosis. So the workflow is that you do a CVS sampling at 12 weeks, follow the DNA is extracted from the CVS sample, you do a VNPR analysis to rule out maternal contamination, you do amylogen PCR in case of X-linked diseases, then you do a PCR amplification using specific primers, confirm that on gel electrophoresis, and then you do a Sanger sequencing and you give the result whether the fetus is affected or not. So coming finally again, so there is always a dilemma what to do when you're suspecting a case of PID. So either you could start with straight away to the whole genome sequencing or whole exome sequencing, or you might have intermediate steps where you could do cellular or biochemical assays like ELISAs or suspension arrays, or you could do a flow cytometry and follow it. And when you have some genes in mind, then you could do maybe a Sanger sequencing, or you can go away to whole genome sequencing. And if you find a novel variant, then you can do animal studies, and based on those results, you can have targeted therapies for your patients. Thank you.
Thank you, Dr. Amit, for a very lucid talk. And I'm sorry I'm not very well versed with the lab in PID. A little I know about PIDs, the clinical aspects, but I'm sure those who are more initiated really enjoyed your lecture. It was so simplified and the pictures were beautiful, and all the flow cytometer diagrams and figures you had shown. Thank you very much. There are no questions in the chat box for you. So, Dr. Amita, in case you want to say something.
Thank you, Dr. Mala and Ujjal for chairing these sessions, and Amit for an extensive, exhaustive talk. So I think you covered everything. That's why the students didn't have any questions left to ask. Thanks a lot, Amit. And we move on to the next sessions, and I will ask you questions after the session is over. So we move on to the next sessions, and Dr. Anshu Srivastav, who is professor of in the Department of Pediatric Gastroenterology, is going to chair this session. Anshu, are you there?
Yes, ma'am. Can you hear me?
Yeah. So yes, now we can see you. So, and Anshu is going to look after 3 sessions, which are basically all case-based discussions. So we hope, because the students always enjoy cases, so that is why we thought that we will have these 20-minute sessions. This is a full 1-hour session with 3 sections of antibody deficiencies, T-cell deficiencies, and neutrophil defect. So over to Anshu.
Thank you, ma'am. So after having heard 2 sessions, one on when to suspect and then how to evaluate immunodeficiency, pre-ID in children, I think we'll move on to the first case-based discussion, which is on antibody deficiencies. And this would be done by Dr. Lisa Rajshekharan. She is the head of the Department of Clinical Immunology and Rheumatology at NIMS, Hyderabad. And her major areas of interest are lupus and myositis, but she runs the PID Center for Immunodeficiency Disorders at NIMS. Welcome, Dr. Lisa. And without taking any time, I would like to start the session.
I'm going to share my slides. So please let me know if everything is okay, my audio and video.
Yeah, we can see and hear you also.
Thank you. It's nice to be here with the ISPID members, trying to charm 150 in the audience to assure them that the diagnosis of primary immunodeficiency is not surfing on choppy, turbulent beach waters, but it's a privilege, and I thank the organizers for that. While talking about antibody deficiencies through case-based discussions, I would like to start with a few important housekeeping information. One which Dr. Amit has covered in the classification of PID. What I would like the audience to focus is that antibody deficiencies need not necessarily be isolated antibody deficiencies. They often come in association with T-cell deficiencies or they may come associated with certain syndromic features. And these are the predominant groups under which we should keep in mind when we are faced with a lab report which tells us, which suggests the possibility of an antibody deficiency. Along with this, there is also the phenocopies of PID, which are not inherited disorders, but which are acquired sporadic disorders which could mimic primary inherited immunodeficiencies. Now, if you look at this cartoon, which is taken from the ESID registry, then you will see that the ribbon is fraying from left to right. This cartoon, I just wanted you to show, to suggest that what starts off as a diagnosis on the left gets modified to different diagnosis on the right based on further inputs which accrue during the life cycle of the patient, which includes further manifestations and which can include refinement in diagnostic tests as and when centers become more equipped or it becomes feasible to transport samples for better studies. So this happens even at highly established centers, and that again has to be kept in mind when we diagnose antibody deficiencies in the clinic. In most tertiary care centers, it's easy to obtain immunoglobulin levels, the isotype levels. What is important before we start thinking of antibody deficiencies is to note that the levels of the isotypes, they vary with age. If you look at the IgG levels across the lifespan of a particular patient, then generally it starts from a peak at birth from the passively transferred maternal antibodies to a dip between 3 months and then gradual attainment of the peak levels by 2 to 3 years. The blue bars indicate the lower limits of normal and the orange bar indicates the upper limit of normal. And if you look at the legends, then you'll realize that in adults, a value of 300 milligram per deciliter also may be normal, and highest values may, of course, we are not really concerned with in this particular talk. If you look at the way IgA levels behave in life, then you will see that you have very low levels till around 2 to 3 years of age, and then they start picking up. And this has to be kept in mind when we look at young children and we find that they have isolated deficiencies or low levels of IgA. If you look at IgM, then the adult values are achieved by 1 year and they remain stable with values ranging from 25 to 250 to 300 milligram per deciliter. Now, the prototype of antibody deficiency is the hypogammaglobulinemia with absent B cells. And I would just like you to keep in mind these 5 arrows which are being seen on this screen and the receptor which is shown on the B cell surface. What the point I want to make here is that while BTK is the most celebrated example of hypogammaglobulinemia with absent B cells, there are many other molecules which can produce the same lab phenotype. And these include the surrogate light chain delta 5, the Ig mu, who is experiencing recurrent infections. Now, look at this case, a 3-year-old male born out of non-consanguineous marriage with frequent hospitalizations for respiratory tract infections, gastroenteritis, coming with inflammatory arthritis of 4 months duration, and exhibiting deforming arthritis with synovitis, with exuberant synovitis of the large joints. The patient had a low weight, had anemia, leukocytosis, thrombocytosis, and a low titer rheumatoid factor positivity. The synovial fluid culture was sterile, and the biopsy showed evidence of an inflammatory synovitis. There was pan-hypogammaglobulinemia, and flow cytometry revealed low B cells. So here, with the infections and with the inflammatory synovitis, we made a probable diagnosis of X-linked agammaglobulinemia. I have heard the reservations which are genuine when we talk about making provisional diagnosis like this on the bedside, but this is often what we are able to reach in quite a few tertiary care centers. But the story goes on to another child who is 15 months old, and this time presents with many painful lesions of the skin, hands, legs, and back, with episodes of 1 or 2 infections in this journey of 15 months, but lesions on the hands and legs, which raise the possibility of pyoderma gangrenosum or vasculitis. But he shows evidence of pan-hypogammaglobulinemia with very low B cells. again, a provisional diagnosis of XLA is made. And if you see here, if you look at his expected IgG levels, they should be between 210 to 1400, and these are obviously very low. Now, this is a very important paper which I thought Dr. Rawat would present, in which 145 definite or probable cases of XLA have been collected from all across the country and published very recently. And these arrows point to the two patients which our center has contributed. What I'm trying to show here is that in these 185 patients who had significant mutations which are considered significant pathologically, there is so much variation in what mutations can happen, the types of mutations, the exons which are affected, the introns which are affected, leading to a phenotype which, as we have discussed during the day, can vary from presentation and death very early to survival into deep adulthood, and yet carrying the same diagnosis of an X-linked gamma globulinemia with mutations in the BTK gene. There were two questions raised about how do we explain raised IgE levels, or how do we explain that there are 1 or 2% of B cells. Now, there are many explanations, some of which say that survival factors like the BCL2 gene, they override these absence of BTK molecules within the cytoplasm and provide survival signals to the B cells. So there is a lot which goes on within the immune system, which has many pathways. However, coming back to the bedside, if you look at for lymphopenia and you have a pretty old person, then and an associated thymoma with or without myasthenia gravis, then you're looking at a classic Good syndrome, which was first described in 1955. And this is said to be one subset in the big category of CVID. CVID is common variable immunodeficiency. Here, in contrast to panhypogammaglobulinemia, you may have normal levels of IgM and important manifestations like autoimmunity, granulomatous disease, and proving that there's no profound T cell deficiency. So this slide basically comes from the ESID definition of CVID. And it is important to note that ESID states that these are all clinical definitions of syndromes, but we must realize that we will have to do immunophenotyping of B cells and showing that there is no numerically T cell deficiency or a functional T deficiency to prove this diagnosis of CVID. And this has to be kept in mind if you have to be a purist when you diagnose antibody deficiency disorders. So hypogammaglobulinemia can also happen with reduced B cells, and this is what CVID is all about. And if you look at this cartoon of a B cell and its many molecules within the cytoplasm as well as on the surface, then CVID diagnosis is associated with mutations in more than 30 genes. Some important ones are those which are responsible for the BAF signaling, that is a BAF receptor and TACI, the CD19, 2021, CD81, CD27, and the XOL. Now, what is important here is that reduction in CD27 is considered to be a hallmark for the diagnosis of CVID. At another end of the spectrum of antibody deficiencies is the IgA deficiency, which is believed to be much more common in the population where surveys have been done. Quite a lot of them remain asymptomatic for life. Some of them have respiratory and gastroenteric symptoms. Autoimmunity is very common in IgA deficiency. Unlike CVID, the risk of malignancy is very little. In CVID, there is very good evidence to say that there is almost a 25 to 100 times increased risk of malignancy. But as I hinted before, IgA deficiency should be diagnosed after the age of 6 to 7 years when the IgA is very low, less than 7 milligram per deciliter. We know the isotypes of the immunoglobulins. What I want to show here is that in IgA also, there are two subclasses, alpha 1 and alpha 2, and you can have deficiencies in either of them. IgG, as we all know, has 4 subclasses, and again, each one of them may have to be assayed in case the total immunoglobulins are normal. So this leads us to one important group in ESID, that is the unclassified antibody deficiency, where there is recurrent severe infection, autoimmune manifestations, and any one of the IgG, IgA, or IgM may be low. It is also possible that everything may be normal, and then we will have to look at IgG subclasses with nephelometry, as Dr. Amit told us. And we have to demonstrate the absence of response to vaccine, which is again a challenge which Dr. Gupta has set all of us, and probably Dr. Amita is trying to meet that challenge. So look at this case now. This is an 8-year-old female child born of a non-consanguineous marriage with recurrent attacks of infection from 3 years of age, and at 4 years developed ocular telangiectasia and ataxia. So obviously this is leading to a diagnosis of ataxia telangiectasia because there is infection also. She also had a brother who was 10 years old and had almost a similar history. This girl had severe IgA deficiency. She had autoimmunity in the form of direct Coombs test positivity, and she had reduced B cells. She, because of her recurrent infections, she had evidence of extensive bronchiectasis on the left lung with reduced volume and a herniation of the right lung on the left side requiring a pneumonectomy, which biopsy which showed necrotizing granulomas in the lung, which were non-caseating, suggesting that this was a granulomatous lung disorder in a patient with ataxia telangiectasia. The genetic mutations in both the brother and the sister were identified. The ATM gene was defective with these particular mutations. Now we also have antibody deficiencies in T minus, B minus KID, and this is because there are molecules which are required both by T and B cells for survival, differentiation, and maturation, and absence of these can lead to a severe combined immunodeficiency. And however, there are other molecules which lead to not so severe deficiencies, so that you may not find the T cell associated infections, you may find B cell infections more. And these include the CD40 or CD40 ligand deficiencies or the ICOS deficiencies. While going through all this, it is very, very important to remember that secondary antibody related immunodeficiency should be ruled out. So which means that you must rule out drug-induced causes of hypogammaglobulinemia, infectious causes, malignancy, and systemic disorders. And this is what a clinician's role is about, as exemplified in many examples given in Dr. Geeta's talk. Now I'll just take you through a few cases which may still be open-ended, but this is to share with you the fact why every iteration of the IUIS is leading to an increase in the number of genetic mutations which are being identified, and the burden which is present on people who do immunology to come to an exact diagnosis in a particular patient. So this is a 1 month old child who had infections in the skin and subcutaneous tissues, who had oral candidiasis, who had moderate thrombocytopenia, and had a little low IgG, a very severe IgA deficiency, and a normal IgM. Now the B cells were very low, the T cells were normal. So in this child with 2 isotype deficiencies and low B cells, should we be thinking of a BTK deficiency? It's a 1 month old child. Mostly it is classically pan-hypogammaglobulinemia, but as I have said, any of this can be associated with IgA, IgG deficiency with normal IgM. So yes, it should be suspected. However, it is said that X-linked agammaglobulinemia is not associated with autoimmunity. However, even in the paper published by Dr. Rawat, out of the 145 patients, almost 40% had some arthritis to go with them. Should we consider, because of only 2 isotype deficiencies, common variable immunodeficiency phenotype here? However, the B cells are supposed to be more than 1% in this group, and it is a diagnosis which is usually considered after the age of 4 years and not before. Because this child has thrombocytopenia, should we consider a syndromic CID? Wiskott-Eldridge is a possibility. There is another disorder called the VIP deficiency. However, if you look at the associated things, then the B cells are not really low. So this child absolutely needs a clinical exome, or it's a whole genome sequencing. And this is the challenges which we face almost every day when we deal with a patient with PID, even though they may have a very easily diagnosable antibody deficiency. Now, should we look at disorders which affect both cellular and humoral immunity? Should we look at SCID in this child? CD19 is low, but you need to have a CD3 T cell lymphopenia to be able to call them SCID. Now, there was a fungal infection, so the T cells is probably abnormal. So should we look at less profound SCID? And yes, there are molecules which can lead to low B cell numbers, low immunoglobulins, and not so severe infections. But again, this would require genetic testing. And even if the, or functional assays of T cells, which are not available in quite a few centers. Now, this child with arthritis and with recurrent diarrhea since childhood, oligoarthritis of both knees, not responding to methotrexate, detected to have low serum immunoglobulins with all isotypes severely reduced, low B cells, with normal growth and development, was diagnosed by gene sequencing to have deletion in intron 9 of the BTK gene, has been receiving immunoglobulins through the FPID for the last 5 years, and has not had one infection since then, has had complete resolution of arthritis, and has completely off methotrexate. So I'm just presented to you variations in what looks like phenotypes which are very similar to each other. Look at this male who again was referred to our unit, which is a rheumatology unit, with a history of undiagnosed oligoarthritis. He was really having bad knee and wrist arthritis, and synovial biopsies had not resulted in a diagnosis. When we saw him, the only thing which struck us was that his labs showed a very low globulin. And then we probed and found that 10 years ago, he had for 8 months a debilitating gastroenteritis. That led us to do the immunoglobulin levels, and we found panhypogammaglobulinemia with low B cells. And that is as far as the story went in this male, because he did not have, and at that point of time, we did not have any funding to investigate him further. So again, is he a BTK deficiency surviving into adulthood? Is he a common variable immunodeficiency phenotype? We don't know. But what we do know, and we will hear and talk by Dr. Sudhir Gupta, that they can be helped irrespective of a complete diagnosis or a most perfect diagnosis. They can be helped with immunoglobulin therapy.
Can I interrupt, please?
Yes, please.
We would because the time is up, so we would
Yes.
like to finish in 2 minutes. Yeah.
So I would just like to finish by saying that normal variations in immunoglobulin isotype levels should be considered before declaring hypogammaglobulinemia. Secondary causes should be excluded. Antibody deficiencies can be associated with T cell defects. The presentations are enumerated below. The normal immunoglobulin levels can be associated with subclass deficiencies or antigen-specific antibody deficiencies. And there are phenotypes of overlap. So bedside predictions of PIDD are a useful exercise, but they are most likely to be inadequate. But most patients can still be helped with IVIG replacement. Thank you for your attention, and thank you for the opportunity.
Thank you very much for a very nice talk. I think there are 2 questions. One has been answered, which was around about publication on levels of IgG-AM in Indian population. I think that has been answered by Dr. Sagar. The other question is if IgA1 or IgA2 is deficient, can such patients have normal total IgA levels?
I know this about IgG, but I'm not sure that I've come across whether these levels are IgA total will be normal or not. And if there's anybody else who can take it up, I would also like to learn.
Yeah, you won't have the normal IgA total if you have one of them. And again, the distribution of A1 and A2 is very different between gastrointestinal tract and respiratory tract, and even in the respiratory tract, in upper and lower respiratory tract. There's not really very much use of doing the subtype of IgA because as I stated, the total IgA will be low if one of those are. So there's really not any necessity of doing the subclasses of IgA. It's important in IgG subclasses, but not in IgA.
Thank you. So I think with this, we'll go to the next session, which is on case-based discussion on T cell deficiency. And the speaker would be Dr. Sagar Batad. He's a pediatric specialist in immunology and rheumatology at Aster CMI Hospital, Bangalore. And he has been able to establish a very good PID center in the last 4 years at the hospital. So welcome, Dr. Sagar, for the talk on T cell deficiencies, a case-based approach.
Good afternoon, one and all. I hope I'm audible
Yeah, you are.
and my screen is seen.
Yes, please go ahead.
Sagar, can we just have a minute with Dr. Biman? He wanted to make a special announcement just before you start. Yes, Biman, you can announce. Or we will have it after your talk then. Doesn't matter. You can go on. I'll just. Okay, Biman has started. Okay.
I think he started sharing his screen. Yeah.
Yes, okay, fine. That's great.
Okay. Can you see the screen now?
Yes, Biman, very well.
Okay, I'll just maximize this. Okay, I just wanted to say, just introduce the society, because this is for the newcomers and people who may be attending this kind of a meeting for the first time. So as you know, this is being done under the aegis of the Indian Society for Primary Immunodeficiency, which was established in 2011. And just to give a small introduction to the society, now we conduct these national and international meetings every year on alternate years. So we have had quite a few national and international conferences. So this is the current one we are having here. This was supposed to be in 2020, but this because of the COVID pandemic, we are having it in March. And so we hold the international conferences supposed to be, it was in this 2021, but we have postponed this so we'll have the 6th international conference on inborn errors of immunity. So as you see, the name has changed now. Now we're calling it inborn errors of immunity. So we'll have this in 3rd to 5th December in the Leela Ambience, Gurgaon. So this is a new event that is coming up. So I want every one of you to mark your calendars and be ready for this meeting from 3rd to 5th December 2021 at Leela Ambience, Gurgaon. So remember this. And we have a host of speakers here. We have a long list of speakers here. And the topics are here. So very interesting topics we have. So this is going to be a mega event with a lot of giants in PID coming to Gurgaon. And so I think you will not miss this event, and please mark your calendars for this event. And we also conduct a lot of annual introductory courses. The last one we had was in Bhopal in March 2020. And we also conduct the outreach CMEs. We had quite a few. The last physical was in Kathmandu in November 2019, but this year in 2020, it were two meetings that were online. One was in Nagpur and the other was in AIMS in September and November. These were the outreach CMEs that the society performs. And I also request you to become members of the society. The life membership fee for this society is just rupees 5,000. You can just visit the website of the society, that's ispid.org.in. Or if you want to put an email, you can just go to put an email at ispid.contact@gmail.com. And there's various advantages of becoming an ISPBIDN, because we conduct all these CMEs and national meetings to which you can get get the CME credit hours. You can get a discount on the registration fee. And he also has access to newsletters, and you can undertake collaborative projects that we do in the people who are involved with the society. So you can get in touch with the people easily if you become a member of the society. And so you can just go to the website and download the form here. You can see here, just click this and you can download the form. Membership fee is rupees 5,000. And you can just do an online transfer, and this is all the details for the account given for the online transfer. And so I request all of you to become members of Indian Society for Primary Immunodeficiencies and keep supporting the cause of PID. Thank you so much. Thank you for being there. Thank you.
Thank you, Dr. Bimal. And I think now we can go back to the talk. Dr.
Yes,
Sagar, please,
yes.
you can start your screen share.
The screen is visible now, right?
Yes.
So at the outset, let me thank the organizers for providing this wonderful opportunity. And it's nice to see around 140 participants on a Sunday afternoon listening to primary immune deficiencies. My job is to talk on T-cell deficiencies, a case-based approach. The objectives of this brief presentation would be to highlight when to suspect a T-cell deficiency, a numerical or a functional one. How can one quickly diagnose severe combined immune deficiency? and to have a case-based discussion. We all know that amongst the white blood cells, lymphocytes are a subset. And amongst the lymphocytes, we have T cells, B cells, and NK cells. On a rough scale, I could say T cells contribute to 70% of these lymphocytes. And that is what is important to understand when we understand the basics of immunology, because if one has absent T cells, he is likely to develop lymphopenia. In other words, when you see lymphopenia, which is persistent, you must be thinking about an underlying T cell deficiency. And for beginners, these are the markers that you would see on a flow cytometer result: T cells CD3, B cells CD19, and NK cells CD56. Now, we all know that T cells have a lot of functions, but what is important to understand is that when an antigen presenting cell presents antigen to the T cell and you get this helper T cell, I believe we know that helper T cells play a central role in the adaptive immune response. And then they do signal to the B cells. The B cells produce antibodies, which are fundamental in handling bacterial infections. The CD4 T cells do signal the macrophages, and activation of these macrophages is very important to handle intracellular pathogens like mycobacteria, fungi, and viruses. And you have those killer T cells which handle viruses and provide tumor surveillance. I present this simple slide to the residents out there because we all know that if there is a T cell dysfunction, you would get host of infections. And that is because a severe T cell deficiency would result in B cell dysfunction. So though the B cell numbers may be normal, the B cells inside the body would not be able to function, and you end up getting hypogammaglobulinemia in some of them and bacterial infections. And you do get opportunistic infections like viral, fungal, and parasitic infections. And that is why the term combined immune deficiency. That means you have a T cell deficiency with B cell dysfunction. The B cell numbers may be normal, yet hypogammaglobulinemia can be noted. And this is one of the basic facts we must know why we call it combined immune deficiency. Now, what is severe combined immune deficiency? This is the severe form of combined immune deficiency. As it is the most severe form, children usually present in early infancy. This is universally fatal if not treated. Most of them would die before the age of 2. That means if you see a 5-year-old child, you should not be making a diagnosis of SCID, severe combined immune deficiency. Now let's take up 2 simple case scenarios. You have the first case here, 6-month-old boy who is unwell from 3 months of age. He presents to us with persistent oral thrush, pneumonia, and a fundus examination shows CMV retinitis. On the other hand, you have the second case who is a 5-year-old boy who is unwell from the age of 1, again has persistent oral thrush, extensive molluscum, pneumonia, and the fundus shows CMV retinitis. So you can see there is a lot of overlap between the 2 cases. And the type of infections that you see here being CMV, Candida, molluscum contagiosum. So these are all opportunistic infections. So in such situation, T cell defect is likely. However, in the first case scenario, as the child presented quite earlier on, he went on to get the diagnosis of severe combined immune deficiency. On the other hand, the second child, who is still surviving it to the age of 5, is likely a combined immune deficiency. And we today know that the mutations which cause SCID in the hypomorphic state, some of them like hypomorphic RAG1, RAG2 mutations, can present at a later age as CID, the combined immune deficiencies. Let's take up few cases, as this is a case-based discussion. 7-month-old girl from Bangalore presented with severe pneumonia and oral thrush. The first thing that we did was did an HIV test, which was negative. Since the child presented with pneumonia, we got a chest radiograph. And as you can see here, there is pneumonia. But what is very striking in this infant is absent thymus. As pediatricians, we must know that thymic shadow is very prominent in the first few years of life, and absent thymus in an infant means something very sinister. And this was the hemogram. There was marked neutrophilic leukocytosis. The platelet count was normal. So the resident felt this may be septicemia because there is remarkable neutrophilia. But I think this has been aptly highlighted in all the previous talks that one must look at the differential counts carefully. The absolute lymphocyte count here was 1200. Any lymphocyte count below 3000 persistent in infancy means this is likely a case of severe combined immune deficiency. So we went ahead and performed the lymphocyte subsets. As I previously highlighted, we did this, the T cell, B cell, NK cells. And as you can see, here the T cells were only 13%, less than 20%. The T cells were absent, the B cells were absent, and this child had only NK cells. And this is what we call the T minus, B minus, NK plus severe combined immune deficiency. Obviously, the next step would be to perform a genetic test. So what is SCID? SCID is a group of disorders wherein young infants present with multitude of infections, severe pneumonia, often caused by Pneumocystis jirovecii. They may have oral thrush, all kind of opportunistic infections. They often, once they start getting infections, fail to thrive. And since this disease is fatal, you would often see families in our situation where you have family history of early sibling deaths. So if you have a family wherein a previous infant has died and the present child presents to you with infections, kindly consider SCID as a prime possibility. Suspicion on our hand, a close look at the differential counts. And if there is persistent lymphopenia, lymphocyte count of less than 3,000, and the chest radiograph is not showing the thymus, you have almost got the diagnosis. By definition, these children are less than 2 years of age with either less than 20% of CD3 positive T cells or absolute lymphocyte count of less than 3,000 and at least one of the defined mutations. Now, this was another interesting case, a 4.5-month-old boy who presented to us with the very first episode of pneumonia. He was thriving well, and the pediatrician just rang me up and said, I'm referring you a suspected immune deficiency. I was kind of concerned. This child was thriving well, and this was the very first episode of infection, but the pediatrician had something significant to share, a very important family history. The first child had died in his hospital at the age of 5 months with severe pneumonia and ARDS, and they could not arrive at a diagnosis. And since the family and the pediatrician were anxious, the child was referred, and this child was diagnosed to have severe combined immune deficiency. Now you can see if these children are diagnosed early, they may not always fail to thrive. Genetic studies by NGS whole exome confirmed that this boy had pathogenic mutation in the common gamma chain gene, the IL2RG, confirming X-linked severe combined immune deficiency. The parents were counseled. The mother was ready to become the donor for a haploidentical bone marrow transplant, which was performed almost 2.5 years ago, and the child is doing fine. And in the picture, you see Dr. Stalin, the transplanter in the hospital. So what I want to say is that if you diagnose these children early, we can transplant them, we can cure them. Now, this is one more child who is right now admitted in the hospital, a 5.5-month-old boy from Nagpur, who presented with oral thrush and fever and rash for the last 1 month. And these are few clinical pictures. On a closer look, you can see that there is a papular rash all over the body. I would say papulonodular rash. A skin biopsy was performed, and what we could see is that on ZN staining, this was flooded with AFB. This is likely disseminated BCG. And this child was evaluated further, and as you can see on the lymphocyte subsets, the T cells and the NK cells are absent while the B cells are present, and this is the T minus B plus NK minus severe combined immune deficiency. By now you must know that T cells are often absent in most varieties of SCID, whereas the B cells and NK cells may or may not be absent. SCID is a pediatric emergency. Hematopoietic stem cell transplant is curative. If diagnosed at birth or within the first 3.5 months of life, success rate of as high as more than 92% has been reported. At least in our setting, most of these children come infected, but yet we are able to offer a success rate of 70 to 80%. So this is an important slide for all, especially I would say trainees out there, that clinically if you see opportunistic infections in infancy, if these children are failing to thrive, they present to you with persistent diarrhea or sometimes recurrent pneumonia. You look at the family background, you may often get early infantile SIB deaths. Simple investigations like the lymphocyte count, if you get persistent lymphopenia, an absent thymus, non-palpable lymph nodes, tonsils not being seen, this is almost always severe combined immune deficiency. And once you think about this disease, diagnosis is not very difficult. You get a lymphocyte subsets, you preserve an EDTA sample for genetic testing, and you quickly refer such a child where a transplant can be offered. Now, T cell deficiencies are all not about numerical deficiencies. T cell deficiencies can be even functional deficiencies. So what I mean to say is that if T cells are present, yet you can diagnose a child with an immune deficiency. So this is a 5-month-old girl from North Karnataka. She presented to us with ear discharge at 1 month of life, severe pneumonia. To her surprise, she also had hepatomegaly and very high liver enzymes. So we thought this could still be a case of severe combined immune deficiency with disseminated CMV causing the liver involvement. Immunoglobulins were reduced. There was lymphopenia. The absolute lymphocyte counts was 1100, and we almost had made a diagnosis of severe combined immune deficiency. However, the hepatomegaly was striking. And since the hepatomegaly was striking, when an exome sequencing was asked for, to a surprise, we got a mutation in SP110, homozygous recessive gene. This is what we call the hepatic veno-occlusive disease with immunodeficiency. So this is another group of disorders which almost has kid-like presentation in infancy, but they do come with hepatic veno-occlusive disease. And in the past 3 years, we have at least seen 2 children with veno-occlusive disease with immunodeficiency. So sometimes what may appear as kid, the exome sequencing may give you some additional clue. And especially when you see hepatomegaly or deranged liver enzymes, one must think about hepatovenoocclusive disease with immunodeficiency. This is another interesting case, a 1.3-year-old boy who presented from Yemen. He had recurrent pneumonia from 3rd month of life. He had persistent oral thrush. Looking at this history, we felt this must be another case of T-cell deficiency. However, to add to it, this child also had significant motor delay. The other sectors were preserved. The social, the language sectors were preserved, but there was isolated motor delay. And on repeated questioning, the parents reported that the child would not sweat. In fact, there was a positive family history. One more child in the family had expired, and this child also would not have any sweating. So this looked very suspicious. We got an immunoglobulin profile. As you can see, IgG was markedly elevated. Even the IgE was high. And this profile obviously did not look like a typical case of severe combined immune deficiency, and neither the motor delay and absent sweating. And now we know that there are a group of disorders which can present with ectodermal dysplasia, absent sweating, a classical example being immunodeficiency. However, when we investigated this child, the genetic studies on the whole exome showed a novel mutation in STIM1 gene, and what was finally diagnosed to have was STIM1 deficiency. So now what is STIM1? I told you that it is not only important to have T cells in good number, but the T cells have to function when challenged. So we all know that when antigen presenting cell presents antigen to T cell via the T cell receptor, there are multitudes of signals that are given to the T cell, and the T cells get activated. There is also a co-signaling that happens via CD80, CD28. But what is important to remember that we have calcium channels called ORI1 channels. And whenever such T cells are activated, these channels function to have an increased intracellular calcium. And then there is STIM1 protein, and there is a release of endoplasmic reticulum calcium. Such a release of calcium is very essential for T cell activation. In fact, the ORI1 and STIM1, these channels are equally important for function in the muscles. And that is why these patients who have ORI1 and STIM1 deficiency may have myopathy. And you can understand these calcium channels play important role for sweat gland function. So, and because these T cells don't function here, these patients typically present like SCID, but with a normal T cell number. So if you have a child who looks like SCID, but the T cells numbers is normal, you need to really go ahead and investigate. Maybe look at T cell proliferation studies if they are available, or genetic studies. And if you have a child with SCID-like phenotype, absent sweating, you are likely dealing with ORI1 or STIM1 deficiency. So seniors, friends, and colleagues, what I would want to highlight through my brief presentation is that infants with severe infections, one must think about severe combined immune deficiency. Always look at the lymphocyte counts in a sick infant. Family history of sibling deaths, think of immune deficiency. Earlier is the referral, better is the outcome. And beyond numbers, we need to occasionally look at function of these cells when we are diagnosing immune deficiencies. Over the last 4 to 5 years at Aster CMI Hospital, where I'm currently working, being blessed to be with one of the largest pediatric departments, we have had a small cohort of 168 cases with primary immune deficiencies, out of which we can see almost 33 children with severe combined immune deficiency, and the others which have been highlighted have been the combined immune deficiencies, and almost more than a dozen of these kids have received a bone marrow transplant, and more than 28 children have undergone bone marrow transplant for a primary immune deficiency. So to end my talk, I would want to highlight that often when I met pediatricians, they often questioned, is there a small book which we can refer for primary immune deficiency? This is a small effort from our end, wherein a 150-page book has been highlighted for practicing pediatricians, physicians, and medical students, highlighting how to diagnose immune deficiencies with case-based scenarios and providing the age-appropriate norms for such patients. I strongly believe we can all diagnose these conditions and even treat them. Thank you. Thank you once again.
Good job, Sagar. Good job.
Thank you, sir.
Anshu, are you there? You'll have to unmute yourself, Anshu. Yes.
Okay.
Yourself.
Yeah, now they was telling the host is not allowing. So that was a very nice talk, Sagar. I have just one question because I'm a gastroenterologist. So this VOD related immunodeficiency, what is the mechanism? Like, does it increase the prothrombotic risk, or is there any other sites where they are predisposed, or it's just the smaller hepatic veins that are thrombosed?
What I've understood by my basic reading is that this is SP110 gene, and it is involved in gene transcription, and it is important for the nuclear function of certain genes which are important for T cell function and likely for endothelial function. Okay. So that is what is why you get this compound manifestation of both veno-occlusive disease and immunodeficiency. And the spectrum is variable, wherein some people can come only with veno-occlusive disease and can have immunodeficiency later. But that is what I have understood.
Okay. The second thing is a very simple thing that I want to ask you is that supposing you have highlighted these infants who are presenting to you with pneumonia, and obviously these pneumonias are refractory to treat. And even once you start suspecting immunodeficiency and proving a diagnosis is going to take a matter of few days. So are there any tips in the management which you would like to suggest should be done while in a suspected immunodeficiency versus a normal pneumonia, which you would like in the management while we are still awaiting the diagnosis?
Sure, ma'am. That's a very valid question, especially if you are suspecting a child with severe combined immune deficiency. Yeah. A lot of things that one can do even before a diagnosis is established. Number one, it would be prudent that a simple test, I would say, is a fundus examination. I have seen at least 3 kids who pick up CMV retinitis, and you are very sure that this is likely SCID at that particular age of 4 to 6 months. The second thing is never give them blood products without irradiation. Always give them irradiated blood products, because it's not a standard practice here in India to give irradiated blood products to all patients, and because they can develop kind of graft versus host disease. And the third thing is it is important to store EDTA sample if you feel that the child is extremely sick. You can later on counsel them for a genetic study. Sometimes we are not able to treat such patients, but at least providing a genetic diagnosis is very crucial. And then I would say these days, the lymphocyte subsets and immunoglobulins are available in 24 hours time, ma'am. Even if you transport sample, I think here we can give the results in 24 hours. So today you suspect and tomorrow you must have at least a reasonable diagnosis.
Would the lymphocyte subset and immunoglobulin levels be affected by a recent blood transfusion? Because many of these children come with a 24 hours ago, they've had a blood transfusion. So does that affect the results?
I would say immunoglobulin profile essentially would not get affected, and because these patients have remarkable hypogammaglobulinemia, and the lymphocyte subsets, I would say, because most often we are giving PRBC transfusion, so I wouldn't say that there should be a very remarkable difference in the lymphocyte subset. What we are looking at absent T cells, so I think
be affected. Yeah. Okay. Thank you very much. I think we are overshooting the time perhaps. So we'll go to the, thank you very much. It was a very nice talk. We go to the next speaker, Dr. Neeta Radhakrishnan. She is the Assistant Professor in Department of Pediatric Hemato-Oncology at the Super Speciality Hospital in Noida. And her special interest is immunodeficiency disorders apart from hematological disorders. And she's going to discuss neutrophil deficiencies, case-based approach. Welcome, Dr. Neeta, and I would request you to start your presentation, please. And we can see your slides, yeah.
Yeah, thank you, ma'am. Good afternoon, everyone. Thank you to the organizing team, Professor Sudhir Gupta sir and Professor Amita Agarwal ma'am for this opportunity. We'll be discussing neutrophil disorders in the next few minutes. So neutrophil disorders constitute around 20% of all the primary immune deficiencies. And like we heard in few of the earlier talks, that this group of disorders are constantly evolving. The IOIS classification, every time it is revised, it has a whole set of new disorders. So these proportions also keep changing with time. Neutrophils, as we know, are the first response to acute infections and are responsible for direct cell killing and cell damage. And whenever faced with a neutrophil disorder, either a neutropenic disorder or a neutrophil function disorder, we do have severe and recurrent infections, usually bacterial and fungal. So this is the IUIS 2019 update, which puts neutrophil disorders in the phagocyte function and defects group, which is section 5. Here again, it has been divided into non-syndromic. Non-syndromic would have the traditional neutropenic disorders, the severe congenital neutropenias, the multiple molecular reasons for that. Whereas a syndromic, which includes conditions where neutropenia is just a part of a whole spectrum of other conditions. This would include bone marrow failure, especially its SDS, which would have neutropenia as the primary manifestations, where other marrow failures would also come. Then there are other disorders which are not related to the bone marrow at all, which would include, say, GSD type 1B, where there is neutropenia as an additional feature, or a SMARCD2, whether there is some bony disorders along with neutropenia. So these are again whole set of new disorders which have come up. When you don't have neutropenia, when you have abundance of neutrophils in the circulation, but they are not functionally good, then you have these functional disorders. Here again, we do know about LAD, which is syndromic, and CGD, which have been traditionally taught of. But there are new additions to this classification like GATA2 and some certain disorders like cystic fibrosis now, which has been classified under these group of phagocyte functional disorders. So before we go to the discussion on case-based discussion, it would be nice to know a little bit of neutrophil biology. So neutrophils essentially in the body exist at 3 locations. One is the bone marrow, where its origin starts from the bone marrow, from the hematopoietic stem cells. And after the maturation, after the mitosis and maturation into a neutrophil, there is a post-mitotic pool which is kept in the marrow and is released into the circulation. So it is held on to in the marrow by CXCR4 receptors. Then when it is released into the circulation, it is in the intravascular system, it is actively circulating, and it looks for any signs of inflammation. So whenever there is an infection or inflammation, there are cytokines that are released, which tell the neutrophil to come to that location. So when it does so, there is this process of rolling. Initially, a roll which is not very tight, a slow roll followed by a firm adhesion to the endothelial surface through integrin receptors. And once that firm adhesion occurs, then there is a migration across this. There is a diapedesis and transmigration across the endothelial cell membrane, and it goes to the site of infection. At the site of infection, there is killing of the phagocyte. It goes basically for a cell kill. So it does it by either a NADPH oxidase related reactive oxygen species, which is released, and through its secretory granules it can kill, or it can kill through these extracellular traps as well. So once the killing it occurred, once it's over, once its function is over, it either undergoes apoptosis or there is a reverse migration that can also occur in the body. So these are the 3 areas, and we'll see how how things can go wrong in these 3 steps. So when you start about marrow, whenever there is a defect in the function, so that you have in the production, you have severe congenital neutropenia group of disorders. When there is a release defect, you have what is called a WHIM syndrome, where there is warts, as well as there is neutrophils in the bone marrow, but there is hardly any neutrophils in the circulation. There is a release defect here. Once in the circulation, when it is not able to have this rolling and addition part, which is when there is abnormality, you have leukocyte addition disorders happening here. And finally, when there is a defect in the clearance part, where in the phagocytic disorders, all your CGD group of disorders come here, where it is not able to do a cell kill. So all the classical feature of all these disorders are they manifest in a similar way. So all of these would have infections, pyogenic infections, but not necessarily pus-forming infections. When there is many times there is no pus in the periphery, so then you may not have, when the neutrophil is not coming to the periphery, either because of severe neutropenia or because of leukocyte addition disorders, there may not be any pus at all, but they're all bacterial or fungal infections. And at times there would be granuloma formation, and there is, because neutrophils are necessary for wound healing, because when there are neutrophilic disorders, there would be poor wound healing as well. And the organisms that we encounter commonly are bacterial infections, again, Staph aureus, GNB infections, Enterobacter, Pseudomonas, all these organisms are commonly encountered, and occasionally Burkholderia, Nocardia, etc. as well. And invasive fungal infections, which would include Aspergillus candida as well. So these are classical examples of neutrophilic disorders where you see there is extensive necrosis, but there is no pus formation. Most of these defects would be fungal, usually rhizopus, fusarium, mucormycosis group of infections. There may not be, again, infections without any pus. There can be thrush along with sick-looking children with severe oral thrush can be a presentation. Agranulocytosis can present with patch in the throat. And then, of course, lesions in the perianal area and the melanoprostoid skin infection can be common in these areas. Even with mild neutropenias, you can get patients who come with these kind of infections in the scrotum and penis. When you call of neutropenia, when you start talking about neutropenia is traditionally 1500 cells, but in infants, even less than 1000 is considered because physiologically there is lymphocytosis in infants. So neutropenia can be considered at an NCS less than 1000. Whenever you are encountering a child with a neutropenia, majority of patients would have something which is an acquired condition. So you're not going to see severe congenital neutropenia frequently. So usually it is a drug-induced cause or an infection-induced cause that is there, the neutropenia, or another condition like a bone marrow disorder, like leukemia, lymphoma, something like that is just presenting with neutropenia. We need to look at whether there are any anomalies, what is the focus of infection. We need to ascertain that there is significant neutropenia, which is persistent and which is severe, and that demands further evaluation. So those chronic neutropenias can be either congenital or neutropenias where there is an immune component to it, like there are other primary immune deficiencies where neutropenia may be a part of, like XLA or hyper IgM syndromes. And then there are other autoimmune neutropenias which can also be seen. So we'll start with one case. She's a 5-year-old girl who has one sibling who is healthy, non-consanguineous parents, who's been having these recurrent skin boils. I'll just show you the boil first before we discuss. So these kind of vesicles which have blood in it since 1 year of age. So there is classically there is no pus formation at all. There is serosanguinous discharge. Every time she has this, the mother would take her to a hospital, give her oral antibiotics, and it gets relieved with that. And occasional fever, cough as well. In 2016, when she had a similar boil in the perianal area, she was started on oral antibiotics, but subsequently that lesion became so severe that by the time she became very sick and was admitted to a medical college, she was diagnosed to have necrotizing fasciitis. The culture from that area grew Staph aureus, and she had to undergo a wide excision and colostomy subsequently. And since recurrent boils persisted, she was referred for evaluation. And you can see the colostomy. Other than that, she was phenotypically normal. She had gingival hyperplasia and nothing else significant on her examination. But if you see the CBCs, you can see that the WBC count is essentially normal, but ANC has always been less than 100. Myeloid monocytes as well as platelet count in these children are usually on the higher side, especially thrombocytosis is seen probably because of recurrent infections. And again, an immunoglobulin profile was done from the referring center, which also showed a higher IgG, probably because of recurrent infections in these children. So this is the marrow that we did, and marrow showed promyelocytes, abnormal promyelocytes. So this is what happens in a child with, severe congenital neutropenia. You would have maturation arrest usually at the promyelocyte stage, and these promyelocytes will be abundant and there would be little abnormal. So this is a paper which says that shows the vesicular characteristic of the promyelocyte also. So in our patient, this was the Elaine mutation that was identified. Yeah. So these are the different mutations. So it is a multi-gene disorder. Multiple new mutations are being identified in this group as well. And these are the common ones. The Kosman syndrome was the one which was earlier identified. This is an autosomal recessive condition. And here there would be other abnormalities as well. And Elaine mutations are in fact the commoner ones. And this is again the European data on severe congenital neutropenias, the percentage of mutations identified across the registry. And there are newer mutations also which are being described. The X-linked, the Viscott-Aldrich gene mutation would actually result in what is called an X-linked neutropenia. These children are going to present with early onset. So it's an innate immune defect. So it is going to come very early in life. So from neonatal period onwards, we're going to see it. They're going to come with recurrent bacterial infections, superficial abscesses, usually skin infections like I showed in the pictures earlier. Pneumonia, otitis media, frequent oral lesions can be seen. And gingival hyperplasia is very characteristic in many of these patients. And it can be so severe that it can result in loss of permanent teeth. Severe congenital neutropenias are a pre-malignant condition. So they would there is clonal hematopoiesis and there would be progression to MDS and myeloid leukemia. And that is all the more reason why these children should be transplanted as early as possible. And this is a paper which shows how there is an evolution. So other than the original mutation that you have, with the passage of time, there would be additional acquired mutations that would come in, and that would result in further clonal hematopoiesis and the progression into myeloid leukemia. So even without myeloid leukemia, this is how their gums look. So this is on the picture on the left is a child with severe congenital neutropenia, and the right is a child with myeloid leukemia. Their gums exactly look the same. So this is this can be seen in severe congenital neutropenia as well as in LAD as well. This is another child, a 3-year-old boy this time, first child, no siblings. Again, repeated history of fever and lymphadenopathy since 6 months of age. Since 6 months. This child was evaluated prior, and as usual, tuberculosis was child was received ATT as well, and TB evaluation was negative. So he was suspected to have a lymphoma at some point, and he underwent a lymph node biopsy that was inconclusive, reactive lymphadenopathy. But the thing is that lymph node biopsy site developed a sinus. So he was referred for that, in fact, for the lymphadenopathy bit and suspicion of Hodgkin lymphoma. But if you see the CBC, 12,000 WBCs, of which just 1% is neutrophils. And on bone marrow examination, there is maturation arrest in the myeloid series, and again, preponderance of monocytes that we're seen. Again, classical diagnosis of severe congenital neutropenia, no siblings. He cannot afford a haploidentical transplant, so he's on follow-up. He's just on oral amoxicillin prophylaxis. And since then, he has remained free of infections. And this is the bone marrow picture. We tried to get a molecular diagnosis here again from 2 different centers, 2 different labs, but both of which were negative. And now we're planning to send it for whole exome sequencing. So this is just to highlight that many conditions with severe congenital neutropenia, we still do not have a molecular reason for it, and we need to look for new mutations that may be there. Reticular dysgenesis again is in that same spectrum of disorder, but here it would be very higher up mutation. So because of that, it would have a SCID phenotype with agranulocytosis. So these children are going to come with very severe cytopenia, very severe leukopenias, WBC count of say 200, 300, etc. So, and these children progress very fast and require transplant early. And there is again, this is again pre-malignant. There could be increased risk of malignancies in the family as well. There is another condition called cyclical neutropenia, which resembles severe congenital neutropenia. That is why when we have a fresh patient, we're supposed to look at CBCs frequently, at least 2 times in a week for around 6 to 8 weeks, before we can be sure that there is no cyclicity, or there is in severe congenital neutropenia, the ANC would remain very low, whichever range it is in. It's usually around 100 to 500. Whereas in cyclical neutropenia, there would be there will be an increase, and usually the cyclicity is around 21 days. And this cyclical fluctuation can be seen in other cells as well. It could be in platelets, it could be in reticulocytes also. And here again, mutations can be seen in the same genes as well. The ELA2 mutation are reported in cyclical neutropenias also. Here, most of the children, it is benign in most of the cases, and these children need to be just on antibiotics if they are suffering from infections, and many a times they will just respond, and after a few years, it just improves on its own. And whenever, if you're planning a bone marrow, you need to plan it before the next nadir occurs. By the time the nadir occurs and then you do a marrow, the marrow is already started to regenerate. So when you are expecting a next nadir, when you have established a cyclicity and you are expecting a next nadir, probably 4 to 5 days prior, a bone marrow should be done so that you can pick up the maturation arrest inside the marrow at that point. Now coming to the second group of disorder where there is defect in the rolling and the diapedesis part is wrong. So here is a 4-month-old child who was brought to a pediatrician with symptoms of URI, but then they were noted to have few lesions on the face, and the child had very high fever. When this evaluation was done, the WBC count was found to be 62,700 and CRP was positive, and hence the child received IV antibiotics from the pediatrician. This was the third child. The first child was well. The second baby had died at 7 months, again due to repeated infections. This was a normal delivery, and umbilical cord had fallen around 2 weeks of time. So here the child was clinically well. By the time the child came to us, the child was clinically well because of the IV antibiotics that had responded also. But when we saw the child, the WBC count was at that time also was 48,700. So a child who has seemingly had a acute bacterial infection, had neutrophilic leukocytosis with response with antibiotics, it should have responded by now. But since the TLC was still remaining high and there was a history of death in the family, we went ahead and evaluated for LAD, and LAD was tagged. There was absence of CD11B and 11C expression that was noted. So leukocyte addition disorders are a group of disorders. Again, they present very early in infancy. Similar infection profile as we saw earlier. A couple of things which are different are, one is there is delayed cord separation, which is characteristically available as a history. And because of repeated skin lung infections, there may be lung infection, especially because of staph, there may be recurrent pneumatoceles which may be seen. And neutrophilia will persist in between episodes of infection as well, and that should be our clue to pick these children up. And despite very high WBC count, like in the images we saw earlier, there'll be inability to form pus. So it will be essentially a serosanguinous fluid that will be seen. And some cases are not so severe, so pus formation may be seen in some children as well. But usually in the classical ones where there is absent CD18, their pus formation will not be observed. So there are three types again, and this again is a group of disorders basically. So LAD1 would have whatever I described right now, where the acute infection you treat with antibiotics, and many a times we would need even granulocyte transfusions as well. And the definitive treatment is only transplant, and now there is gene therapy as well. The LAD type 2 presents a little later. There would be other manifestations like mental retardation, short stature, and they would have Bombay blood group as well. And here, and just prophylaxis and dental care, etc., would be enough. And type 3 is a specific type where there would be additional platelet function disorders as well. And there would be they will have bleeding also. And here again, transplant is required. So we finished this group of disorders. Now we come to the next one. So this is a 2-year-old boy. Again, I think multiple cases have been discussed in the last few sessions on these group of disorders. This is a child who was essentially normal in the first 6 months of life. And since then, since 6 months, you can see that the weight centiles have been falling off the charts. And this child has presented with recurrent episodes of pneumonia and presented at 1.5 years with fever, lymphadenopathy, and again, lymph node abscess, which has grown Staph aureus, and a urine culture, again, bacteria, which is E. coli. Child was suspected to have SCID, and the pediatrician had given off IVIG before referring the child here. And on examination, the child was sick by the time. So it's already 2 years of age. Child has been having repeated infections, febrile tachycardia, tachypnea, and on exam, even oral candidiasis, few cervical lymph nodes, bilateral crepitations, and already pneumonia with a saturation of 88% in room air. And
Dr.
if you can see that,
can I just interrupt you, because there are only 2 minutes left for your talk, so please try.
Yes, ma'am. So here you can see there is neutrophilia, and immunoglobulin profile essentially is normal, and the diagnosis was CGD. And before I wind up, I want to show two more short cases. One is a child, 14-year-old child with severe growth retardation who was diagnosed to have high-risk myeloid leukemia. The myeloid leukemia part went off well, but subsequently he has had multiple episodes of cryptosporidium diarrhea. And when you evaluate further for that, that came out to be GATA2 deficiency, again in the same group of disorders. And another child who has been treated for ALL, but horrendous infection profile, multiple fungi, multiple bacteria growing, and this turned out to be SAMD9L deficiency. So these are groups of disorders that again present with neutrophils. And just to wind up, their neutrophilic disorders need not be neutrophils with related infections need not be all only neutropenic. There are some conditions like, for example, Majid syndrome, you may have neutrophilic dermatosis also as part of the condition. So CBC and DLC is very, very basic, and this is a common investigation which all of us have access to. So close look at differential counts is very important. This is something which we can tell our colleagues, especially our surgical colleagues, before they take up children for surgeries. The differential count should be looked into. The pattern of infection in these group of disorders are very, very characteristics. It's hard to miss. Most of these children would require an early referral for bone marrow transplant, and genetic counseling is vital. Thank you.
Thank you very much for a very illustrative talk. I think there's one question as to in what timeline would you consider a delayed cord falling? Like what?
So the median cord fall is usually 3 days to around 20 days, but anything above 2 weeks is considered abnormal.
Okay. I think that's the only question. So thank you very much. and for the very illustrative cases. I think everybody would have gained by this. And I would like to thank all the three speakers, Dr. Lisa, Dr. Sagar, and Dr. Neeta, for a very nice talk. And with that, I think I would like to end this session. Dr. Amita, do we have any announcements, or otherwise we can proceed?
Thank you, Anshu, for really looking after the three talks, and all the three speakers have done a great job. And we'll move on to the next session because Dr. Sudhir Gupta has to leave for his flight.
Okay.
Okay. No, thank you. So we will invite Professor Archana Kumar, who is going to chair the session. Hello, ma'am. Nice to see you.
Hello. Thank you, Amita, for inviting me to chair this session. And in this session, we have two talks. One is IVIG replacement therapy for PID, and the second one is BMT in PID. For the first talk, I'll invite Dr. Sudhir Gupta. He is the Professor of Medicine, Chief Basic and Clinical Immunology. He is the Director of Programs in Primary Immunodeficiency and Aging, University of California at Irvine, USA. In addition, he is also Director, Jeffrey Model Center for Primary Immunodeficiencies. And above all, he is the person who's really behind all of this PID movement in India. And I would invite Dr. Sudhir Gupta to please present his cases, and we can really see your slides there.
Okay, thank you very much for kind introduction. I'll be brief, and as you can see, I changed the title. Instead of IVIG, I wrote the immunoglobulin replacement therapy and inborn error of immunity. And with my presentation, you will know why I changed the immunoglobulin replacement therapy instead of IVIG. Immunoglobulin replacement therapy is a form of passive immunity. I won't go through this historical aspect, but the first introduction of immunoglobulin replacement therapy was in 1952 that Colonel Bruton used for X-linked agammaglobulinemia, and that he treated with subcutaneous route. So for people from a historical point of view, subcutaneous immunoglobulin administration started way back in 1952. Immunoglobulin G is the one that we have mostly in immunoglobulin preparation. These are polyvalent, polyspecific, because that's what you want in order to protect from multitude of microbes. More than 90% is in monomeric form with traces of IgA and IgM. They're supposed to represent all IgG subclasses in a relatively physiological concentration, and they provide a wide spectrum of specific antibody and antibodies or anti-idiotypic antibodies. They are derived from a large pool, these days from 20 to 50,000 donors, and they should be free from the known viruses. Of course, bacteria is easy. And as you can see, IgG in immunoglobulin is just not IgG. It's a bowl of soup. It contains a lot of material, cytokines, cytokine receptors, MSC antigen, you name it, it has it. And those are the properties that makes it really very attractive, not only in a replacement therapy, but in an immunomodulatory role. There are various ways to, the two terminology you should remember is the recovered plasma versus source plasma. Recovered plasma is where you have the blood volunteer donors from which you recover the plasma. Other one is a source plasma where they're getting the plasmapheresis for something else, and you take the IgG from there. Number of various purification technologies that you have not to go through it in order to make safe. The donors are screened for all the known viruses. After they are screened, their plasma is again rescreened with nucleic acid technology is listed there. And the most important thing is we can only screen what we know. So we have to make sure, just like HIV came out of nowhere, that you have that we make it safe against the unknown microbe. So there are various chemical and physical means by which we inactivate both all sorts of activate envelope and non-envelope viruses. And then comes those mad cow disease or Jakob-Creutzfeldt, so-called prions, and those are removed by nanofiltration. So immunoglobulin preparation are the safest of the plasma products, and that was the reason perhaps not a single case of HIV was ever transmitted through immunoglobulin therapy. Again, I will not go through this. So if you look at the routes of immunoglobulin administration, the old-fashioned was the intramuscular immunoglobulin. Is still in the United States. One company makes it. It is given to all of the Marines when they go out on their Marine duties. But then you have intravenous immunoglobulin that we did a single. You can imagine how complex now it is. When we did the original study in 78, 79, it was a single center study. No IRBs were required. Nothing was required. And we compare intramuscular to intravenous in an antibody deficiency, primarily in XLA, and severe combined and common variable immunodeficiency. And we showed marked superiority, and that became a intravenous immunoglobulin marketed in January of 1981. And then we have another route, which is called a subcutaneous route. And those we have divided into two, a conventional subcutaneous and enzyme-facilitated subcutaneous. They are different companies. They are available in various concentrations. Subcutaneous are only, again, you look at the subcutaneous, they are available in 10%, 16.5%, and a 20%. The immunoglobulin replacement therapy is used as a prophylactic, as therapeutic, and therapeutic as a replacement therapy in a primary antibody deficiency, secondary antibody deficiency, and as a immunomodulatory in a variety of autoimmune disease, most commonly in neuromuscular disorders. There's one contraindication of selective IgA deficiency, and for that, you are required to do anti-IgA antibodies, but those are IgG antibodies, they are worthless. And selective IgA deficiency, having the anaphylaxis, is extremely rare since it was first case reported a long time back. It is a black box warning, but it is a very extremely rare event, even where blood transfusions are given in selective IgA deficiency inadvertently, and there is no case report of anaphylaxis in those. The purpose of the immunoglobulin is to provide as a protective replacement therapy, as well as to do the effector function, also immunomodulatory function. So immunoglobulin provides us a lot of different functions. So prophylaxis is given in low birth weight infant, and of course, you have a hyperimmune immunoglobulin, which is given in varicella zoster, CMV, RSV, and not too long from now, perhaps by next year, you will have the hyperimmune immunoglobulin for COVID-19. It's just I think, okay, let's go. This is a 30-year young female with a history of recurrent infections, was hospitalized, had the bronchiectasis, and on immunological analysis, T cells were normal, B cells were decreased. Patient didn't respond very well to the vaccine, and immunoglobulin, as you can see, GNA were low, IgM was normal, so diagnosis was CVID. Patient was started on IVIG, and patient responded with no infection in past 1 year. These are major indication for immunoglobulin replacement therapy. As you can see, these are all antibody deficiency disorders. Even after bone marrow hematopoietic stem cell transplant, almost the T cells get reconstituted very fast, and patient for 6 months to a year, they really behave like a gamma globulin patient, so you tide over with immunoglobulin therapy. Here is just to give you some idea about how much and what the trough level you require for to keep the patient free from infection. So the left one, the A is less than 4.5 infection a year, B is less than 2.5, and C is with no infection. The blue is XLA, red is common variable immunodeficiency disease. And if you just concentrate on C, in order to keep the patient free from infection, you require a trough level somewhere here, whereas in CVID, you require here. So as you can see, you cannot make any just levels that you need that trough level to be comfortable regardless of the antibody deficiency. It will vary from immunoglobulin deficiency to immunoglobulin deficiency. And here it shows, this is a meta-analysis which was put together from a number of studies showing here the IVIG dose. As you increase the IVIG dose, the trough level increases. So that's not surprising. So for a trough level increases for each 100 milligram per kilogram body weight increase in the dose, about 121 milligram of the trough level. And does that correlate with the decrease in infection? And here's the pneumonias. And as you can see, as the trough level increases, the pneumonia prevalence is decreased. But then it is very important when you as a letter to editor, here are the two patients with CVID, one little older patient, one younger patient. And here you look at the trough levels, which keeps the patient free from infection. So here you look at the left side, here is a 900 milligram per deciliter is the trough level. Whenever the immunoglobulin trough level went down below this, patient has sinusitis and pneumonias. As soon as it was up, patient was free from infection. In case of this boy, this trough level was 700. So when it went below 700, has the pneumonia or sinusitis, wherever it is away. So in one instance, the trough level 700 was sufficient to keep the patient free, that it required 900 trough levels. So what is the ideal dose of immunoglobulin? Is the dose that keeps the patient free from infection. So there's you are not targeting any specific trough levels. So side effects, there are minor side effects which occurs in 10% or more cases. It's mild headache, chills, myalgia, little fever, nausea and vomiting. And majority of these side effects are mostly rate related. You ramp up the patient, you start slowly every 50 minutes, you increase, and then you see what the maximum tolerizing rate is, and you give that to the patient. Every patient is different, so you have to really individualize the patient. So if you give the same rate to 4 different patients, 1 or 2 will come down with such effects. So you can reduce the dose, and also in some cases you give some non-inflammatory drugs like ibuprofen and so. The rare side effects are aseptic meningitis, more commonly seen where high-dose immunoglobulins are given, more commonly in those with autoimmune diseases where high doses are given. And these, you will have a classical nuchal rigidity, you will have severe headache, you can have nausea, vomiting, and you will have the pleocytosis. And of course, there is no organism there, and it will resolve in 48 to 72 hours. But however, you are not going to restart the immunoglobulin in such a cases. You will switch these patients to subcutaneous. Thrombotic episodes, again, rare. There are thrombogenic factors in immunoglobulin. Some of the companies are really trying to reduce those. So if you have the patient with risk factor with hypercoagulability, you have to be very careful. It's not a contraindication, but you have to be very, very careful. If that patient can take subcutaneously, you should switch to subcutaneously. Renal dysfunction these days are not seen anymore because it used to be because high osmolarity is secondary to sucrose as a preservative, which nobody uses anymore. So you are not to worry about it, but still you can, if something of that sort happens, dysfunction, you can prehydrate the patient and then give them immunoglobulin or switch to Subcutaneous immunoglobulin, as you can see, it is subcutaneous. So with IVIG, you get a peak and a trough. Whereas in case of subcutaneous, you get a steady level. So it seems to tolerate better, but as you can see, you have to give almost 30% more of immunoglobulin by subcutaneous in order to get that trough level. So it becomes much more expensive if you think about it. So there are advantages and disadvantages of intravenous and subcutaneous. The disadvantages of intravenous, of course, the venous access, the systemic side effects that we talk about. It takes about 4 or 5 hours to infuse. Subcutaneous, it's a small volume. The disadvantage is because you have to use several sites in order to give. And as I said, you have to give more than 30% more than IV dose, so it is expensive also. So what you can do is enzyme facilitated, because in between in the dermis, you have the hyaluronin, which is like a jello, and that prevents the dispersal of the fluid. And that's why by putting subcutaneously, you can't give large amount. So if you give the hyaluronidase enzyme, you break down those. So here is the example of conventional subcutaneous. So you give subcutaneously, it can't disperse because there are hyaluronin against it. So it compresses over the lymphatics and the blood vessel. And that's why the absorption becomes less. And that's the reason that you give 30% more to achieve the same level. But if you use hyaluronidase, you break that hyaluronin, and therefore now it allows the dispersion of the fluid. And therefore, in case of subcutaneous conventional, because you can't give too much, you have to give every week. So you divide the 1 month dose of IVIG to 4 and give every week. Whereas once you give the hyaluronidase, you inject hyaluronidase, wait for 5 minutes, it breaks down, then you can infuse the entire amount of 1 month in one sitting. And so you can imagine it doesn't compress over the lymphatic. Absorption is almost as good as intravenous. So you can give once a month, you can still give subcutaneously, and you are using almost the same dose as intravenous. And this way you can avoid the systemic effect of the subcutaneous also. So it becomes the most desirable one. As you can see, the trough levels are pretty similar. So as far as immunoglobulin preparation in COVID, if you look at the current immunoglobulin which we give to our patients with primary immunodeficiency, there are cross-reactive antibodies against SARS-2 or coronavirus 19, but those antibodies are all non-neutralizing antibodies, so they don't do any good, but they are hyperimmune immunoglobulin preparation, which are currently in process, and some of them have been prepared and under clinical trials. So immunoglobulin has been a mainstay for the treatment of primary antibody deficiency replacement and can ameliorate or prevent bacterial infection. And of course, the number of indication for immunoglobulin replacement therapy in a non-primary immunodeficiency conditions continue to expand. There are a number of routes that we have discussed, and we know their side effects. So one should take advantage and always consult with your patient. Give the patient the choices, which route they would like to go for. In some cases, you do not have the choices. If their veins are bad, you have to switch them to subcutaneous. And then in subcutaneous, you can give the choice whether they want a weekly one or once a month with an enzyme facilitated one. Something you should remember, if you have a patient who is complaining of abdominal pain and you're thinking of H. pylori, don't do the antibody test, because normal people have the antibodies to H. pylori, so you will get the false positive H. pylori. Same way the toxoplasma antibody. So remember, all these will give you a false positive result. So be careful and not to make the diagnosis cytologically while a patient is on immunoglobulin replacement therapy. So I think I'll finish here. because it's about time for me to go to the airport. Thank you very much.
So if there are any, Dr. Archana, over to Dr. Archana.
Okay.
Dr. Archana, you have to unmute. Yeah, fine.
For this wonderful talk, it was very simple and everyone could understand it very well. We have 7 questions in the chat box.
I don't have time because otherwise I'll miss. But I don't know if when I reach Delhi, if I can answer them some way, although you can email me. It's simple email, sgupta@uci Upper Charlie India.edu, like education.
I'll put it here.
So if you can put that, you can send me, I'll email you the responses.
At UCI.
Okay, thank you so much for this absolutely lucid talk and wish you all the best for your journey.
Thank you.
So we would like to thank Dr. Gupta for making the effort to come all the way from US to India for this lecture and as well as to attend this meeting. It's been a great, Dr. Gupta, thanks from the whole society to you. And we'll see you.
Thank you very much.
Okay, bye.
Bye-bye.
So Dr. Archana, we can have the next speaker.
The next talk for this session
is about
bone marrow transplantation in PID, and this talk is by Dr. Revati Raj, the pediatric hemato-oncologist at Apollo Chennai. And she's really best known for her BMT program for PIDs. And really, she has more than 100 transplants on children with PID. So, Dr. Revati, you're welcome to present your slides. And I can see your slides already there. So please go ahead.
Yeah. Thank you to Dr. Amita and Dr. Sudhir Gupta and to you, Dr. Archana, and to the society for this opportunity. I think I'm the only person standing between the PG quiz and all of the lectures that have happened so far. So I wouldn't try to take too much time. Over the next 10 to 12 minutes, I have to try and tell you all what I have done over the last 20 years. So in a very condensed manner. So I'm going to try and keep it as simple as possible. We've heard about how to diagnose primary immune deficiency disorders, how to recognize them, how to manage them. And the definitive option of treatment for most of these disorders is transplantation. So just for the postgraduates in the group, just want to introduce you to stem cells. We have embryonic stem cells in our body, which comes from the fusion of the egg and sperm, and they are called totipotential stem cells, which can give rise to all cells of our body. Whereas each individual part of our body has adult stem cell, and the hematopoietic stem cell is actually one of these adult stem cells. So the cardiac stem cell gives rise to different parts of the heart, the nerve stem cell to different parts of the brain, and the hematopoietic stem cell, it sits in a nice spongy marrow where all the cytokines are being secreted. And the stem cell we characterized using an antigen called CD34, and it sits in little stem cell niches in the marrow and produces red cells, white cells, and platelets on a daily basis. Taking these cells from one person to another is now what we call hematopoietic stem cell transplantation. It used to be called BMT, but now we call it blood and marrow transplantation, not bone marrow transplantation. So these are some of the new terminologies. Just want to say that those of you who attend Hindu marriages, you know that you take 7 steps around the fire. So just to simplify what we do in a transplant, I will just talk to you about the Saptapadi, the 7 steps to doing hematopoietic stem cell transplantation. So you need a patient, you need a donor, you need to prepare the child to receive the new stem cells. These stem cells have to be infused into the child. And once they are infused into the child, they don't start functioning immediately. There is about a 2-week gap where the old stem cells we have removed during conditioning and the new stem cells have not yet started functioning. So the time when they start functioning is called engraftment, and the child needs to be supported till engraftment. Once the new stem cells have got engrafted, they shouldn't get rejected or they shouldn't cause graft versus host disease. Namely, the marriage shouldn't end up in a divorce. And we need to have long-term follow-up. And the couple need to remain as lifelong friends. So these are the steps, and I will go through each of them with relevance to primary immune deficiency. So the first step is to identify the patient. And we've heard through all the lectures so far that early referral makes a difference. Once a child is referred to us for transplantation, they are usually riddled with infections, they are malnourished, so we have to optimize their nutrition, stabilize them from infection. Very often we get children like this on the ventilator when it's too late for us to do anything. Whereas if they are recognized early in the newborn period, then transplantation is much, much easier, and they become a beautiful butterfly from a little wriggly caterpillar. So it makes a big difference. So you have very good outcomes in primary immune deficiency. This is one of the infants we had transplanted, who's now a 7-year-old boy going to leading a normal life, and should be able to go to school once the corona period settles. So there are lots of barriers. So our aim is to address all the young physicians. What are the barriers to referral? Most of the children we get are not referred early. Few are, now that the awareness is growing because of conferences such as this, because we think family won't be able to afford, that it's a genetic disorder, it's incurable, there are no brothers and sisters, so transplant is not feasible. It's usually adult physicians who do transplants, and they are scared of infants. So there are a lot of barriers which we hope will be working on to improve more and more patient selection. Next, patient has been referred and we need a donor. This is very, very important. The basis of donor selection is something called HLA typing. HLA is our passport and visa. Every cell in our body carries human leukocyte antigen, which is present on chromosome 6. And this tells us, this is me, this is you. Me, I will accept, you, I will not accept. And this is our body's immune system way of recognizing self from foreign. And it's really, really important. The two cells which are non-nucleated in our body are red cells and platelets. That's why we are able to transfuse them without HLA typing. All other organ transplantation will need HLA typing. We have class 1 and class 2 antigens, which are A, B, C, DRB1 and DQB1. So 5 antigens we get from our mother and 5 antigens we get from our father. These combinations can be varied, and the chance that me and my brother will be matched is only 30%. So we have 10 children that need a transplant, only 3 out of 10 will have a fully matched donor. And nowadays, with the family sizes growing smaller and smaller, it's very difficult to get a family donor. So the better the match, the better the outcome. But we are not living in an ideal world. So there is no sibling donor. What do? We have a huge host of unrelated donor registries worldwide. People like you and I who have registered, we've done our buccal swab, and we've kept the HLA typing on a computer database. So if our child needs a transplant donor, we enter the HLA on the system, and we find that they have an unrelated donor in Germany or in Canada, and those stem cells are brought here for the child's treatment. And this is one message from today. All you young people, try and register yourself as an unrelated donor. You may be the person who's giving a child the chance of a cure from any disorder, blood disorder that they may be suffering from. So cord registries, also unrelated cord registries, also helped us as an immediate source of stem cells. So this is a child who received an unrelated transplant for viscotalrich, and the other little girl an unrelated cord from Belgium, and they both doing very well. So you have a matched family donor, you have matched unrelated either adult donor or a cord blood donor. So another 30% we can cover using matched unrelated donor. And the HLA is very diverse, so not all of us get a matched donor. What do we do with the rest 40%? And they need an immediate transplant and they don't have a donor. So this is where basic science knowledge has advanced so much that it has helped us. We are now into an era which is called haploidentical transplantation. We know that the T lymphocytes are the master of the orchestra in our body to help the immune system tell us what to do tell each cell what to do. And the T lymphocytes, some of them carry alpha beta receptors and some of them carry gamma delta. Alpha beta are the ones that recognize self from foreign, and gamma delta help you fight infections. We now have systems like this called the Clinimax system. Once we've collected the stem cells, even from a half-match donor, we are able to clean the stem cells, remove the alpha beta T lymphocytes, which can help recognize a foreign host. And this is called CD34 selection, stem cell selection, or TCR alpha beta depletion. So we are now able to transplant patients from a half-match donor successfully, and technology has advanced so beautifully that we can get a clean bag of stem cells without the lymphocytes. But this technology is expensive. What do? Again, revolutionary basic science has helped the world of transplant. This is called post-transplant cyclophosphamide. And this was work done in Johns Hopkins University in the US. How a simple drug, a very, very humble drug like cyclophosphamide, it doesn't cost much. So what they have discovered using mouse models is once you've given the stem cells, they get into the patient's body and the T lymphocytes start proliferating. They grow very, very fast. And at the 72nd hour, the T lymphocytes that recognize the recipient as being foreign are maximal in number. So at that point, if you introduce cyclophosphamide, then only the T lymphocytes that cause rejection of the host are destroyed. The stem cells are not touched by this chemotherapy, and this post-transplant cyclophosphamide has enabled us to even use half-match family donors successfully in transplant. And this is a child with Wiskott-Holdridge syndrome whom we transplanted about 5 years ago using this PTCY technique, which has made transplant accessible to developing countries such as ours. So we have a patient whom we've stabilized. We have a donor, which could be a family donor, an unrelated donor, or a half-match donor. Then we have to prepare the child for transplantation. This is called conditioning. Now, this is where the meat of the transplant decision happens, because you already know that these are tiny children sometimes who have comorbidity, like in the form of infections. They're not very healthy babies. And if we have to give them chemotherapy to destroy their stem cells, to destroy their lymphocytes, then they don't cope with it very well. So this chemotherapy that we use for other kinds of transplant is called myeloablative, very heavy doses. Whereas in primary immune deficiency, usually we use something called reduced intensity conditioning. The conditioning has two components: one, to remove lymphocytes from the host so that the new cells are not rejected, and the other one is to remove the stem cells. So there's usually a combination of drugs like busulfan, triosulfan, etc. For those who have seen the movie called The Sky is Pink, know that these are the drugs in growing children that can cause late side effects. So we have to use them really, really carefully. So we call them RIC and MAC, reduced intensity or myeloablative conditioning. And clearly studies have shown a reduced intensity conditioning outcomes are better in most primary immune deficiency disorders compared to myeloablative conditioning, especially in conditions like severe combined immune deficiency. So we have a combination of drugs that we use: fludarabine, triosulfan, busulfan, ATG, depending on what is the underlying condition. Next, we need the stem cells. So we need to give the new stem cells, and the source of these stem cells can come from bone marrow, from peripheral blood, and from umbilical cord. Now, what we need to know is that we need a tiny amount of donors' lymphocytes, because they help carry the stem cells into that of the patient's body and help in the stem cells to settle in the new environment. If we totally remove the lymphocytes, then the chance of the new graft getting rejected is high. So if you look at this cartoon, you will see that bone marrow has an ideal balance of stem cells and lymphocytes. Peripheral blood stem cells have the blue color stem cells and the pink color lymphocytes, huge amounts of lymphocytes. Cord blood has 1 log lower stem cells and 1 log lower lymphocytes. So Here we know that bone marrow is ideal and peripheral blood stem cells, because the number of lymphocytes are very high, graft versus host disease rates are high because the new donor cells can recognize the child as being foreign and cause problems. And in cord blood, the rejection rate can be high because the number of lymphocytes are very few. So bone marrow, we do harvest from the donor in operation theater, and peripheral blood, we give 4 days of GCSF injection. Some of the stem cells come into the blood and that is collected using an apheresis procedure. Cord blood is usually collected after the baby's cord is cut and the cord is cannulated and it's stored. And any of these stem cells will do, but when you infuse, they're infused into a central line, just like a unit of blood. So this is the easiest part. So the day of the operation, as you call it, is the simplest day. But now comes the fun and games, because we have removed all of the child's immune system. Their white count is 0, and we have to protect them from infections. So this is our transplant unit where we have HEPA filter room, we have strict barrier nursing. It's a big challenge to look after children with no immune system. They need nutritional support, they need antibiotics, antifungal, and bugs, as you know, have been there for millions of years before us. So we have to be smarter than the bugs to get them through the 2 weeks of 0 white count. And with increasing drug resistance, we have to adapt and have systems in place with our infection control to beat the 2 weeks of immune system being 0. Supportive care is vital for a transplant unit. We have to train our nurses so that we can work as a team. Once the new stem cells have started functioning, which is called engraftment, the new stem cell shouldn't get rejected and the stem cell shouldn't reject the child, which is called graft versus host disease. So we keep the child on immunosuppression for at least 6 months to a year, and we use cyclosporin or tacrolimus, and we have to balance it carefully because already these are immune deficient hosts. The beauty of bone marrow transplant is that we have only about 6 months to 1 year of immunosuppression compared to solid organ transplants where they continue immunosuppression for the rest of their lives. You don't want rejection where you will end up with a dry marrow. You don't want graft versus host disease, which causes a tsunami in the child. So we just need to get the graft in smoothly. Once we've got them through the difficult 1 year period, we have given chemotherapy to small children and we have to follow them up lifelong. This is important. We need to make sure that they have donor cells. We check their blood, that all the cells belong to that of the donor. We vaccinate them, see them through puberty and their fertility. So long-term follow-up and see how their immune system reconstitutes. It's amazing. A child who was scrawny and who was failing to thrive, they come back smiling, putting on weight. We still have to worry about late deaths due to infections like tuberculosis and CMV. This is our data in our unit, which we've published in Indian Pediatrics. The overall survival is 71%. So to all the pediatricians out there, it is worth referring a child for a transplant, because conditions which have 100% mortality, 70% of them, we can save their lives. And this is a recent multi-center data from our country. You can see that whether it's a matched family donor or an unrelated donor, we are doing well. We are able to cure at least 60 to 70% of the children. And this graph on the right tells us about our learning curve. Before 2016, our outcomes were only in the range of 10 to 15%. But after 2016, they have come up dramatically. So advances and conferences such as this highlight our experience, and we get more confident in dealing with these children. So the one thing we need now have realized is molecular diagnosis is important. Just the term SCID is not enough. What is their actual molecular diagnosis? So this was one baby whom we transplanted in 2005 without knowing the molecular diagnosis. He got busulfan. He had one of those DNA repair defects, and 5 years post-transplant had fibroelastosis of the lung and passed away. So it's important to plan treatment based on the molecular diagnosis. and we need to stabilize, work together, and not to make decisions for the family to say that they're too poor, they can't afford the transplant. Give them the option, give them the idea. And as Dr. Sagar said earlier, if you can't stabilize them, at least store their an EDTA sample so that we can extract DNA and help them for prenatal and prevent new births. That is the most important thing, because the suffering is too great for the family. The future is bright for our children. One of the methods where you can cure immune deficiency is gene therapy. And what do we do in gene therapy? Take the child's stem cells and add the missing gene to the stem cells in the lab. And that, after giving chemotherapy to the child, we give them their own stem cells with the additional genes. And this is a type of transplant, autologous transplant, but you don't have the problem of graft rejection or graft versus host disease. So hopefully you are the people in the future that would be doing gene therapy for all the blood disorders. And so the future is bright. So it's good to know and good to be in the field right now. We have been very happy these last couple of hours to take you through this journey of introducing you to the world of primary immune deficiency. A lot of people have helped me in my work, our nursing team, our patient families, and all the physicians with whom I work. So the main message from me is build up a team, recognize your children early and refer them early so that you can give them the promise of cure. Thank you.
Thank you, Dr. Revati, for making this talk so simple. It is a very complex thing. Bone and the blood and marrow transplantation, you really made it very simple. And your slides were beautiful. Thank you for your wonderful lecture. And as far as I know, I don't know, there are 3 chats in the chat box. Not really.
Not really.
No. So thank you, Dr. Revati, for your wonderful talk. And I hand back the thing to Dr. Amita Agarwal.
Thanks, Dr. Archana and Dr. Revati, and Dr. Gupta has left us. So it's been great. And the whole meeting for 1.5 days has been really very, very illustrative and educative for, I think, all our postgraduates, and including me. I'm always learning. So we have now the last part of it, which is the quiz, which Dr. Vignesh is going to do. So I just wanted to ask Dr. Vignesh, Dr. Vignesh, you're going to use the same portal, or you're going to have they have to log in somewhere else?
The participants have to go to the link, which I put in the chat box now.
Okay, so I will just announce the results of the things we had. So the case presentation which we had yesterday, the first prize for that goes to Dr. Hasina Said. She's from SGPGI Department of Medical Genetics. She presented a case of monogenic lupus, complex riddles solved by clinical cues and radiograph. The second prize is joint second. This is Dr. Umair, who presented on a patient with PLCG2 novel mutation, and Dr. Prerna Modani from KEM Hospital, who presented a case of ALPS. So those two shared the second prize. So this was judged by Dr. Anju Gupta and Dr. Amreen from Wadia Children's Hospital. Regarding the free papers, the first prize goes to Dr. Harika, who presented hematopoietic stem cell transplant in neutrophil disorders from Apollo Chennai. And the second prize goes to Dr. Ritika from NIIH Mumbai, who presented the utility of HLA-DR evaluation while screening for inborn error of immunity. Regarding the posters, the first prize goes to, which was judged by Dr. Sudhir Gupta, the first prize goes to Dr. Jaya Arundhati, who presented the ecological spectrum of very early onset IBD from SGPGI Department of Pediatric Gastroenterology. And the second prize goes to Dr. Lakshmi from CMC Vellore, who presented 2 cases of 2 different primary immunodeficiencies in one family. So these are the award winners. Congratulations to all of you. But I think all the participants did a great job. So don't worry if you got the prize or not. It is that all of us are learning and we all learn from you. So now over to Vignesh, and we have prizes for the quiz also. So participate in full go and you will get more prizes.
Thank you, ma'am. Shall I start?
You can start.
Okay.
So is my screen visible now?
Just double click on that. Yes, now it's visible.
So a very good evening to one and all, and I thank the organizers for having given me this opportunity. So this is going to be the last session of this conference, and would be a little exciting. As a postgraduate, when I did my post-graduation, I will be really excited with the quiz. So I thought this would be a very good learning exercise for the postgraduate. And I thank the organizers for having given me this opportunity to conduct the quiz in this PID conference. So just quickly going through the rules, how to play this quiz. So you have 40 questions and 30 seconds to answer each question. So the question format will be like this. So you have a question and you have 4 options and you have 30 seconds to select the right option. So the option you have to select in the link that is provided. Please don't write the options in the Zoom chat box or in the chat box. So this is how it goes. So you get 30 seconds. So the question is, what is the present number of COVID-19 cases in the world? You can select out of any one of these 4 options and you vote in the link that is provided. So you can play it in your laptop or phone. So this is how it looks. When you click the link, you have the options like this. Don't write anything in the chat box. You just tap on the correct answer. And once 30 seconds is over, the screen automatically moves to the next question. Okay, so total of 14 multiple choice questions, no negative marking, and the quiz will have no tie. How faster you answer and how correct answer, how much correct answers you give. So that's how the results are decided. So all questions have same points and top 2 winners will be declared at the end of the quiz. Okay. Thank you. So now I request Shweta to share the slides that has the questions. Ms. Shweta?
Shweta, just double click on your, yeah.
Okay. So now we move to the quiz. Shweta, is everything ready? Yes. So this is the first question. Disseminated BCGiosis is not a feature of A gamma globulinemia, B, severe combined immunodeficiency, C, chronic granulomatous disease, and D, Mendelian susceptibility to mycobacterial disease. This is the second question. Which of the following represents a natural killer cell? CD19 positive lymphocyte, CD3 positive lymphocyte, CD56 positive lymphocyte, or CD14 positive cell? So this is the third question. Autosomal dominant form of hyper IgE syndrome is caused by mutation in which gene? A, STAT1, B, STAT2, C, STAT3, and D, STAT4. Number 4, which of the following statements regarding single nucleotide substitution is not true? A, it can affect splicing. B, are usually pathogenic. C, it affects the gene expression. D, it may result in termination codon. This is the question from Dr. Vinod Sakaria's talk. T-cell receptor excision circles are measured to screen which disorder? A. X-linked agammaglobulinemia. B. Chronic granulomatous disease. C. Common variable immunodeficiency. And D. Severe combined immunodeficiency. Number 6, which of the following hyper IgM syndrome has X-linked inheritance? A. CD40 ligand deficiency. B. CD40 deficiency. C. AID deficiency. And D. UNG deficiency. Number 7, which of the following represents a cytotoxic T cell? CD8 positive T cell, CD45 O positive T cell, CD5 RA positive T cell, or CD4 positive T cell? Number 8, which of the following genetic analysis methods cannot accurately detect the copy number variation? A. Sanger sequencing. B. Fluorescence in situ hybridization. C. Multiplex ligation dependent amplification. And D. Chromosomal microarray. Question number 9, targeted next generation sequencing is not an ideal method for detection of NCF1 gene GT deletion because A. Deletion is located in deep intronic region, not typically covered by targeted gene panels. B. Deletion is located in 5' UTR. C. Deletion is located in region within repetitive sequences. Or D. Due to the presence of pseudogenes. So this is question from Dr. Amit Rawat's talk. Number 10, which of the following is not true of flow cytometry based assay for diagnosis of PID? A, flow cytometry may be used for assessment of protein expression. B, flow cytometry is a useful test for diagnosis of X-linked carrier females. Presence of protein expression on flow cytometry rules out a PID. And D, absent B cells on flow cytometry is a hallmark of XLA. Question number 11. All of the following cause severe common immunodeficiency due to impaired DNA repair, except number A, Artemis defect, number B, IL-7RA defect, C, DNA ligase 4 defect, and option D, Seronos defect. Question 12. Classic immunoglobulin profile in Wiskott-Aldrich syndrome is A, low IgM, high IgA, high IgE. B, low IgM, low IgA, high IgE. C, low IgG, low IgM, low IgA. D, low IgA, low IgG, and high IgM. Question 13. Which of the following statement is true for X-linked hyper IgM syndrome? A, IgG and IgA levels in the blood are low while IgM levels are high. B, T cells are not capable of engaging CD40 on B cells. C, lymphoid tissues lack germinal centers. And option D, all of the above. Deficiency of adenosine deaminase type 2 is due to mutation in which gene? A, CCR1, B, CCER1, C, CECR2, option D, ADA1. So this is a 5-month-old female child who presented with disseminated BCGiosis, recurrent diarrhea, and failure to thrive. So you have the flow cytometry reports there. You could see the T, B, and NK percentages and proportions. Which of the following genetic defect is more likely in this child? A, IL2RG, B, DCLRE1C, C, NHTJ1, and option D, JAK3. Question number 16. Cytokines primarily involved in T cell proliferation and development are option A, IL-2 and IL-7, option B, IL-12 and interferon gamma, option C, IL-4 and IL-5, and option D, TGF-beta and IL-10. Question 17. Which of the following is not true about chronic granulomatous disease? Option A, it is a defect in generating microbicidal oxygen metabolites. Option B, increased susceptibility to BCG-induced infection. C, serum galactomannan is usually raised in fungal pneumonia. And option D, corticosteroids can be used in the management of liver abscess. Question 18. Which of the following statement regarding X-linked agammaglobulinemia is wrong? A, refractory skin ulcers due to Helicobacter species can be seen. Option B, susceptibility to enteroviral meningoencephalitis. Option C, lymphoid hyperplasia is usually seen. Option D, neutropenia can occur. Question 19. All of the following are associated with chronic granulomatous disease except A, colitis, B, hemophagocytic lymphohistiocytosis, option C, hypogammaglobulinemia, option D, obstruction. Question 20. Whole exome sequencing approximately covers how much of the human genome? A, 1 to 2%, B, 10 to 20, C, 40 to 50%, and option D, 60 to 80%. Question 21. Steroids can be used in following conditions in chronic granulomatous disease. A, CGD-associated colitis, B, staphylococcal liver abscess, C, mulch pneumonitis, and option D, all of the above. Question 22. Rapamycin or sirolimus is used as treatment for lymphoproliferation and autoimmune manifestations of which of the following PIDs? Option A, activated PI3 kinase delta syndrome. Option B, deficiency of adenosine deaminase 2. Option C, interferon gamma receptor 1 defect. And option D, IRAK4 deficiency. Question 23. Which type of leukocyte adhesion deficiency syndrome is inherited in autosomal dominant mode of inheritance? A, type 1 LAD, B, type 3 LAD, C, RAC2 deficiency, and option D, E-selectin deficiency. Question 24. Which of the following statement is true of autoimmune lymphoproliferative syndrome? A, germline mutation in CASP16, B, plasma soluble fast ligand levels more than 200 picogram per ml, C, reduced CD3 double negative T cells, and D, lymphoid hyperplasia. Question 25. Which of the following is not a disorder of immune regulation that is associated with autoimmunity or lymphoproliferation? Option A, autoimmune lymphoproliferative syndrome. Option B, IPEX syndrome. C, CTLA4 deficiency. And option D, Bruton's A gamma globulinemia. Question 26. This is a 2-year-old boy who presented with multifocal osteomyelitis due to Mycobacterium bovis. He had normal lymphocyte subsets and normal nitroglycerin test. So this is the flow cytometry plot. In the left is the normal control and the right is of the patient. He had decreased expression of CD119. What is the likely diagnosis? Question 27. Which one of the following defects is not optimally identified by whole exome sequencing? A, splice site mutation. B, large duplication. C, point mutation. Option D, frame shift mutation. Again, a question from Dr. Vinod Sakaria's talk. Which of the following genetic defect in SCID has a higher sensitivity for ionizing radiation and alkylating agents? Option A. Question 29. Which one of the following strategies is not considered appropriate for T lymphocyte depletion in graft in order to reduce the risk of GVHD? Option A, post-transplant cyclophosphamide. Option B, CD3 positive 45 RA positive depletion. Option C, CD3 gamma delta and CD19 depletion. Option D, CD3 TCR alpha beta CD19 depletion. Question 30. All of the following statements regarding chronic autoimmune neutropenia of infancy are true, except option A, it usually runs a benign course. Option B, neutropenia is incidentally detected in most of the cases. Option C, many children will have autoantibodies directed against surface antigens of neutrophils. And option D, many patients require GCS therapy. Final 10 questions. Question 31. Which of the following autoinflammatory syndrome can manifest with interstitial lung disease? A, Aicardi-Goutieres syndrome. B, sting-associated vasculopathy of infancy. Option C, ADA deficiency. Option D, Nemo-deleted exon 5 autoinflammatory syndrome. This is the question from Dr. Rafila's talk yesterday. Question 32. Which of the following statements related to A20 haploinsufficiency is not true? Option A, it occurs due to homozygous gain of function in TNF AIP3. B, increased NF-kappa B signaling. C, recurrent painful oral, genital, and or gastrointestinal ulcers are the hallmark features. Option D, can present with features of early onset SLE. Question 33, identify the autoinflammatory disease. So this is a child who has some papular rash over the trunk and abdomen, boggy synovial swelling and choroid tubercles and some finger deformities. Option A, NOMID. Option B, FMF. Option C, TRAPS. Option D, Blau syndrome. Question 34. Early onset HLH due to the following defect will have associated colitis, normal NK cell degranulation, and highly elevated IL-18 levels. Option A, Chidiac-Higashi syndrome. Option B, perforin defect. Option C, NLRC4 gain of function. Option D, CD27 defect. Question 35. Severe COVID-19 is associated with which of the following? Option A, autosomal recessive IRF7 defect. Option B, autosomal recessive IFN-AR1 defect. Option C, autosomal dominant TLR3 defect. And option D, all of the above. Question 36. Development of autoantibodies against which of the following cytokines is associated with severe COVID-19? Option A, IFN alpha 2 and IFN omega. Option B, IFN beta and IFN gamma. Option C, TNF alpha and INF beta. Option D, IL-17 and IFN alpha 2. Question 37. Which one of the following is not a component of innate immunity? Option A, follicular dendritic cell. Option B, phagocytes. Option C, plasmacytoid dendritic cell. And option D, natural killer cell. Last three questions. Question 38. Which of the following defect results in autoimmune lymphoproliferation, predisposition to herpes virus infection, and hypogammaglobulinemia? Option A, defect in Fas ligand. Option B, caspase-10 deficiency. Option C, defect in Fas. And option D, caspase-8 deficiency. Question 39. Which of the following defect is not a CD27 deficiency? Option C, MYD88 defect. And option D, CARD9 defect. Okay, it didn't come up, but it's okay. So we'll be having the results in 5 minutes time. And I can send the correct answers.
The question didn't come up. Vignesh, the 40th question didn't come up.
Yeah, probably I think they have missed up.
Yeah, we can leave it there.
Yeah. So I can mail the correct answers and the questions to all the participants. I can send the PDF of the questions.
Yes.
So Shweta, are we ready with the results? Okay, so we are ready with the results, I think. Okay, we have many senior people have participated in this quiz, so I'm not going to take them into consideration for the results. Is that okay, ma'am?
Yeah, that's perfectly. Everybody wanted to participate, let them participate and know their scores, and then you keep the students.
Okay, so actually it is Dr. Amit Rawat and Dr. Amita Agarwal came first and second position in this quiz. But
we just wanted to do it for our own sake. That's all, to enjoy.
But amongst the PGs and fellows, it's Dr. Sundaram, TG, has scored with 77.5%. And second is Dr. Vaishnavi Iyengar, who has a 70%. She has the similar score. I think they can be given joint first prize.
Yes, joint first prize.
And you want me to announce second prize also, ma'am?
One more, yeah.
Yeah, so it is Dr. Sukhdev Manna. He has scored 75%.
Great. Him I know. He's from AIMS Rishikesh, if I remember correctly. Sukhdev Manna.
Okay. So Dr.
I don't know
Sundaram
the
and
rest two. Rest two, do you have the place from where they are? Can you, if you can identify them?
I cannot see the place they come from. Dr. Vaishnavi Iyengar is from Apollo Chennai, I guess.
Yes, I think so. So can you put in the chat box, the person who is one, can you put your designation or place from where you are? You can put it in the chat box. It'll be good to identify. If you're still, you should be still there.
So
So
Dr.
Vaishnavi
Sundaram.
is from Vadia Children's Hospital. Vaishnavi Iyengar. And who was the second person you said? Dr. Vignesh?
Dr. Sundaram and Dr. Vaishnavi. The first
Sundaram.
prize.
Sundaram is, what is his second name? Sundaram, just Sundaram?
Sundaram TG.
Sundaram PG. Sundaram TG and yeah. Sundaram TG is probably from our institution. Yes, he's our resident.
Okay. Good.
I thought there may be other Sundarams. So we know. So Vaishnavi is from Vadia Children's Hospital and Sundaram is from SGPGI Department of Clinical Immunology. So they are joined first. And Dr. Sukhdev Manna, who's from AIMS Rishikesh, he's also doing DM in clinical immunology and rheumatology. So Amit Rawat is writing that we should also get some prizes. Amit, I will send you some prize. So thanks a lot to all of you for joining and being there till the end. And I think the meeting is a success if we have good participation. And I think we had wonderful participation from all of you. Yesterday we had nearly 140 people, and today also in the sessions in the morning we had around 130 to 140. Finally. So if any of the audience wants to say something, you can unmute yourself. I'll just ask, they will allow you to unmute. Or if any of the other participants want to say anything. Dr. Biman, you want to say something? You are the president of the society. So everybody who want one by one, if you want to say something, you're most welcome, because now everybody can unmute themselves. So Dr. Biman, we want you to say a few words as the president
Dr.
of the
Amita, can you hear me?
Yes, we can.
Yes, I think that was a wonderful conference, and we had it for the first time on the online format, but this was absolutely wonderful. The lectures were wonderful. I think your team, the entire team has done a wonderful job, and congratulations. Thank you so much. Thank you. Thank you so much.
So we will be sending out the certificates to all of you, as well as the receipts of the registration fee and for the prizes. I'm just thinking what would be the best prize for the students. So is it a book? Is it something else?
The last time, ma'am, the last time when we did the conference, we did the webinar, we provided the STEAM PID book to the winners.
Yeah, so we are just thinking, let's see how much we can do and what would be the best prize for the students. At least we'll send the certificates first and then we will.
Libido now.
Okay.
Dr. Amita, wonderful conference. Really enjoyed. The quiz was
Thank you.
fantastic.
Everybody helped out. That's why it happened. It's all your effort. I haven't done anything. I have just put people together. That's all I have done.
Madam, wonderful conference. This is Partho from Kolkata.
Okay, thank you. So we've had great time, and I think everybody is getting late. It's already 5:25. So thanks a lot, and bye-bye to all of you. Enjoy yourself. Have a great evening.
Thank you so much.